Good afternoon. Welcome to the Senate Finance Committee. Today is Tuesday, February 14th. We are going to hear 12 bills today. I can't give you a bill order because a number of the sponsors are in other committees and can't get into this committee, so it's going to be very, whatever happens, just going to happen. So you'll see, members are out testifying in other committees. Other members will be coming into this committee, and we'll just have to take them as they come in. I am going to ask, we have 114 witnesses today, so we have a 2-minute limit. So the sponsor of the bill gets as much time as they need to explain the bill, and everybody that comes up and testifies has 2 minutes. And if you don't hear the timer, I'm going to simply ask you to finish your sentence. But please listen for the timer, and there's lights on the desk when you're speaking. So I just need to ask you to respect that because it's a long day when we have over 100 witnesses. So thank you for your patience. Mr. Vice.
Good afternoon. Today we will start. Today is Tuesday, February the 24th. We're going to start with Senate Bill 515, Health Services Cost Review Commission, Health Facilities, Jurisdiction and Rate Setting. We will hear from Chair Beidel along with her panel of Patrick Carlson, welcome back to Senate Finance, as well as Andrew Nicholas. Madam Chair, whenever you're ready, you may begin. The sponsor has all the time they need, and all the rest of the panelists will be restricted to 2 minutes.
Okay, sure. Hi. Good afternoon, Mr. Vice Chair and members of the Finance Committee. Senate Bill 515 is a Health Services Cost Review Commission, Health Facilities, Jurisdiction and Rate Bill. Senate Bill 515 requires the Commission to consider all costs incurred as expenditures made by a health facility in connection with the operation of the facility and generally relating to health facility rate setting. As you know, I think you all know, the HSCRC sets the rates in Maryland for hospitals. It is becoming increasingly expensive for Maryland hospitals to maintain essential physician coverage. Physicians are critical to the ability of the hospitals to provide life-saving, acute care, and other health care services that communities rely on. Given this, the high and increasing cost of employing or contracting with physicians and the corresponding financial losses are unavoidable since hospitals require sufficient medical staff to perform the basic functions of providing daily life-saving care to patients. The current global budget and rate structure does not include a funding mechanism that enables hospitals to recover expenditures for physician services that are not fully reimbursed by the payers. These losses are not sustainable, especially as the state and its providers transition to the AHEAD model. Without relief, hospitals will face financial instability and resource constraints that threaten their ability to sustain core operations and preserve access to care in every community. I respectfully request a favorable report on Senate Bill 515. Thank you.
All right. Thank you so much, Madam Chair. Good afternoon, Mr. Vice Chair, members of the committee. For the record, my name is Andrew Nicholas. I'm here representing the Maryland Hospital Association in strong support for Senate Bill 515, and many, many thanks to Madam Chair for sponsoring this important piece of legislation. So this committee is very familiar with the fact that the Health Services Cost Review Commission, HSCRC, reviews and approves hospital reimbursement rates. The HSCRC does not set reimbursement rates for physicians, and this bill does not change that. But it's important to note because according to a 2023 report from the Maryland Healthcare Commission, commercial reimbursement rates in Maryland are the second lowest in the country. Only Alabama has lower physician reimbursement rates than Maryland. So because of these low reimbursement rates, it's very challenging for hospitals to attract providers to come and work in their hospitals. And this is true for essential services like radiology, anesthesiology, and your hospitalists. And it also extends to some specialty providers like gastroenterologists and neurologists, where often in communities, the hospital-based physician is the only access point for those physicians in the community. So in order to ensure adequate physician coverage, hospitals are in a position of needing to provide payment beyond what is reimbursed for these services in order to get physicians in their hospitals. And so these circumstances are costing Maryland hospitals millions of dollars. They're unavoidable, and under current practice, there's no mechanism for hospitals to make up that difference. And that's because right now, HSCRC has received advice from counsel that there's a statutory provision to them that they lack statutory authority to include those costs in hospital rates. And so that's what SB 515 does, is clarifies that the costs hospitals incur associated with ensuring adequate physician coverage can and should be considered in the rate setting process. It does not give the HSCRC authority to set physician rates, and it does not require the HSCRC to reimburse hospitals at a specific rate or under any specific methodology. It is simply enabling and clarifying that they have the authority to consider these costs when setting hospital rates.
Well, Chair Beidle, Vice Chair Hayes, members of the Senate Finance Committee, thanks for having me today. Patrick Carlson, Vice President of Care Transformation and Finance at the Maryland Hospital Association. And as Andrew shared, Senate Bill 515 would ensure that the HSCRC is able to implement a policy solution to address the difficult challenge of hospitals experiencing high and rising physician costs and resulting operating losses due to insufficient reimbursement. By having HSCRC take these costs into account when carrying out its global budget and rate-setting authority, HSCRC would be able to develop and implement a targeted policy solution to address specific challenges hospitals are facing. With authority, HSCRC could fashion a policy to address defined objectives with eligibility criteria, as it does with other policies through a process that includes study and stakeholder input. A tailored HSCRC policy could address challenges in supporting select physician services that are essential to acute care delivery, ones with high and escalating costs and low reimbursement that are producing unsustainable losses and are needed to achieve key mission-critical objectives, such as preserving or expanding access to hospital care locally, supporting throughput, and reducing emergency department lengths of stay. To support access to essential hospital care, policy could focus on key specialties that are presenting escalating cost challenges, such as anesthesiology and emergency department physicians. And HSCRC regularly designs and implements targeted policy solutions. It recently did this to provide funding for hospitals with unforeseen cost pressures, and it stood up a policy to address respiratory surges. A targeted policy to address specific physician cost challenges would occur through its normal policy-making process with a staff recommendation, followed by review and approval of HSCRC commissioners. So with that, I'll turn to Tom Kleinhansel, who served as the president and CEO of Frederick Health and can speak to the experience of his hospital.
Yeah, thank you. Madam Chair, I'm delighted you're sponsoring this bill. There was no more important issue when I retired 6 months ago than this issue in my organization. I ran Frederick Health for 21 years, and if there was one major change in my career towards the last 10, it was the splitting of the medical staff of those that wanted to stay in the outpatient setting versus those that wanted to be in the inpatient setting and be subsidized. And we've seen that grow dramatically in the organization I ran. Just 4 years ago, we spent about $15 million on this issue. We're now spending about 30. It's more than almost doubled, more than doubled, and it's not getting any easier. The workforce issues among physicians are real. You cannot run a hospital without the specialists and the coverage that we need. I've watched this waiver get updated 3 times in my career in Maryland, and this is the first time that somebody has stepped back and said what needs to change at the state statute in order to be contemporary with how hospitals are run and the costs that they incur. So thank you for that. I'm pleased you're looking at it. This loss statewide is about $890 million last year of subsidies that hospitals are investing to make sure there's access to care in their organizations. I've seen it across the board, OB, GYNs, ED doctors, radiologists, anesthesia, gastroenterology, pulmonology, I can go on, but all those have been touched in the organization I just left that need this, and I think this is a very good first step. Again, this is enabling clarification. It's a structural necessity, I think, in order to make sure that that word all that's in the definition is truly all costs in terms of running a hospital. So it's very important, I think, that this change to the actual enabling statute get done. And I am here to spend my personal time on a voluntary basis saying I'm passionate about this because I see it be such a huge issue across all community hospitals, which are struggling with this every single day. It happens very frequently that there's another specialty. When you just fix one, another one walks in and says, we've got a problem with cardiology coverage or GI coverage or whatever it is. So it's a very important bill, and I'm very happy to be here to help talk in favor of it. Thank you.
Excellent. Thank you for your testimony. Senator Lamb.
Vice Chair. So I guess a baseline question right now, with the bill as drafted, which physicians would be included? Is it just the inpatient physicians in a hospital, or would it include others that are tied to the health system?
Yeah, so excuse me, so Senator Lamb, the bill doesn't specify which physicians would be subject to a targeted policy solution. I think that would be determined through the HSCRC's normal policy-to-making process. Presumably they would identify the specialties of concern, where there really are sort of high and escalating cost pressures and losses, and also that would achieve specialties for which there are important access aims that would be achieved. So that is something that I think would be determined through the policymaking process, but it isn't spelled out in the bill. This bill enables that process to go forward.
So it's basically deferred to the HSCRC to kind of figure out which physicians would be under the umbrella, I guess.
Yeah, that's right. And the HSCRC has been standing up a survey process where they've been gathering data from hospitals through a clinician cost survey. So a lot of this work has already been underway. I think there's still more work that's happening to collect this data. But I think it would be an HSCRC staff-led process with stakeholder input, and then an ultimate decision that would be made by the HSCRC commissioners. But the idea is that we have a legal impediment that we need to clarify. And for this work to go forward, we want to remove that so that we can define a good policy and stand one up that fits within the framework of the AHEAD model and enables us to support those aims and addresses really specific acute challenges.
Right. My other question is to deal with the AHEAD model that you just kind of pointed out. And obviously, there's a lot of changes that are coming down the pike. This committee has been briefed on a lot of those revisions as well. Do you have a sense whether the changes in the rates would have a material impact on AHEAD model's savings goals, for example, with Medicare and all-payer?
Yeah, I mean, I think with any policy implemented right now, it will be within the context of whether it can be implemented and us to be able to achieve our model targets. Obviously, we have savings targets that we need to meet, total cost of care savings requirements for Medicare. And also, we're going to have a total cost of care growth target for all payers, and so we would have to have a policy that is sufficiently tailored in scope, that can be impactful and address the real needs that hospitals are confronting, but that also wouldn't introduce financial pressures that would inhibit our ability to meet our contract requirements.
Okay, so you have to kind of thread the needle there with a lot of things. On the piece of trying to figure out which physicians would be included or not, is there an expected timeline to figure out these physicians, which would be included and which not, and their costs that might be incurred, to be able to factor that into the global budgets that are determined by the HSCRC?
Yeah, so one of the reasons why the bill was drafted to have an emergency effective date is that we wanted to have the option to implement a policy solution as soon as this upcoming fiscal year, if possible. We recognize that there may need to be a policy development process that could take some time. Certainly, the HSCRC can entertain a more short-term policy initiative with a more long-term framework. But I do think that what is contemplated is that there would be, again, a stakeholder process for policy development where the key specialties of concern would be identified, and that there would be a framework for establishing regional benchmarks for cost and taking into account the reimbursement, insufficient reimbursement and losses that can be addressed through a policy.
Okay. And then last question has to deal with resident physician training and GME as a resident physician program director. And then we also had I guess we have multiple bills that the committee is considering on resident physician training. Wanted to just see if you had any thoughts on how resident physician training would be factored into these global budgets. I know it's a little bit different than in other states because we have a global budget system here that's kind of designated by HOCRC for specific funding to hospitals for resident training. Do you envision anything here would affect that or would either positively or negatively?
I think that, there is currently interest in separate policy work through the HED regulatory working group where they're going to look at GME. There's interest in making sure that there's additional funding for GME slots and training. We currently do provide funding for GME slots right now under our global budget structure. I think there's interest in standing up more funding for GME. It very well may be that process could be paired with, with a solution on physician losses. But I think right now that's envisioned as a separate and distinct, sort of policy.
Because I know just from briefings that we've had that the GME process is pretty involved here. So if any hospital wants to start a new residency program or train additional resident physicians, they have to go through like a complete rate setting again to bring before the HOCRC, which seems like a really involved process and probably one that most hospitals wouldn't want to go through with. So, okay.
Yeah, just a nuance of the GME and is important and is necessary as the GME and the training is, those hospitals get funding for that. One of the issues I think this enabling legislation does is it allows community physicians to get funding for the same coverage that teaching hospitals are getting with residents. You follow me there? So community hospitals right now are at a competitive disadvantage because they get no funding for any of the coverage of the ED or GI or any of the specialties that we're talking about, whereas teaching hospitals cover those services with residents, and they get funding for it. So right now there's a disconnect. The all cost doesn't cover all cost. It covers it for some and not others. It's just my opinion.
Right. And a lot of these community hospitals do have a tough time. I know, I have Howard County Medical Center from Hopkins in my district, and there have been challenges like getting radiology coverage, anesthesiology groups to cover it. So, I think that's probably the root of all of this, right?
That is it.
Okay, thank you.
Thank you. Are there any additional questions for this panel? Seeing none, thank you so very much. I believe
Thank
we
you, Mr. Vice
still
Chair.
are expecting some testimony from Daniel Shattuck and Ram. I will not butcher your last name, but first name Ram, R-A-M. Daniel, you're going to go first?
I'm going to let Dr. Parabamba go first.
Okay, let's let Dr. Ram go first.
Just started.
Okay. Thank you, Madam Chair, members of the committee. My name is Dr. Ram Paravemba, and I'm the current president of the Maryland Society of Anesthesiologists. I'm here to represent the MSA in support of Senate Bill 515. Stipends, as explained in the previous panel, are a necessary thing that is paid often to hospital-based physician groups in Maryland to allow these groups the ability to offer attractive compensation packages to new physicians. It is critical to understand that when we are recruiting new providers, we do so in a national market, and compensation must be competitive on that scale. Stipends are particularly necessary for hospital-based physicians, including anesthesiologists in Maryland, for several reasons. Firstly, the total cost of care model and previous iterations has encouraged the movement of elective procedures on those with largely commercial insurance to the outpatient setting. The result is hospitals often provide more care to patients with public insurance, such as Medicare and Medicaid, in addition to, of course, taking care of the under or uninsured. Since commercial payers' reimbursement is often higher than public payer reimbursement for most physicians, the net effect is a payer mix that necessitates hospital subsidies to make up this differential. In fact, in nationwide the Medicare percentage in hospitals is 18.5%. In Maryland, it's up near 30%, a substantial difference. In addition, average commercial physician reimbursement in Maryland is one of the lowest in the country, despite, of course, high practice costs and high cost of living. The dual effect of low commercial reimbursement and a higher percent of patients with public insurance in the hospitalized patient population in Maryland necessitates subsidies from hospitals. It is critical to understand that these subsidies are simply utilized to allow hospital physicians the ability to offer competitive compensation to new
Thank you
providers.
so much, Dr. Ram, for your testimony. We'll see if there's any questions, but the buzzer is not a suggestion. It's the end of your testimony. Go right ahead, Daniel.
Mr. Chair, Madam Chair, my name is Dan Shattuck. I'm here today on behalf of the Maryland Society of Anesthesiologists. You heard from our president, Dr. Peravemba, and from the previous panel, this is an important bill. It's important because it's a complex world out there. We know that. We know that the hospitals operate under a very complex system. The physicians are trying to navigate the system equally as well as the hospitals, and it's a challenge. And I think what the MSA has been doing, what I've been tasked with by my members over the last few years, is to try and figure out how do we solve the workforce problem? What are the root causes of the workforce problem? Well, there's multiple causes, but I think what this bill does is put into that perspective the importance of these hospital-based physicians, like anesthesiologists. You can't run a hospital without the anesthesia department. And I think we want to partner with the hospitals, and we've been trying to work hand in glove over these last few years to come up with solutions. And I think what's on the table today is a good first step. We look forward to continuing discussions with the HSCRC because we want to make this a workable system. And I think, we're on the right path. So with that, I'll take any questions, and thank you for bringing this bill forward.
Senator Lamb.
Thank you, Vice Chair. So I kind of brought this example up when the prior panel was up there, but with Johns Hopkins Howard County Medical Center, trying to get the name right now, that, in talking to Dr. Med, who's their CEO, that they've had challenges trying to have specialty society, especially physicians, cover essential elements of the hospital's services. So, anesthesiology and radiology. And, I guess the question to Dr. Peravemba, is the challenge here that the rates that are being set by the HSCRC, because they're not able to consider these, the compensation that's required for these physician groups, makes it very difficult for hospitals to attract physician groups in some of these really important and core specialties to the hospital's services to be able to retain them in a way that allows the OR to function or for x-rays to be read. Is that kind of the core essence of the problem here, and this bill will help address that by allowing the HSCRC to be able to take into account those provider costs as part of the rate setting that the commission does?
Yes. So basically, I think you summarized it very well. We've had cases where hospitals could not recruit any anesthesiologists, and they've been actually the rate determining step in terms of getting operating room cases done, both elective and emergency cases. So yes, and for a long time, we've been wanting this to happen in the sense that subsidies have been there for a long time. I think they've probably reached all-time highs because of the factors that I explained in my testimony. So yes, so by factoring, those are real costs. There's nothing we can do about those costs. They are to do exactly what you said, to keep the staffing at an appropriate level in facilities where those factors exist that necessitate these subsidies. So I think it's important, since it's a real cost, it happens every time, that it's factored in. And may I just answer two things you asked the MHA panel as well? Firstly, that data is already out there. As an anesthesia group, if we go to the hospital and ask for a subsidy, we give them an actual analysis of why we're asking. So the data is there already, and those costs are already there. And as far as who would you include right away, I think it makes sense to just include the people who are getting subsidies first, because that clearly means a definite need in terms of getting them and those folks in the facilities and that coverage. So.
Okay. And then not having this potentially as a solution to be included for consideration by the commission could really impact a lot of hospitals out there, particularly hospitals that may already be struggling or trying to cobble together their budgets. In particular, some of these rural locations like Carroll Hospital, or I know there's the new hospital for Shore, for the Eastern Shore, that, you know, without these provider practices and physicians being there to help staff them, you know, these hospitals would struggle to be able to provide the essential service they need for those communities. So, thank you.
Are there any additional questions for this panel? Seeing none, thank you all so very much for your testimony. Next, we have Gene Ransom, favorable with amendments.
Good afternoon, Chair Beidle, Vice Chair Hayes. Thank you for having me this afternoon. And thank you, Senator Beidle, for bringing forward this important legislation. And I think the legislation points out what a lot of us know, Maryland's physician payment model is broken. It's a major problem. The current market is failing physicians and patients. We currently exist in a monopoly where one carrier controls 78.3% of the small group market and 65.3% of the individual market. Essentially, this monopoly situation creates a situation where physicians have a take it or leave it proposition, and that physician could be employed by a hospital or be in private practice. It really doesn't matter. That reduces patient choice, and we have a problem. And that's why we're here today with this legislation, and that's why we continue to struggle with this problem with regards to the HSCRC. CareFirst financial data shows the imbalance clearly. Premiums have increased 6.2% between 23 and 24. Medical costs only increased 1.9%. CareFirst risk-based capital is 875% of required levels, 4 times the legal minimum. So we fundamentally have a problem in this market, and that problem is resulting in things like this needing to be done. We obviously like the idea of giving hospitals subsidies for physician payments. It's not surprising. We would suggest that you consider a couple amendments to make sure that as we do these types of things to try to correct market failures, that we do them intelligently. We would suggest some amendments. First of all, transparency amendments, making it clear that any subsidy that goes forward is clearly used for the purpose stated. We also think that it would make a lot of sense to make sure that the subsidies would be available to everybody, regardless of what their practice setting is. So if you decide you're going to subsidize a particular type of physician, that everybody, whether they're in private practice or employed by a hospital, have a shot at it. Secondly, we think there are a couple technical amendments for clarity with regards to the AHEAD agreement. In closing, thank you so much for bringing this forward today. And I think what we really need is a physician floor with regards to payment. Thank you.
I'm sorry. Oh, yeah. Gene, will you put your amendments in writing and make sure that you submit it?
Yeah, I think they're in the written testimony that was submitted. It might be under Dana's name instead of mine, actually, but I think they're actually attached to it.
Okay, thank you. Are there any questions for this panel? Thank you so very much.
Thank you. Thank you, Senator.
Next, we have an unfavorable panel. Matthew, Allison, and Willem. First one. Are you substituting Willem Daniel?
I'm sorry?
Are you substituting Kim?
Am I
We have a
not signed
Willem
up?
Daniel. No, we don't have you signed up. Is Willem Daniel from CareFirst here?
He is.
Okay.
You want me to go first? Sure. Okay.
Yeah, if you wanna stay at the podium in case there's any questions that may come up, Kim, that's completely fine.
Thank you
Yeah,
so much.
absolutely. Thank you.
I'll start then, if that's okay, Mr. Chair. Okay, Matt Celentano here today on behalf of the League of Life and Health Insurers in opposition to Senate Bill 515. While we are very much sympathetic to rising healthcare costs and how that impacts financial stability, we can't support this legislation that could have potentially disastrous downstream consequences to Maryland consumers. We certainly understand that rising physician costs are a tremendous issue and of concern to the hospitals. And I could spend the next few hours talking about runaway healthcare costs that keep insurers up at night. But this bill is a major departure from the norm, and that impact could be wide-ranging. We believe that we should take a measured approach here to make sure that we understand the consequences and have all the data to make a proper and prudent decision. We heard the proponents saying that it's just a tool, but if so, why is it an emergency measure? The league believes we should enable the healthcare agencies, the HSCRC, the MIA, the MHCC, to dig into this issue, study the impacts, and give the General Assembly options for the future. It's also my understanding that the impact from this bill, including physician costs and rate setting, could impact the financial stipulations of the AHEAD model and threaten the contract terms. And I'm sure that nobody here wants to do that. So once again, we understand the desire to address healthcare costs across the continuum, but we respectfully ask for an unfavorable report on Senate Bill 515. Thank you.
Welcome.
Thank you, Mr. Chairman, Madam Chairman. CareFirst has three concerns about this legislation. The first is we're concerned about reopening the AHEAD model just 6 weeks after the model began. The most contentious piece of negotiation with CMS during that process was the scope of the state-based rate setting system. We think it would be imprudent to expand the scope of that state-based rate setting system so soon after beginning the AHEAD model. Second, we are concerned that this legislation looks at physician costs without considering the whole impact on the health system. Hospitals tend to be paid more than physicians for the same services. As a result, hospitals tend to book revenue under the hospital side rather than under the physician side so that they maximize the reimbursement that they receive. Consequently, hospitals tend to be profitable and physician practices owned by health systems tend to be unprofitable. But when we look across the entire system, those things balance out because the money is being booked under one side and the costs are being booked under another side. According to HSCRC data, hospital-based physician losses were approximately $900 million, but hospital profits were on average 8.4% of regulated revenue, or approximately $1.5 billion, more than enough to cover the physician costs. When looked, as the HSCRC has done for basically its entire history, at the total health system margins, they were about 2%, or in line with historical averages and higher than they were in 2013 prior to the start of this model. We think it a mistake to look just at the physician costs because that would contribute to an affordability crisis if those costs were allowed to be passed directly into hospital rates without considering the offsetting revenue that hospitals bill for the services that they provide. And it's for those reasons we are concerned about this legislation, and I will pass it to my colleagues.
All right. Good afternoon, Madam Chair and members of the committee. For the record, my name is Allison Taylor. I'm here on behalf of Kaiser Permanente. We're also here in opposition, although our perspective is a little bit different from the rest of our payer colleagues. Kaiser Permanente does contribute physicians to hospitals to care for Kaiser members. So to that extent, that's a real value add that Kaiser does provide. Our opposition is predominantly because we think this issue should be unpacked a little bit more, and there may not be enough time within the next 50 days or so to do that. The issue of stipends is important, as is I'd say looking at what's been described as the lower commercial rates versus higher public payer rates, relatively speaking, under the model, and other factors that go into this. So Mr. Carlson is correct. I have also reviewed some data that's been collected, and it's been pretty insightful on this. I will send it to the chair and committee council if you haven't seen it before. But so our request would be unfavorable report and continuing to look at this over the 26th interim. Thank you.
Questions from Senator Reedy?
Yeah, I wondered, Matt, if I could ask you, I mean, several of you mentioned the AHEAD model, and obviously it's been top of mind. I guess there's a pun there with the head and top of mind, but it's been it's been obviously hanging all over all of us, this new model. How would this in your opinion, or the opinion of your organization, endanger the head model? I guess I'm trying to understand why it would endanger it. Not that it might not need some massaging, but why would you use some you said disastrous, which is it's a harsh term, so.
So I don't know if it's harsh considering the implications of this bill, and I want, if Senator Reed, it's okay for Will, who's the expert, to answer this question, but I will say that every one of the Carrier Council have said to me that major financial departures from the contract that we agreed with on ahead could invalidate the contract we have, and that is a risk I don't think that any of us should be worth taking.
Can you repeat that? Major what? Major
risk to the contract terms. This is a departure from the financial situation that was agreed to with the state, with CMS.
If I might add further elaboration from the other guests there. Yeah, thank you.
Thank you for the question, Senator. So CMS, over the course of the AHEAD model negotiation, made it clear that they were concerned about the scope of state-based rate setting for hospital services. They required that the state give up Medicare rate setting and limit itself just to commercial rate setting on the hospital services. Now, this piece of legislation would expand the scope of the rate setting system when they have just spent a year and a half trying to, or a year, I guess, trying to limit the scope of state-based rate setting. And so we think that reopening and trying to relitigate with them how expansive state-based rate setting should be under the AHEAD model, would at least involve additional discussion. And second of all, anytime we reopen this model, things seem to get a little bit worse for us.
Could an adjustment where we are only rate setting in a more narrow way than this bill, and I'm just seeing the bill myself. If we adjusted if the bill was adjusted to narrow that to where you're focused in a particular area, like just the private market, that's still an issue, in your opinion?
So CMS did express concern about state-based rate setting in its entirety. They directed in the contract that the state review, and the state agreed to review, the impact that the model has on the nature of competitive markets in the state. I don't know how CMS will view this, but I do think they will review it, and that any review so close to the end of a tense negotiation incurs some element of risk.
And I guess lastly, if I might, Mr. Vice Chair, the concern that we've heard from the proponents, and they're echoing the things we've heard from our health providers. Are we saying this AHEAD model does not give us the kind of flexibility, that we need to make some of these adjustments? And we're trying to modernize. Anytime you're trying to have rate setting, it's somewhat confined. So we need to be able to modernize in some way. And whether this bill is the exact right vehicle or not, is certainly open debate. But is it a contention of you all that any kind of rate setting change endangers the AHEAD model?
Again, I'm not sure I can predict how CMS would view it, but I do think, and again, everything I think the state heard that we heard through that process is that they wanted to limit to the greatest extent possible state-based rate setting. They don't like
even
it for
if we could argue,
reasons.
and sorry to interrupt you, but even if we could argue that it's actually going to save money in the long run, but then it would still open it up for them to have to debate that with us, is what you're saying.
Yes, correct. And again, we think the state, the administration, the secretary, the Department of Health, the HSCRC have done really a fantastic job getting the deal that they did get from the state from CMS under very difficult circumstances. And our contention is just 6 weeks after we start that model, restarting a conversation with CMS contains some risk.
Okay. Well, thank you. Thank you.
Thank you, Senator Washington.
Thank you, Mr. Chairman. Kim, is there something you would like to add in 60 seconds or less?
Thank you so much, Senator. I appreciate that opportunity. I just want to say, as
you heard about CareFirst's role in this market, and CareFirst has been serving the citizens of the state of Maryland for nearly 90 years. We are a carrier who has been consistently in every market in this state. And while, yes, that might produce that we have a large market share, I think it is because we are consistently here showing up for the people that we care for. When we talk about rate setting, we're talking about how costs are shifted from premium to carriers to providers. And there's always a tension because on the other side of that, someone is paying that rate that is going to ultimately pay for those services. We value our partners in the healthcare space who take care of the people that we serve, but at the same time, we know how important the AHEAD model has been, how unique our rate setting system is, and all the reasons why my colleague talked about the risk that making these changes can provide to the state when we are relying on the federal government to allow us to continue to do what we've been doing. So I will leave it right there. If anyone would like to understand better the financing of healthcare, I'm happy to talk about the importance of high-risk-based capital because it's what keeps company afloat. But other than that, I appreciate the chance to say something to you today.
Senator Washington, done? Yes. Okay. Senator Lamb?
Yeah, thank you, Vice Chair. So I guess I'm trying to understand why there's this huge level of concern here. You know, obviously the negotiation's been going on, and a lot of this was really for, it's still a work in progress, right? And I know that CMS's primary interest was in the Medicare part of this. This was the rate setting ability that they pulled back was really just for the Medicare piece. The negotiation took place between the department, obviously HSCRC was involved, and also with CMS. You know, I'm not, in looking through this bill folder, I'm not seeing opposition from, you know, MDH. The commission just has informational. There's, you know, no concern being brought in as huge red flags that this could derail a process that the department just went through for the last 6, 8, 10 months or so.
If I were at the commission, I would be concerned. And I realize that, you know, they might have a different assessment. I think the conversation that CMS has had with not just the state, but also with hospitals and payers has expressed concern about the impact that state-based rate setting has had on the model and the market in the state of Maryland. And, you know, I think that an expansion of state-based rate setting to physicians would be concerning with them, concerning for them, and likely to restart a conversation.
But the agreement still gives time for there to be a system to be set up, right? That, you know, has CMS and the state finalized a rate setting model for the private insurers yet? Because I don't believe that they have.
So the model allows the rate setting system for the existing global budgets for hospital services under the commercial, for commercial payers to continue. I think it also requires there to be a conversation with CMS anytime there's a change to that methodology. And in particular, there is language in that agreement that says it is a potential terminating event if there's a change to the legislation that makes it difficult for private payers or the state to participate. And so an expansion, I think, of the rate setting system into an area that has been historically unregulated, I think would at least cause some conversation with them. And again, our position is not that the state has a good plan for that or that CMS, you know, would, you know, look negatively on it. Our position is just that 6 weeks after the start of the model, it seems risky to restart that conversation.
So you mentioned a few times that they would have a conversation with them being CMS, they being, you know, either the department and or the HSCRC. But, you know, what the bill does is ask for for the commission to review and develop a policy to account for this, right? And then there would be a conversation with CMS about how this could be implemented and coordinated. That, as with any negotiation with the federal government, they've been having these ongoing conversations, right? So, why is it that just having a review and establishing a policy means the sky's falling down?
So, under the existing rate setting system that we've had since 2013, the all-payer model and the total cost of care model, the HSCRC has looked at total system margins to assess whether the system is adequately funded. That means they have implicitly considered unregulated physician losses, and they've balanced those against regulated hospital losses on the other side. And they've looked to make sure that the system, the health systems, have been adequately funded in totality. I think that the system, the HSCRC, has done a good job preserving hospital financial stability over the duration of the model, as evidenced by the extraordinary rate actions they've done over the past 3 or 4 years since COVID. And so I think that the problem, at least in my opinion, of the physician losses when looking at a health system and balancing the regulated profits against the unregulated physician losses has preserved sufficient access to services and preserve financial stability for the health systems. I do think that in response to your question, going the extra step and saying explicitly that we want the rate setting system to do this new thing involving physician services and pushing the bounds of state-based rate setting into an area that had been a competitive market to determine physician rates between payers and carriers, I think has some risk, considering everything we've seen out of CMS is that they want to, they have literally said they want to get rid of state-based rate setting in places where they find it, right? And so I think we can solve this problem, and the HSCRC has solved this problem over the duration of the model, and we can do it without running that risk of doing an explicit rate setting policy, which CMS has indicated they have ideological concerns about.
But they only took back the rate setting ability for Medicare. If they really had that strong ideological concerns with, they could have blown everything up and taken the entire, taken it entirely under the CMS umbrella.
I agree that they could have blown everything up. I think we and the state deserves a lot of credit for convincing the state, the Secretary, HHS, that the aspects of the global budget, which preserve stability and create incentives for hospitals to invest in preventative care, align with other ideological aspects, their MAHA thingamajiggy that they're trying to do. And so I think we've been, the state has done a really good job balancing those two. And again, our contention here is that it would be risky to, give them a second or a third bite at the apple here.
Let me just close on this. I think you mentioned balance quite a few times, and with the regulated marketplace here, everything's kind of in. All of us are trying to strike that right balance, right? We're trying to thread the needle there to strike the right balance. You mentioned that it's important to have a balance of keeping rates under control, but then also making sure that there are adequate services that are being provided in these hospitals. When I hear, and when some of my other colleagues hear, the fact that it is becoming increasingly difficult to provide essential physician or provider coverage in some of these absolutely necessary services to have a hospital continue to function, I'm not sure that that balance is properly struck. And so this is where, to me, this seems like a lot of fear-mongering for a potential risk that is probably pretty low, because these ongoing conversations are supposed to be taking place with CMS to push back and on a bill that's trying to strike that right balance again. Thank you.
Thank you. Madam Chair, Senator Biden.
Just a quick question. I'm going to direct it to Matt. So we heard in earlier testimony that there was a 6.5% increase in health insurance premiums, but only a 1% increase in payments to hospitals and carriers. Can you comment on that?
I don't know if I can comment on that, Madam Chair. I'd have to see the numbers. That's not something that I have heard before.
Are there any additional questions of this panel? Seeing none, this ends the hearing. Oh, no, we have one more. Informational. We have to hear from the commission. Jonathan, is Jonathan here? Where's John? Oh, here he is. Thank you all so very much for this panel. We're going to hear from Jonathan Crom from HSCRC.
Right. Good afternoon, Vice Chair, Chair Bidle, members of the committee. Thank you for the opportunity to share information as the committee considers Senate Bill 515. For the record, I'm John Crom, the Executive Director of the Health Services Cost Review Commission, the HSCRC. As you know and has been discussed, hospital services are paid in two parts functionally. One part to accommodate the hospital operating costs and a separate amount intended to cover the cost of physicians or other professional work. Historically, HSCRC's jurisdiction, what we refer to as the regulated services or costs, has largely been over that first part. So it's widely recognized, you've heard it here, that that portion of costs related to physician coverage that's unregulated for hospitals is growing at a faster rate than other cost drivers. I would single out, because we haven't heard it as much, that the Medicare professional payments have not kept pace, and that's really one major driver here. So both nationally and in Maryland, hospitals are needing to supplement payments for professional services from the amounts that they collect for operating costs. Historically, within the HSCRC, rates for regulated services have been higher than regulated costs, and that's offset much of the physician cost growth over the years. But I want to acknowledge that that historical approach doesn't necessarily prevent high rates of future cost growth or ensure that revenue is distributed to the places where it's most needed. I would say, I would just highlight that HSCRC policies really revolve around hospital rates. So if a policy approach were to redistribute revenue, there isn't much of a direct fiscal impact. But if it were to increase statewide total revenue, that would have an impact, and that was discussed in the fiscal note. I would say that we believe that there are a lot of considerations here. You've heard a lot of them here. Happy to answer questions and appreciate the opportunity to provide information.
Indeed. Senator Reedy?
Jonathan, I know we've already had a lengthy hearing, but I just want to be sure I understand. I'd like to get your perspective. Do you believe that this bill would endanger the AHEAD model?
Yeah, so let me reflect on a couple aspects of that have come up.
I know you're here as informational.
Informational, yeah. But I would say a couple things, right? It would certainly be a discussion with CMS, as you all have heard. I think Senator Reedy, you had a great point, which is like if we can.
Stop right there. No.
always willing to recognize that. The point about if there's a policy in place that would enhance affordability over the long run, or fit within the affordability targets of the model, certainly that's a different discussion, right? In that circumstance. So I think part of what we're saying here is that there's a lot of considerations here that are kind of complicated as we think about how to solve these challenges going forward.
Okay. Thank you. Thank you, Mr. President.
Thank you, Senator Lamb.
Thank you. So the HSCRC could have taken an oppositional position, right? And in this instance, they did not. You're here just for informational. There have been instances where the commission has opposed bills.
Yeah, we're here informationally, yes.
Okay. And you chose not to oppose this one, right? And so, correct, yes.
Correct.
I'll answer that one for you, but has the commission been hearing about more instances where hospitals have struggled to be able to find physician practices that staff essential services for a hospital?
Yes, and historically, yes, and then I would also say nationally, yes, right? And so part of what we've been doing over the last couple years is collecting cost report data. You heard Patrick mention that. That's been pretty involved work, and we still have work to do because we don't have all hospitals reporting apples to apples comparisons of their costs and how they're structured and so forth. So still work to do there. So I think it's important to note that what we don't have a full insight on is distributionally, right, across the state, what impacts different hospitals differently about hospital costs. So still work to be done in order to validate, but that is a challenge that I think is held kind of broadly nationally in healthcare finance.
Okay. And I guess in looking at the bill has language that says it shall take into account, which take into account doesn't mean that it has to lead to an increase in rates, right? That doesn't necessarily compel this to be an increase in rates, that you could still keep rates, the commission could still keep rates similar, you know, recognizing and taking various things into account. This is not a piece of legislation that forces a rate increase.
I don't read this to force a rate increase, but to solve the challenge, right? There's only a set number of tools that the HSCRC has, and hospital rates are the primary tool.
And would you envision that if there was a review and the establishment of a policy to address this, that would lead to a negotiation with CMS, that you would have ongoing negotiations with CMS about this and how this could be taken into account?
So in terms of negotiations with CMS, do you mean on the
Well, there's been a
Medicare
lot of concern
component?
about how this would derail the HED model and you know,
I think it
threaten.
depends on the solution, right? It depends on the solution, depends on the scope, depends on the impact on rates. You know, what is the mechanism for future enhancements to affordability, right? Like, in other words, this is a cost growth problem, right? More than anything else. How is it going to solve for that problem going forward? So I think in those regards, it would, you know, I think CMS would be interested.
Okay. All right, sounds good. Thank you.
Thank you. Are there any additional questions for this panel? Seeing none, this ends the bill hearing officially on 5/15.
Thank you so
very much. Next, we're going to hear from Senate Bill 583, Senator Jennings, Developmental Disabilities Administration Self-Directed Services Manual, public comment. We have Cherie Dexter, Cody Stevens, and Michael DeFeo signed up. We still have a long day to go. We're still on the second bill. The sponsor of the bill has as much time as he like. Everyone else has 2 minutes. Please do your best to stick to the 2 minutes. Colleagues will chime in and ask questions that will give you additional time, but please stick to the 2 minutes in your testimony when you have the opportunity to do so. Senator Jennings, you may begin whenever you're ready.
Thank you, Mr. Chair, distinguished members of the committee. For the record, Senator J.B. Jennings for Senate Bill 583. 583 is about stability, transparency, and accountability for Marylanders with developmental disabilities and the families who support them every single day. Over the past several years, the Maryland Developmental Disabilities Administration, or as we know it as DDA, has implemented repeated and sweeping policy changes to self-directed services with minimal notices to families, participants, providers, and support teams. In recent months alone, major revisions to these self-directed service manuals were issued with as little as 14 days' notice. A waiver amendment was released with only a 30-day public comment period. In one instance, a new policy was announced after it had already taken effect. These have detrimental effects to these families. In November 2024, there was a sudden waiver change. It happened again in May 2025 and in October 2025. Each time, families were forced to rebuild services in a matter of days, adjusting staffing and budget overnight, and respond to complex policy shifts without meaningful stakeholder input, all while trying to maintain stability for individuals with these disabilities. Again, this is a huge impact to these families and these individuals. Self-directed services are built on the principles of autonomy, person-centered planning, and family partnership. Yet DDDA's current practices destabilize teams who are simply trying to keep people safe, supported, and engaged in their communities. Families are left scrambling, staff fear losing their jobs, participants experience disruption in daily supports that are critical to their health, their safety, and their independence. At a time of financial uncertainty, the last thing these families need is policy uncertainty layered on top of that. This is a critical shift. A manual is an internal guidance and can be updated quietly. That is the concern that many of these families that are here today are, that's what we hear about. I know many of your offices hear about it daily. You know, when these changes come in, that they don't have time to adjust. That's what this bill does, is it gives them a chance to read it, understand it, and enact it or deal with it. Families are asking for time before these changes take effect. They're looking for transparency and stability for their daily support. I understand that DDA has implemented or submitted an amendment. I have talked to them, trying to work with them on that. I know my bill has it at 90 days. They're trying to bring it back to 30. I'm hoping that, you know, we could try to find a median there, somewhere in there in between. I just ask this committee to please look at these families as they come up and they testify, understand what they have to go through. They need some type of notice and time to act, to at least give their insight to DDA with these changes when these manuals come out, so they can give their insight to say, hey, this is going to work, this isn't going to work, how are we going to adjust it? Because these things happen rapidly, they don't have time to adjust. So, Mr. Chairman, with that, I ask favorable consideration, and with that, I'll turn it over to my panel.
Absolutely. Thank you so much, Senator Jennings. I have 4 people at the table, but 3 people signed up. So Sherry Dexter.
Right
okay.
here.
Cody Stevens. Okay. Michelle Defoe. And ma'am, are you signed up?
I'm Ann Valerbone. I am signed up, but I was just
I'm
holding the
sorry.
paper for them.
What are you signed up as? What's your name?
Ann Valerbone with a V.
Okay. All right. Excellent. Sounds good. All right. You all may begin whenever you're ready.
Great. Thank you so much, Madam Chair, Vice Chair, members of the committee. Thank you, Senator Jennings, and the sponsors of SB 583, as well as Delegate Michelle Guyton, who is sponsoring our companion bill in the House. I'm Sherry Dexter, Cody Stevens, and I also have some of my other co-leaders with me. We're leaders of Concerned Citizens Self-Direction Maryland, but we're also parents of participants in the self-directed services, and Cody and I are both representatives of the DDA's MidSec committee, which is their sustainability committee. You may recall, it may not have been your committee, but we were here last year, and we came at the time that the manual was first released. Since that time, there have been 4 other additions. These are the additions of the manual that are right in front of you that families have had to look at. The manual has expanded from 116 to 192 pages, often effective immediately or within days, as Ann is showing you the sign of the number of days that we've had between revisions and also how long it has taken until they go into effect. Last summer, the DDA had released 623 pages of the Community Pathways Waiver, which is right in front of you. We had 30 days to comment on that. With more than 260 recommendations that were submitted, we are aware of about 40 that were approved without other remarks. Just days ago, there were 28 new policies totaling 291 pages that were posted on PolicyStat, and those were effective upon posting, so no time to read those. Together, when you look at all of these documents, they total 1,675 pages.
As MidSec members and as parents of Luke and Timmy, we have participated in advisory processes in good faith. yet major decisions surrounding the $155 million in proposed cuts have advanced without consensus and without meaningful incorporation of stakeholder input. Each of the revisions Sherry mentioned require staff time, legal review, administrative restructuring, and in some cases, litigation and corrective amendments. In a year defined by $155 million savings conversation, it's fair to question whether the fiscal costs of repeated policy shifts have been fully considered. SB 0583 is a necessary safeguard. We respectfully request and insist that it be amended to require 90-day public notice, an opportunity for comment whenever the DDA changes their terms, scope, or delivery of services, whether throughout regulation, policy, practice, or procedure at any time. We also urge that proposed changes be described in plain language so families can understand them before they're expected to comply with them. Notice is not obstruction, transparency is not a threat, accountability is not opposition. When policy can change overnight without notice, stability turns into uncertainty. Uncertainty undermines safety, planning, and trust that is expected and required. Marylanders with disabilities deserve governance that is predictable, transparent, and participatory. SB 0583 restores that standard. We respectfully urge a favorable report with this amendment. Thank you.
Good afternoon, Chair and members of the committee. My name is Michelle DeFeo, and my daughter here, Madison, just left the room, so sorry about that. We are here to support SB 583, requiring a 90-day public comment period before any new DDA policy changes are implemented. My daughter, Madison, has been receiving DDA services since the very beginning of self-directed services here in Maryland. In fact, she was one of the original participants who helped pilot this program over 20 years ago. Madison has maintained the same support staff for 20 years, 17 years, and 13 years. For decades, participants and families have partnered with the DDA to build a model rooted in choice, community, and stability. However, the last year and a half has been the most difficult period my daughter and her team have ever experienced. There has been constant policy change, often with little notice, limited explanation, and no meaningful stakeholder input. These changes have created chaos and unrest across the self-directed community. The confusion has not only affected participants, but also families and their teams tasked with implementing these new policies. Guidance has frequently gone unanswered. In some cases, the guidance provided by one state employee directly contradicted guidance from another. Participants, families, and providers have been left trying to interpret policies that were unclear, inconsistently communicated, or revised repeatedly in short timeframes. When DDA waiver changes occur, the impact is not limited to the services on paper. It directly affects the participants, employees, and the stability of their teams. Changes in wages, service definitions, or administrative requirements can destabilize long-standing support systems. Even small shifts can create uncertainty. We certainly hope that you support SB 583. Thank you.
Hi. Oh, sorry. Hi, Vice Chair, members of the committee. My name is Ann Valerbone. I'm the mother of Michael, a 35-year-old son with autism and developmental disabilities. I am also a widow, now his sole parent and lifelong advocate. I'm here in strong support of SB 583 and its companion bill, HB 1593, which would require DDA to provide a 90-day public comment period before implementing policy or manual changes to either the traditional or self-directed models. This bill is about transparency and stability. Currently, DDA policy allows changes to take effect immediately upon publication. That means participants who are the employer of record can instantly fall out of compliance through no fault of their own. Families, support brokers, service coordinators, vendors, and direct support professionals are left scrambling to understand new rules after they are already in effect. When you are the legal employer, non-compliance carries real financial and legal risk. for families like mine that risk threatens the services that our loved ones our loved ones safe. A 90-day public comment period would stop reform. It would ensure responsible reform. It would allow for proper training, clear guidance, preparation for vendors and staff, and meaningful stakeholder input before changes disrupt lives. Constant, repeated policy shifts in developmental disability services affect medical supports, employment structures, and compliance with federal Medicaid requirements. They should not be implemented overnight. SB 583 and HB 1593 provide reasonable guardrails. They ensure policy changes that are thoughtful, transparent, and manageable. I respectfully urge you to support this legislation. Thank you.
Thank you so much for your testimony. Senator Reedy.
Thank you, Mr. Vice Chair. And just, I wonder if I could ask Michelle maybe to follow up on your testimony. All of you gave excellent testimony. But something you said struck me, and I don't think the department is here today to testify. You said one guidance from one employee contradicts another. So we get these things that come out, and I remember many of us in this room were on a call in November of 2024. Which was a really interesting call. And there's been some changes since then, but these huge manuals just come out, these changes come out. And when you have that contradiction of guidance from one employee to another, surely there's someone that you then can email in an ombudsman type capacity, or someone gets back to you, right, and clarifies, or no?
Well, there's supposed to be. And I call them the team captain, which is the CCS, or service coordinator. However, in many cases, the CCSs are not trained on new policy until after the policy has been in effect.
So maybe a 90-day comment period would allow for some additional training for that, those employees?
I would think so.
Can I, and I'll, we're going to have a lot of witnesses, I know, so it's a situation where you're dealing with a population, I hate calling it that, it's your child, but people are dealing with either their child, or if they're staffing, they're dealing with somebody that they care very much about. It's not a great quick change. I found when I had children, I had to learn that I can't do quick changes like all of a sudden and shift what we're doing, and this is that population. So it doesn't work well to do a quick change like, oh, we got to drop everything and change our routine in 48 hours, or is that a fair assessment?
It is very fair, and it's also it should go both ways, because we are asked to pivot at the drop of a dime. However, when we're needing guidance and understanding, we're not. It doesn't appear that oftentimes we get the same in return.
Lastly, I've had some meetings on these issues, and I've been told that there have been, in the last year, there have been over 100 meetings between not just you all, but also self-directed agency, everybody involved, and DDA staff, some of which the directors attended, many, but not all, which is fine. But the point is that there's been a lot of these meetings. Is the experience that you guys have been able to have meetings in the last few months where you've at least been able to share more of this, or are we still not really getting answers on things and feeling like there's appropriate feedback?
If you don't mind, I'm happy to take that question. So I personally have been part of many of those meetings that you are describing, and it varies, is what I will say. So some of the community meetings we know feel more like one-way discussion where there's comments from the community and the DDA is taking notes, and sometimes doesn't really provide too much of an answer or guidance for us. I know on behalf of our group and other groups in self-direction, they've raised the same issues time and time and time again, and it feels like we're on deaf ears. I know personally, I've written to the secretary multiple times on behalf of our group on some of the same issues. We've come before legislators to talk about some of the same issues. So there's while there is conversation, and we do appreciate the DDA going to the lengths that they have, as far as having the webinars, the community meetings, other things, we still feel very much that there's many things that are falling on deaf ears.
So we want to be fair to them. So there's some follow-up, but it's inconsistent.
Yes.
And my view at times, from what I've heard from you, is there's a little bit of a customer service issue. It isn't that there's bad intentions by anybody, maybe, but there's just, we still have this problem. So it's another reason why it would be a good idea to have maybe a little more time and comment period. Thank you very much.
Thank you, Senator. Senator Lamb.
Vice Chair, thank you for bringing this forward. I think, I remember being in that meeting that Senator Reedy was talking about in November 2024, and I think a few of us here in this committee were in that meeting too. That was one heck of a meeting, and it was frustrating. And I think, you're sensing the frustration from many of us. And, and I've had folks reach out in Howard County and in my district too that have had issues with DDA that have gone unaddressed and unresolved for months and months at a time. And so while, you were asked if there's an ombudsman or, your personal experience that you just shared about trying to reach out to the department and seeing if you can get a response, and it's unfortunate the department's not here to respond to this, but, I think we share a lot of the same frustrations that you're seeing as well with a department that's been unresponsive to a lot of these just technical DDA concerns because of all the switching of the policies and the manuals that have come down very quickly and rapidly on you and your families to try to have to adjust to, and also the providers that are providing care for your relatives. And so it's been increasingly frustrating because even in the example that I gave, we had reached out to the department back in, I think it was June or July of last year, about a technical issue to try to get someone the coverage that they needed from DDA. It dragged on for months and months and months, and I could not get an answer out of the department as well. And it wasn't until November where we were just fed up. And I told the department that I would be texting the secretary on Thanksgiving to try to get this resolved. And it's only at that point that they responded and solved this problem. It should not take a legislator having to text the secretary on Thanksgiving to get your problems resolved. This went on for months. It went on for so many months that I thought I was talking to a chatbot at MDH. It was really, really frustrating. And I guess the question then to the sponsor, to Senator Jennings, I think you're probably reflecting and hearing from a lot of your constituents as well that these are concerns that you're pushing up to the department and they just seem to bounce around and never get resolved.
Not only my district, the committee has statewide reached out to me. I will give fairness to this department and the new director. She has been working with me, or the new deputy secretary, on this. She's been in my office. In fact, I met with her right before session today. There's a lot of issues in this agency they're trying to deal with. And I am trying to help her and work with her. She understands it. She knows it. Not only am I dealing with this side of this building, but over on that side of my committee on budget and tax, we're dealing with the financial side and, trying to handle the huge increase in the financial issues that we're dealing with over there. And she's somewhat inherited a mess, and she knows it. She's trying to deal with it, but this is one that it's not fair. I mean, you're a physician. When they push down some type of new regulation for you as a physician, there's some time for you to adopt that before it's implemented. With what I do, there's always a period of time before, something takes effect. It's not fair for these families. And and my staff has worked with them several times. We've told them that. And they some of their pushback is, hey, some of this is federal regulation they have to deal with. Look at that manual. Look how thick those books are. How many pages was it? 1,000 some? There's no way, they're working their full-time jobs. They come home, they're dealing with their family, with their other kids, and that they have to try to deal with all that too. It's just not fair. They need more than 30 days.
And even for the department just to respond.
Yeah.
Like I've heard from a lot of folks in my district and our communities that say that they forward this on to DDA and they just don't even hear anything back. Like it's nothing. And so at least the courtesy of a response to give an update on.
I think you're getting changes from this administration. I think they see it, this new, the new head there. I think she's hearing it, and I think you're going to hopefully see some changes coming through.
Okay.
Hopefully, I'm hoping.
Thank you.
Senator Kramer.
Thank you, Mr. Chair. So I completely understand the merits for the bill. My thanks to the sponsor for addressing this. This sounds like the worst of government bureaucracy. And hopefully, as has been just discussed, we're going to see a change in that trend, which is critically important. Looking at those documents, do you think maybe there are other things that should be addressed as well? For instance, the frequency with which these changes can come. Should there be a limitation within a fixed period of time that you can't have more than, a fixed number of changes within a fixed period of time, and that there be some respect for you all, because it sounds like it's almost been a little dismissive of what it is that you all are doing and what you have to do and the demands on you all, and that the department is dismissive of that because, well, they're just a massive bureaucracy and there is absolutely no concern for the realities of what it is they are doing. So just real fast, do you think there is an opportunity for other legitimate, important changes in addition to this that maybe would be appropriate and I don't want to speak out of turn, but maybe could be addressed in an amendment to this bill, Mr. Sponsor, as long as we are taking this up, that might also.
Well, one thing I have heard from the community is that, as you said, the amount of changes is that they'll be very frequently. And, I would have to leave it to the panelists when they come up, the amount. So original date, can you explain? I don't know.
Okay, so this was the slide I was holding up. It's the DDA self-direction manual revisions since October of '24. The original was October 24th of '24, effective November 7th. 14 days notice was given. It was 116 pages. The second one, when its original date was October 24th, went into revised on November 6th, went into effect November 21st, 15 days notice, 120 pages. October 24th, revised May 9th, effective May 9th, 166 pages. October 24th, original date, May 19th, so only 10 days later. May 19th went into effect, 0 notice, 167 pages. October 24th origination date, revised date September 24th, 2025, went into effect October 6th, 2025.
May I just interrupt, because there's still a lot of people who are going to come up, and I get it and I appreciate it, but what I'd be interested in finding out, and maybe you'd work with the sponsor, just to come back and say, here are a couple of other pressing issues that we think would make sense and be practical and realistic to help with the lift that you all have. And with that, thank you, Mr. Chair. But if you all would have that conversation with the sponsor, maybe there's an opportunity for some other relief that could be provided. So thank you.
Amazing.
Is it possible
Thank you.
to?
1 second, let me just see, is there any other questions of this panel? Let's move along. I know you guys,
Thank
but
you.
thank you all so much for your
Thank you
testimony this
very
evening. I know
much.
how hard it is. I could just imagine it's tough. The next panel, we have Shayna Farlow, Hannah Chirito, Jane Moncure, and Kim Nutt. Sure. How do we get the, how can we get the her two brothers? Yeah, on the end. Got you, okay. Yeah. You could pull a microphone. There we go. Ooh. All right, who's ready to go first?
Good afternoon, Chair and members of the committee. Thank you all, and thank you especially to Senator Jennings for this bill. My name is Hannah Sarita, and for more than 5 years, I've now had the privilege of serving participants in Maryland's Self-Directed Services Program. I currently support 2 individuals in Howard County, one of whom is with me today. He has spent his morning and afternoon today meeting with legislators, advocating for his right to live independently alongside his mother and myself as his caregiver. I provide vendor community development services, personal support staff services, as well as day-to-day administration services. I am here today to speak specifically about day-to-day administration because recent changes to the manual have severely restricted this essential support, harming the participants I serve and love, as well as my small business in Maryland. Until recently, day-to-day administration allowed me to handle the critical behind-the-scenes work that makes independent living possible, managing complex staffing schedules, ordering medical supplies, coordinating transportation, overseeing household logistics, and resolving issues before they would escalate into a crisis. Even in a light week, those responsibilities would take up to 10 to 15 hours. Under the new Self-Directed Services Handbook, however, this service has been reduced to now just 10 hours a month. Participants must navigate an extensive decision tree process to qualify, and even then, approved tasks are now limited to a very narrow list that truly does not reflect the reality of our daily lives. Independence does not run on just 10 hours a month. When administrative support is restricted, stability is lost. Families are forced to shoulder an unsustainable burden, and the very promise of self-direction that was solidified in our Self-Direction Act is undermined. I respectfully urge you to pause these cuts, require a 90-day public comment period before further changes are implemented, and ensure formal public notice prior to updates. Participants, families, and providers deserve a meaningful voice. Please protect day-to-day administration and the integrity of self-directed services. Thank you for your time and for your consideration today.
Who would like to go next? All right, thank you.
Hi, my name is Shayna. I am the sister to Andrew over here, who's 43, and Nathan over here, who's 34. They suffer from a leukodystrophy, a devastating brain disease that leaves them like quadriplegics. They rely on dedicated caregivers for every aspect of their lives. I am here because DDA has already begun cutting the rates paid to the staff my brothers now trust, know, and love. Just last week, we were told the hourly rates were being reduced, and I was given 1 day on that, what they were talking about a while ago. Now we are facing a proposed $150 million cut, which could lower wages by $15 to $17 an hour. These are hardworking Marylanders who will not be able to afford to stay with us. Because my brothers have REM and a nursing plan with REM, DDA is eliminating the enhanced hourly rate, calling it a duplication of services. But their medical fragility has not changed. Their needs have not decreased. Taking funding from the most vulnerable because of bureaucracy is discrimination. We staff 8 caregivers in our rural home of Stockton, Maryland. It has already become difficult to recruit and retain quality staff, especially since our mother passed away 5 years ago. If these cuts happen, caregivers have told me they will leave. We tried respite in a traditional setting. Andrew went with 150 Vicodin. After 3 days, I went and got him, both of them, and he came home with zero after 3 days. Someone had stole his medication. How can I trust institutional care? Despite being in wheelchairs their entire lives, my brothers do not have any skin breakdown. Nathan has only been in the hospital once in 15 years. Andrew has been in the hospital 0 times the last 15 years overnight. I know what quality care looks like, and institutional care would cost the state far more. Oh, man. Yes. Thank you. They attended a school called Cedar Chapel School in Snow Hill, Maryland, when they were young, and learned to read and write. After graduation, they were placed into a day program that was traditional. They did not like it. You can ask them yourself and they will tell you. Since moving to self-direction, they are reading and writing again. They are engaged. They are thriving. These services are not luxuries. They're lifelines. My brothers deserve dignity. Their caregivers deserve fair pay. And Maryland families deserve a system that protects the people it was created to serve. Thank you so much for your time.
Thank you for your testimony. Who would like to go next?
Oh, it's okay. Okay.
Hi, everyone. My name is Kim Knupp, and my husband and I reside in Howard County. We have 4 grown children. Our oldest has her doctorate, and she supports young adults at Shepherd Pratt. Our youngest is a senior at University of Maryland. Today, I want to tell you about my 2 other children who cannot really speak for themselves, my 27-year-old son, Benjamin, and my 24-year-old son, Jacob, who is here with us today. He's a microphone hog, so we had to put him in the back because, right? He would talk too much. Okay. Both of those young adults, my sons, have disabilities, and they now use self-directed services. When Benjamin finished high school at the height of COVID, we were offered a medical facility where we saw about 40 clients crammed into a room sitting and watching TV. Through my trained teacher eyes, I saw many people that were listless, bored, and not being communicated with. After several unsuccessful placements, we realized that finding a safe and engaging day program was going to be much harder than we originally thought. Benjamin's self-injury increased as a result of being driven around as many as 4 hours a day that we found out. So my husband took 18 months of unpaid leave so that we could do the self-directed services and find better care for them. This has been such a positive change for Benjamin. He spends his days out in the community with one-on-one support person like Hannah. He attends activities that he likes, and he can now be communicated with because people understand him better. Before self-directed services, we would go through caregivers frequently, constantly having to retain new ones and retrain them. We now have reliable staff to support both boys, and because we can pay them better for what their commitment and training deserves. When our son Jacob left high school, we went right to self-directed services. Now he can go out in the community and volunteer, but more importantly, he has started to be much more independent. He is now thriving, and his challenging behaviors have diminished. Self-direction gives my sons a chance to live life the way they hope for, that many of us take for granted, to be safe, secure, productive, and to be heard. Due to some of these policy changes, we have lost our nurse, we have lost other caregivers. Our nurse was not paid for months at a time, and she finally said that she just had to leave. So I'm asking to please support this bill so that we can have more time and stakeholders can have more discussion towards what would actually work with our families. Thank you.
Could he say one little thing? He wants to say something. He wants to say something bad. Go ahead. Say what you want. You say bye. Bye. So what he just said was, I want to keep my sweethearts. And that's it. Is that it? Please. He says he loves you all.
We love you.
Thank you.
Thank you.
Jane?
Yes, my name is Jane Moncure. I have a 33-year-old adult daughter with cerebral palsy. She was initially denied services from DDA because she received a high school diploma in 2011. She began receiving services in 2023. She now has her college degree from Towson University, but has considerable mobility, speech, and behavioral issues. In 2025, her agency decided to exit personal supports due to financial difficulty, and so we began receiving self-directed services in October. We have experienced constant, nonsensical, and confusing policies. Policy changes came with no warning, which caused us to cut funding for therapeutic programs, equipment, and administrative services. I spend hours a week doing administrative work to make sure our providers are correctly and timely paid. They cannot afford to miss a paycheck or take a cut in pay. These are not natural support activities. I do not make appointments, monitor budgets, coordinate staff and program schedules, read policies, review vendor invoices, or oversee payrolls for my other adult children. We hired staff with the promise that they would be paid certain hours at a certain rate and would receive certain benefits, but red tape has made that difficult. We have had to pay out of pocket to keep our staffs whole. Employees cannot bill mileage for transportation to medical appointments, even when those appointments occur in the middle of their shift. We had included health benefits in our budget, only to find out that most health insurance is excluded from payment because it is through a group plan, even though our employee incurs costs for her coverage as a dependent. Our providers have not billed respite services, even though they have provided hours in their homes overnight for my daughter, because we cannot find a clear policy on how to bill them. I urge support for Senate Bill 0583 to require a 90-day waiting period before implementation and periods of public comment. I'm a former senior financial officer for Baltimore County Public Schools. I know the value of public hearing and public input. Open communications between institutions and their constituencies are invaluable. Thank you.
Thank you. Are there any questions for this panel? Seeing none, thank you all so very much for your testimony this afternoon. In just 1 second, we're going to hear from some virtual testimony in favorable. Oh, we have one more person. I forgot because I had that one checked. Coming to the podium in just a second will be Rachel London, Jessica Gallatin, and Margot Thomas. No, the one. Who do we have here at the podium?
I'm Rachel London.
Rachel?
Yeah.
And
Jess Gallatin.
Jessica. Is Margot Thomas here?
I'm here.
Margot?
I elected not to testify.
Okay. Understood. Thank you so very much for coming. All right. You all may begin when you're ready.
Thank you, Madam Chair, Mr. Vice Chair, members of the committee. I'm Rachel London, Executive Director of the Maryland Developmental Disabilities Council and Chair of the Developmental Disabilities Coalition. You have the coalition's written testimony in front of you, support with amendment. There's been a lot of testimony about why all these things are necessary. So I'm going to talk about why they're necessary for all people with developmental disabilities, their families, the providers and staff, and not just for those people who self-direct. I'm also going to address what I understand is the department's amendment that strikes the bill and it replaces it with a requirement to adopt regulations. Yes, regulations are needed. We know that. We need regulations about the waiver program, about a lot of things. They're already required. In fact, the coalition has worked with the department for over a decade on numerous rewrites, none of which have moved to the next stage. Adopting regulations is not the intent of this legislation. The manual and the other guidance provided by DDA may not be law or regulation, but it leads to a lot of policies and a lot of procedures. You saw everyone's stacks. There are even more stacks. If the department is really committed to stakeholder engagement, this bill, with the amendment to ensure notice is provided for all policies, procedures, and guidance, including the Self-Directed Services Manual, would actually accomplish the intent of the legislation to make sure that people with disabilities in Maryland, families, providers, and staff have the opportunity to express how the proposed changes may impact their services and supports and prepare for those changes, as you heard. Thank you. So the Council and Coalition supports with the amendment. Thank you.
Hi, guys. Good afternoon. My name's Jess Gallatin, and normally I would be here on a personal level, but today I'm here representing the Self-Directed Advocacy Network of Maryland. And we submitted some written testimony where we believe that this bill is a very important step towards some transparency. And just like my colleague here said, it doesn't matter quite where policy lives, which is why we would offer an amendment to cover the various platforms that DDA uses to implement policies, because one affects the other. So we believe that it's definitely necessary. I'm slightly distracted from this only because listening to these personal testimonies, we've recently reached out. I think it's important that you guys understand that in self-directed services too, the employer, the boss, the person in charge of implementing any and all of these policies is the participant, the person with disabilities. So not only is it frustrating, and you hear from all of the families, my twin sister is like that. She's a nonverbal participant that has her mind and enjoys managing her staff and her people. She has to be able to do that, and there's no possible way even the average well-trained person can do this. This is a program for people with disabilities. Most recently, I've talked to someone who sat as a co-chair with DDA, and she specifically said, this feels like bureaucratic violence. And it's sad, and it's devastating, and it's so frustrating that it happens all the time, and nothing is being done about it. So we submitted some written testimony. I urge you guys to consider this because it's incredibly important, and we need to respect these participants for what they are capable of doing and what they're trying to do with their lives. It's important. Thank you.
Thank you. Margot, are you sure you don't want to testify? It'll only take 2 minutes. Come on. All right, there we go.
This is my son, Brett Barwick,
And you could pull the microphone toward you.
Okay.
That's fine.
Sorry. You might grab me, but okay, give me. Great. Just let the microphone down. So we have had services with REM and DDA. He has REM because he's very medically complex for many years, the same services. I'm a single parent, and I was given a denial without notice, actually 2 different denials on the same day. One was for, it was duplication of services, and I'm trying to think of what the other one was, but I went back to them. I said, which one is it? Which denial did I go with? You know, it's just devastated us. I've even hired a lawyer. I'm $10,000 into him, and he's hearing 0 from DDA. He says crickets. They're not even responding to him. And he gave me permission to come today. He says, I welcome you to go because this is crazy. They're not even responding to me. And I'm sorry. Yeah, I mean, they've totally denied his plan. We're in auto extend, and I don't know what I'm going to do. I work full time, and I just don't even know. I don't know. I mean, you know, I'm up a lot of nights without any services. Friday night and Sunday nights, I don't have anybody. He has seizures during the night. I can handle it. I've been handling it, and I think I fell asleep on our Zoom meeting last night. You know, it's devastating what they're doing. It's devastating, and that's all I can say. I'm just devastated and very emotional here, and no, I don't know what else to say.
Well, thank you for your willingness
Yeah.
to come to the podium. We
Yeah.
appreciate your testimony. I think it's intimidating being at that mic a lot of times, but I think it's helpful to the committee to hear all of the voices, so we appreciate it.
Right.
Are there any questions here? I'm sorry, I can't go in the back unless it's something really, really powerful. You want to tell Margot real quick so she can present it, or one of the ladies at the table real quick?
Yeah, I'm so sorry, Sherry Dexter again. I just want to say I have written to the secretary and to the DDA multiple times on behalf of Brett and Margot, trying to plead their case about trying to get services. I think I've written to the secretary at least 3 times, and the last time she responded was only because in the headline, based on what Margot had said to me in a phone call, "I am losing hope," was the headline of a subject that I had written to the secretary, that she responded that they were going to look into this further. We've made multiple appeals, and you see where she is today, so.
I'm pretty sure they're all listening now. And so
Thank you.
hopefully they will be a lot more responsive what they have in the past. And I'm
hope
sorry
so.
that you had to endure that wait.
Yeah. Thank you.
Thank you so much. And thank you for
Took
testifying.
out a
for it.
loan against my house to try and save them.
Indeed.
Save us. Yeah.
Colleagues, are there any additional questions for this panel here? No, seeing none, thank you all so very much. We have a couple more folks that would like to share with us this evening. We're going to go virtually, so bear with us for a minute. We're going to start with Ashley Johnson. Ashley, you may proceed when you're ready.
Okay, thank you. My written testimony is in much more detail, but I did take the time to shorten what I wanted to say today. I'm a single mother of a 19-year-old adult son who has a rare genetic disorder. I hold 2 master's degrees in education and behavior analysis, but I had to leave my professional career to become my son's primary caregiver in the self-directed services model after he failed to receive the support he needed under the traditional agency pathway. I am one of 4 of his support staff, and I am the only paid family member. And I say every single day, I cannot wait for the day that my son can fire me so that I can only be his mother. So under the traditional model, I had to call off of work a lot. I actually lost my employment working with the traditional model. So for us, self-direction was a lifesaver. We actually were in a position where due to dealing with the chaos of traditional agencies, we were literally experiencing homelessness. We got calls for emergency assistance the day before we had to go to a homeless shelter. My son has KIF1A, a rare neurogenetic condition that requires specialized medical and behavioral support. During our time in the traditional model, I reported staff misconduct, theft, inappropriate behavior to DDA, MDH, Office of Healthcare Quality. I've received no follow-ups or corrective action. When looking at this proposed bill, the abrupt changes to this policy or service guidance without notice jeopardize family stability. If I don't have my staff for my son, I have no ability to work outside the home. I have no ability to sleep at night. My son is going to be at risk of hospitalization and other things that he experienced frequently under other models that weren't adequate for him. We need time to prepare. We need time to secure staff. We need time to develop safety plans. We're employers, and we need notice to be ethical employers.
Indeed, thank you so much for your testimony, Ashley. Are there any questions for Ashley? We're going to go on to Crystal Jones.
Hi, everyone, and thank you so much for allowing us to speak today. So I did want to discuss how the multiple policy changes have affected our family. I'm currently assisting my nephew, who I have been raising with his self-directed services. Last year, there was a policy update regarding his day-to-day administrative position. We reached out to his CCS, who is the only one who can submit his plan to DDA. She was actually unaware of the policy change. So after multiple phone calls and emails, I requested to speak with her supervisor, who was also unaware of the policy change. So we I pretty much called and emailed and begged DDA to the point where it got to one day where I just called repeatedly. And I mean upwards of 20 times back to back until someone answered the phone. And I asked her, please reach out to his CCS and her supervisor so that they could be aware that the policy has changed. This took 2 months with his non-family day-to-day admin staff waiting for pay. I paid her out of pocket once, which was all that I could afford to do. And then she quit 2 months later, since we still did not have any changes. During this time, during this particular stressful time, about 2 months later, I ended up having a mini stroke. These changes are exhausting. We are literally trying our best to manage the staff, to manage our personal lives, and to make sure that our loved ones are taken care of. I am asking to please support the bill so that not only family, but the CCSs and their supervisors and anyone else who is in charge of changes has time to learn them. Thank you all so much.
Thank you so much for your testimony. Are there any questions? Seeing none. Next, we're going to hear from Ms. Babbitt Smith. Babbitt Smith? Oh, there you are. Thank you so very much. Babbitt, you have to take it off of mute. You're still on mute. We're getting close. We're getting close. All right. No, we still can't hear you on this end. I still see the little mute icon. It should be at the bottom of your screen there.
I'm asking her to unmute, that's all I can do. She can hit, was it the space bar and some kind of...
Space. All right.
So if she touches the space bar, sometimes that helps.
If you touch the space bar, see if that will help you.
Space bar.
You touch it.
Space bar and M.
Space bar and M, maybe. It's one of those moments where you need a Geek Squad. Babbitt, why don't you give it a chance? You keep trying. We're going to go to the next person, then we'll come back around to you. If there's anyone there that could help you, but we'll give you a couple of minutes while we go to, is this Matt Rice? Matt Rice, if you would go ahead with your testimony, and we're going to come back to Babbitt.
Thank you, Honorable Chairperson, members of the committee. My name is Matt Rice. I'm the Executive Director of People on the Go Maryland, which is Maryland's statewide self-advocacy organization for people with developmental disabilities. I'm here to testify today in support of SB 583, which proposes to allow for a public comment period on the self-directed service manual. We are proposing some amendments to the bill, which would make it apply to people in all DDA service models, not just self-direction. And we feel that this is a necessary step in order to ensure accountability and transparency, which is badly needed at this time. Our amendments also include some language around plain language and some guidance around what that would look like. I'm not going to belabor all of the technical points. You have our written testimony. What I will say is we are also in concurrence with the Developmental Disabilities Coalition and their amendments. And where I think we would differ with our coalition colleagues is even if our proposed amendments do not pass, we believe the bill should pass as originally drafted because it is a needed step towards accountability, as I mentioned before. With that, I hope for a favorable report on the bill as amended. Thank you.
Thank you so much for your testimony. Is there any questions for Matt? Seeing none, we're going to try to go back to Babbitt. Look like you have your phone. Can you give it a test to see if we can hear you? Babbitt? No?
It's frustrating.
Yeah. Babbitt Smith, can you hear us? Ms. Smith, can you try to say something? I don't see the mute symbol no more. Maybe we could hear you. No? All right, you're in. Miss Smith, you want to start talking? See if we could hear you?
She's trying.
Yeah, she's not moving her lips.
I'm not sure if you're able to hear us.
Yes.
Can you hear me?
We can hear you. We can hear you.
Okay,
That's great.
I
Perfect.
cannot hear you. I apologize for the technical difficulties. My name is Babette Smith. This is my daughter, Melanie Smith. We're coming to you from snowy Garrett County, although Melanie just told me that she wishes she was there. She is quite at home in front of the camera and speaking, and I'm not. I've rewritten this testimony several times as I've listened to everyone else. I appreciate all of the previous people who have spoken. They've done a great job of telling you about the changes and how often they've happened. So we decided to go another route and just quickly tell you about how it can personally affect one person. So we received the the original manual. I found it in my email as we were traveling on vacation. It was not good reading for vacation. One of the changes that we noticed was that a support broker, you can find the definition of what that does, I'm sure, without me explaining it, could not also provide any service to the same participant for whom they were a support broker. This was not in the manual, or in the waiver. The waiver said that you could not provide any other services to that participant. So in trying to research this, we found out that Melanie's support broker also provided direct support to another individual, which meant he was ineligible to continue being her support broker. Those two duties were totally unrelated. And I reached out to DVA requesting guidance on this. And the only thing they said was, please see the manual. That was our response. And this was finally rescinded in May, which did not let us have time to keep him. We had to find a new support broker. So these changes look bad even in paper, but they're more, they affect our people more than they do the paper. So we do ask that you support this bill, please, to give notice so that these changes can be made with appropriate time for individuals like Melanie to take them into consideration and to continue to live her life. Thank you.
Thank you so much. I'm so glad you got through those technical difficulties. Does anyone have any questions?
Why it's not letting me.
Thank you so much, Ms. Smith, for your testimony today. And now we will hear from Ms. Ann Smith.
Hi. Good afternoon, Senator Jennings and other members of the committee. My name is Ann Smith. I'm from Towson, Maryland. My son, Patrick, is 28 years old. He suffers from autism and mental retardation along with other needs. I want to let you know that I do support the bill, but as far as I'm concerned, it does not go far enough. DDA, as other people have mentioned, recently notified us of changes by email on February 3rd and said they went into effect immediately. And this was notified email. It said it was in 20 different categories, and you had to go to each link by link by link, and it opened up even more things. That it took me just to look up one thing, it took me quite a long time to read. Some which affected my son directly, like assistive technology and behavior therapy, to name a few. We waited over a year and a half to start behavior therapy. It has been very beneficial for Patrick and my family. We are very excited to see, we just started assistive technology, and we're excited to see where that takes off. But we hope we don't lose that right now. And I'm asking you to extend from just the manual to any changes made by the DDA. It must include this 90 days and be given, to the community for input. If you examine this email sent on February 3rd alone, you can see how detailed it was. And while you're taking care of your loved one, reading all these detailed emails and manuals takes time, as you could see from those 1,000 pages. I'd also like to mention DDA even my son's, I'm running out of time, but my son's plan was held by the DDA for 2 months and it went out of time. And we had to resubmit his plan because the DDA did not act on it. And it was all put back in our lap to resubmit his plan. So the DDA is the one sometimes that holds up everything, like other people have mentioned. Again, Senator Jennings, and thank you so much for your support.
Thank you so much for your testimony. Colleagues, are there any questions of this panelist? Seeing none, this ends the hearing on Senate Bill 583. I will be turning it back over to Madam Chair Beidel.
Thank you, Mr. Vice Chair. Okay, what are we doing? This one, okay. Senator Mounts, we are going to hear Senate Bill 611, Maryland Department of Health, Study of Maryland Medical Assistance Program Reimbursement of Hospice Room and Board. You are having Peggy Shimoda from Hospice and Palliative Care Network of Maryland and Kristen Bryce, University of Maryland Medical Systems, maybe.
We've got.
And Jake's at the table. How about Heather Guerrieri, Compass Regional Health? Is Heather here? And Carlos Graverian, LifeBridge Health.
Hey, good to see you. Thank you. Kristen, thank you for being here.
You just get everybody up at once, right?
Hey.
Did you want me here, Senator?
Sure, absolutely. I'll stand right over here.
I can move down.
Oh, that's good. Yeah, that's good. We got the hard stuff.
I think we're
Senator, as soon as it quiets down, you can start.
Thank you, Madam Chair. Is the microphone working okay? Madam Chair, Mr. Vice Chair, who just left the room and sure will be back, committee members, Senator Johnny Mouse, District 37. It is a great honor for me to present Senate Bill 611. We've got a terrific panel that will get into the details of what this legislation is, the nuances, but I just want to remind the committee, this is a study bill. This bill will look at the use of hospice and respite care and have that be reimbursable through Medicaid. I know there is some opposition testimony citing that this type of care is not covered by Medicaid. I just want to remind everybody in the committee that while that testimony is there, this care is reimbursed in 25 other states. And it is an enormous burden on hospitals, and there's a great potential. We have a great hospice network. And so with that, I'd urge a favorable report, and I'll turn over the details to our expert panel. So with that, Madam Chair, whichever witness you would like us to begin with, Kristen, do you want to go? You want to start first, Peggy? Sure.
Okay, let's start with Peggy, and we'll just go right down the aisle. Okay,
Perfect, thank you. Is this on? Okay. Okay, great, thank you. Okay, well, good afternoon, Chair Beidel and members of the committee. For the record, my name is Peggy Shimoda. I'm the Executive Director of the Hospice and Palliative Care Network of Maryland. You have my written testimony, and I would just like to touch on a few highlights of this bill. So the network is in strong support of Senate Bill 611, which calls for a very thoughtful, data-driven study of Medicaid reimbursement for hospice house room and board services in Maryland.
So first, it's important to clarify that hospice houses are not hospital inpatient units. General inpatient or GIP care is short-term, hospital-level care for acute symptom crises. Hospice houses, by contrast, are residential, home-like settings for patients who cannot safely remain at home but do not require hospital-level care. They are lower intensity, comfort-focused environments. Under the current policy, Medicaid covers the hospice benefit itself, meaning that interdisciplinary team services, medications related to the terminal diagnosis, equipment, and supplies, regardless of the setting. However, Medicaid does not cover room and board in a residential hospice house. As a result, patients must pay privately for the room, which places this option out of reach for many low-income Marylanders. Research consistently shows that hospice enrollment is associated with fewer hospitalizations, fewer emergency department visits, and lower overall spending, particularly when hospice begins earlier. A carefully structured room and board benefit could support safer discharges. So for this and for other reasons, the reasons I've mentioned, we respectfully request a favorable report for Senate Bill 611. Thank you.
Chair Beidle and members of the Senate Finance Committee, thank you for the opportunity to provide testimony in support of Senate Bill 611. My name is Carlos Graverin. I'm the Assistant Vice President for Bridging Life Palliative Care and Hospice, the member of the LifeBridge Health System. Current Maryland Medicaid hospice reimbursement structures are multi-layered and administratively challenging. Hospice services for terminally ill individuals are covered under Medicaid when physician certifies life expectancy of 6 months or less, but room and board payments, as Peggy mentioned, are not included. Reimbursement for room and board for Medicaid beneficiaries residing in nursing homes involves pass-through arrangements that complicate cash flow and operational consistency for providers. These payment complexities can result in delays and fragmented funding, creating barriers to smooth service delivery at a time when continuity is critical. Maryland HEAD model seeks to advance health equity and improve care delivery while controlling cost and emphasizing value-driven care across the continuum, not solely in hospital settings. Hospice and palliative care services are intrinsically aligned with these objectives. Better care, hospice, and palliative care promote whole-person, patient-centered approaches that uphold quality of life through coordinated pain, symptom, and psychosocial support, cost controls by supporting beneficiaries in appropriate settings such as hospice homes and community residences. These services help avoid costly acute care admissions and prolonged hospital stays at end of life. Health equity and community-centered delivery. Hospice care models can be tailored to meet cultural, linguistic, and social needs, increasing accessibility and reducing disparities in end-of-life care. This study represents a necessary and pragmatic first step towards better understanding of how Medicaid reimbursement for room and board in hospice services could improve length of stay, reduce hospital deaths, and improve quality. We urge you to support a favorable report on SB 611.
Good afternoon. My name is Heather Guerreri, and I'm the CEO of Compass. We serve Queen Anne's, Kent, and Caroline counties on the Eastern Shore. Today, Medicaid beneficiaries in Maryland often lack a meaningful choice at end of life. When room and board are not covered in hospice residential facilities, many patients are left with only one option, a long-term care facility, even when hospice residential care would better meet their medical, emotional, and personal needs. This legislation would change that. By allowing Medicaid reimbursement for hospice room and board, patients would be able to spend their final days in a setting focused on comfort, dignity, and family-centered care without the burden of out-of-pocket costs. for the most vulnerable in the state of Maryland. Hospice residential facilities are regulated healthcare providers, and hospice teams specialize in end-of-life care for both patients and their families. While federal Medicaid rules limit room and board payments, states have the flexibility, and several, including New York and California, are already implemented CMS-approved reimbursement models. SB 611 would align Medicaid policy with patient choice, quality outcomes, and compassionate care at the end of life. For these reasons, I respectfully urge a favorable report for SB 611. Thank you for your time and consideration.
Great. Thank you, Madam Chair and members of the committee. I'm Jake Whitaker on behalf of Maryland's hospitals and health systems, here to testify in strong support of Senate Bill 611. MHA supports Senate Bill 611 because hospitals see every day how critical it is to place patients in the right care setting, especially at the end of their life. When Medicaid doesn't cover room and board in hospice houses, patients ready for comfort-focused care often stay in hospitals longer than is compassionate or clinically necessary. And as you know, hospitals do everything they can to serve patients, but they're just really not designed for this type of care. So even with the most caring staff, the hospital environment with just the hustle and bustle, the clinical rotations and everything going on, it just may not be the right location for patients. And so we believe that hospice houses offer a more appropriate environment for those patients, but we understand that Medicaid still represents a reimbursement barrier for this transition. When one patient can't be placed in the right setting, it doesn't just impact that patient, it also has an impact on other patients in the hospitals as well. So for example, when a patient who cannot be transferred to a hospice house continues to occupy a hospital bed, other patients can't be transferred to that hospital bed, and that just drives up ED wait times and other throughput issues. And unfortunately, because the Medicaid program only allows for reimbursement for skilled nursing facilities, oftentimes folks are transferred there not because it's the right place, but because that's where they're getting reimbursements for. And so we do think that Senate Bill 611, although it's studying an important topic, it is taking a responsible, methodical approach by really studying this issue before just diving in. So we just want to say that we really appreciate Senator Moutz's leadership on this issue, and we respectfully request a favorable report on this bill. Thanks.
Thanks. Good afternoon, Madam Chair and members of the committee. For the record, Kristen Jones-Bryce, Chief External Affairs Officer for the University of Maryland Medical System, here in strong support of Senate Bill 611. I'd like to think, right, that Maryland hospitals do a lot of things really well for the communities we serve across the state. We provide life-saving care in emergency rooms and trauma centers for people who are critically ill or injured. We deliver babies, and we treat all kinds of life-threatening conditions, including cancer, cardiac disease, and neurological conditions, just to name a few. Acute care is, in essence, our sweet spot. It is our area of expertise along the continuum of healthcare delivery. Fortunately, there are other providers along the healthcare continuum that are also great at what they do. Think about primary care providers, long-term care providers, and hospice providers. As we've heard, hospice providers deliver care in a variety of settings, most often in a home, sometimes in nursing homes and assisted living facilities, sometimes in a hospital, and in hospice inpatient facilities. Currently, Medicaid enrollees in Maryland have access to all but one of these options. I am not an expert on this by any measure, but I asked my friend ChatGPT to aggregate survey findings about settings in which people say they would prefer to die, and I learned that 60 to 80% of people say they would prefer to die at home, 10 to 20% in a hospice facility, 5 to 15% in a hospital. I thought we did better than we might have, and 5 to 10% in a nursing home. And then among those who are seriously ill or close to the end of life, the preference for inpatient hospice increases. It's not surprising that people want to pass in a familiar place, surrounded by familiar things and people who love them. For many reasons, though, dying at home is not always an option. For the hospital's part, in addition to not being a setting of choice, acute care facilities are expensive and they contribute to a healthcare system where cost is already borne disproportionately on the back end of life. For this and many other reasons, we urge your favorable support of Senate Bill 611. Thank you.
Thank you. Obviously, people are out in other committees, but I guess I don't understand, this is all part of what the HEAD model decides to pay, and we don't pay hospice residents?
I will defer to my hospice colleagues down. My understanding is this is a federal rule that applies to Medicaid programs across the country.
Oh, I thought somebody said that CMS has approved it in another state.
I did.
Okay.
And it wasn't through anything like the HEAD model, though. It was through different amendments, state amendments and/or contracts with hospice residential facilities and the state.
And that was only one?
Well, there's multiple states, but the ones that I cited were California and, New York.
Okay.
Yeah.
It just seems strange that, someone's residing in a hospital and you can't get payment.
Right.
So,
Yeah.
thank you for that. I don't see any other questions. Thank you very much to this panel.
Thank you.
Thank you.
That ends the hearing on Senate Bill 611. I see Senator Hester's here. She's going to do Senate Bill 602 for us. This was a prior introduction, so we're going to have two proponents and two opponents. So Senator, you want to bring up Christine McComas, favorable? And let's bring up Ann Geddes, favorable with amendment. Let's have everybody. That's everybody. You don't have any opposition, Senator.
Thank you, Madam Chair, members of the committee. For the record, Senator Katie Fry Hester, here to seek your consideration of Senate Bill 602. This bill aims to establish the Algorithmic Addiction Fund as a special non-lapsing fund to receive settlements from lawsuits against social media companies and invest those funds in research, prevention, intervention, and treatment of addictions. As this committee knows, Maryland's children are facing a growing public health crisis, driven by deliberately engineered social media platforms designed to maximize engagement at all costs. Social media companies have increasingly built business models around attracting, retaining, and monetizing minor users. The consequences are measurable and alarming. According to the Pew Research Center, as of December 2025, over 1/3 of teens report using at least one social media platform almost constantly. In 2025, the University of Michigan found that adolescents and young adults average nearly 7 hours a day of daily screen time. That same study found that 60% believed they were addicted to their phone, 73% reported worsened sleep due to social media, 72% reported negative effects on their self-esteem, and 72% believe social media affects them overall negatively. In my testimony, there's several examples from high-profile cases that have gone forward. I'll just touch on one. There are countless examples of teens battling with social media addiction, but not all of them, survive. Lori Schlott, a mother from Colorado, lost her daughter Annalie to suicide that she believes was related to algorithmic addiction. Annalie spent countless hours online with an algorithm curated based on the pain she was struggling with. Her Instagram was flooded with content encouraging self-harm, downplaying the possibility of help, and glorifying suicide as a way out. Colleagues, this is completely unacceptable. Major social media companies, including TikTok, Meta, and YouTube, are now facing extensive litigation from individuals and from states, including Maryland, who allege they were harmed as minors by deliberately addictive platform features. The plaintiffs report experiencing anxiety, suicidal ideation, body image disorders, and other serious mental health challenges after beginning to use these platforms at a very young age. Many parents involved in these lawsuits state they were unaware of the addictive design mechanisms embedded in these products and would not have permitted access if they understood the risks. This growing body of evidence and litigation underscores a critical reality. When corporations manufacture addictive digital environments for children, the resulting harms require a coordinated public health response. So that's where this bill comes in. 602 provides a response that mirrors Maryland's successful approach to other large-scale public harms. The Algorithmic Addiction Fund is modeled after the Opioid Restitution Fund, which directs the settlement funds from prescription opioid manufacturers and distributors towards treatment and prevention efforts. As of fiscal year 2025, that fund has received over $192 million and has strengthened Maryland's response to the opioid crisis by ensuring accountability and dedicating resources to recovery. Senate Bill 602 establishes the Algorithmic Addiction Fund as a similar non-lapsing fund to receive civil penalties and settlements resulting from litigation related to harm caused by social media platforms and improper use of algorithms. Rather than allowing these funds to be absorbed into the state's general budget, this bill ensures they are directed into prevention, intervention, research, and treatment efforts. So specifically, Senate Bill 602 establishes the fund held by the state treasurer and administered by the Department of Health to receive civil penalties from judgments or settlements concerning harm to children for social media use. It authorizes the state to seek and receive additional funding sources, including federal grants such as those offered by the Substance Abuse and Mental Health Services Administration, to address algorithmic addiction comprehensively. It requires the Secretary of Health to establish measurable goals, objectives, and indicators aligned with the U.S. Surgeon General's call to action, including conducting a statewide needs assessment and supporting ongoing research, expanding access to evidence-based mental and physical health services, developing prevention initiatives, creating a comprehensive system of intervention services, and consulting annually with stakeholders, including consumers, providers, families, and advocates, to ensure the responsible and targeted use of these funds. Senate Bill 602 ensures that if the state prevails in pending litigation against social media companies, any settlement or judgment funds will be dedicated to addressing the harm those companies have caused. When corporations design products that knowingly foster addiction among minors, the financial recoveries should be reinvested in the children and families who have suffered the consequences, not absorbed into general revenue. I do have an amendment that I believe was sent to the committee. Basically, this amendment says that any remaining funds should go into the fund, the Consortium for Community Supports, which is working on mental health through our school system. And so, colleagues, I urge your favorable report of Senate Bill 602. With that, you're voting for sound fiscal and public health policy, which ensures that the recovered funds go to support the youth and families in your districts. Thank you very much.
Thank you. Christine, you want to go next?
Sure. Good afternoon. My name is Christine McComas, and I'm the mother of Grace, for whom Maryland's Grace's Law Against Cyberbullying is named. We lost our joyful and kind-hearted child to suicide on Easter Sunday of 2012 at the dawn of smartphone and social media availability. The research now shows that cyber abuse is an independent risk factor for depression and suicidality, and the trajectory of smartphone and social media adoption tracks very closely with the alarming decline in child mental health. The monies collected in this fund are needed. I'm a member of Parents SOS. We've all lost children. Lori Schott is in that also. We've lost children to different social media harms and worked together for change, like we've been working for years for the Kids Online Safety Act at the federal level. When Mark Zuckerberg and other big tech CEOs were called to account for their harm to children, we were there. And in the last 2 weeks, we have been at the first landmark social media addiction trials as they began in LA. I hope you'll watch the link within my written testimony for our vigil that was held on the courthouse steps, which was covered worldwide. Witnesses and documents in these trials make clear that executives at these companies were very aware of the harm being done, but time after time chose profit over safety. I'd like to suggest that the title of the fund be changed to be Algorithmic Protection and widen the help offered. For instance, over the years, I've been shocked at Grace's Law 2.0 and its many protections are not known as they should be, nor used properly. There have been multiple cases where school admins, local police, and DJS have failed children and families in distress. For instance, through Grace's Memorial page, I received a chilling phone call from a Maryland mom who'd been contacted by the Maryland Internet Crimes Against Children Task Force with the state police and the National Center for Missing and Exploited Children that her child was on XXX porn websites. Child sexual abuse material, also called CSAM, was made by using AI, taking her head from a family vacation photo as a preteen and attaching it to the body of another person featured on the website, the XXX porn site. Some of the men paying to get into the website were also paying to supposedly interact with her fake persona in lewd chat rooms. Shockingly, one of these men used reverse facial recognition to find this child in real life and was trying to contact her, which obviously threw the family into deep crisis, with the child hiding in closets and their pantry anytime just someone came down the driveway to make a delivery. An investigation found that it was a high school classmate well known to police who was spoofing multiple girls across multiple sites and was using his phone during school hours to do so. Grace's Law should have given this young man a meaningful correction, but local police did not use it to charge him. Thankfully, just last year, the deepfake AI portion of SB 360, sponsored by my Senator Hester, was passed to help, but much more needs to be done. I hope that you'll pass SB 602. Those funds will be needed.
Thank you. Thank you, Madam Chair and committee members. I'm Ann Geddes with the Mental Health Association, here in support of Senate Bill 602 with the amendment. As has been said, I could cite a ton of data about the worsening mental health of kids, children and youth across the country. I think the statistic that startled me the most was that 25% of Maryland middle school students have reported seriously considering suicide in the last year. Increasingly, studies show that the impact of excessive social media use has contributed to that worsening mental health, especially excessive social media use that is promoted by the algorithms that social media companies use. Maryland and other states have lawsuits outstanding, and if any funds come in from those lawsuits, it absolutely just makes sense for those funds to go to support and improve children's mental health. The amendment that Senator Hester referred to and that we support is, instead of excess funds going to the Department of Health, that they go to the Consortium on Coordinated Community Supports, which provides grants for school-based behavioral health services across the state. That the consortium grantees have shown outstanding outcomes in the few years that they've been in existence. Last year, they served over 137,000 students in 86% of Maryland schools, with really stellar outcomes and satisfaction on the part of both youth and families. So, you know, that program is really helping a lot of Maryland students, and the funding for that program has continually been at risk. Last year, the BRFA proposed cutting it by $80 million. This year, the BRFA proposes cutting it by $20 million, which is 20% of the funding level. So it would be really helpful if it did have a sustainable funding source so that these programs that are having such great effect could continue and we wouldn't lost gains made. Thank you for a favorable report.
Thank you. We do have some questions. Senator Kramer, who would you like to direct your question to?
To Christine, if I may. Hi, Christine. Just a quick question. Would you briefly expand just a little bit on evidence that the industry and the executives are and have been aware of the harm they're causing minors? Would you please just briefly address that?
Since 2022, this group of bereaved parents has been on Capitol Hill working for the Kids Online Safety Act, which would put up common sense guardrails like turning off geolocation and just very basic things that need to happen. But during the course of this, we've been at multiple Senate hearings and House hearings where the whistleblowers have come forward who were high up in the corporate structure. And with them, they've brought internal documentation that proves that any number of harms, they went to the higher people at the company and said, look, this is hurting people. This is hurting children. We could easily fix it. It wouldn't be that difficult. And time after time, they've chosen not to do that. Even when we were on Capitol Hill in 2024, with the leaders of TikTok and Discord and Snapchat, all of them, you know, Mark Zuckerberg was goaded into standing up and turning around and apologizing to us. We're all holding our kids' faces, right? But during that actual hearing, he even said he did not think social media was harmful to kids. And then he turned around and said that when someone said 13 and unders were being predators were going after them, he said, well, 13 and unders, I don't think we don't allow them on there. But some of the documents and witnesses that are coming out in the trial already, just in the first couple of weeks, make it clear that they knew there were millions of 13-year-olds on there, and they were going after them to collect their data, which then they turn around and sell for billions of dollars in ads that are aimed right at those kids that ages 8 to 12, they're not even supposed to be on there until age 13.
Thank you for all your work that you're doing.
Certainly.
Thank you.
Senator Gall, oh, you turned your, Senator Lamb? Nope, everybody? Senator Kramer, you did a good job.
Read my mind.
I don't see any other questions. Thank you, Senator Hester. Thank you for this bill. Thank you for the panel. All right, so next I see that Senator Harris is here. We're going to see him on Senate Bill 527, Public Health Bill. And I think, Senator, this is your first visit to Finance. Panel?
Yes.
Zachary Federico, Dylan Hager, and, Dylan and Chase are virtual. We'll bring them up as part of your panel. Thank you.
Appreciate that, Madam Chair, Vice Chair, and awesome Finance Committee. Appreciate the time. This is my second time here at the committee. Yes, absolutely. For the record, Senator Kevin M. Harris representing District 27, Prince George's, Charles, and Calvert counties, here to present Senate Bill 527, the Veterans Mental Health Innovation Act. A consequence of wars in Iraq and Afghanistan is that hundreds of thousands of U.S. service members sustain and return home with traumatic brain injuries. Repeated blast exposure can result in changes to brain functions, leaving veterans with chronic symptoms, including post-traumatic stress disorder and major depression disorder and anxiety disorder. Veterans often struggle to find treatment for their conditions, resulting in pain, suffering, and self-harm. Veterans make up about 20% of suicides in the United States, despite making up only 7% of the nation's population. The goal of Senate Bill 527 is to create a grant program that will fund clinical trials on the use of ibogaine to treat opioid use disorder and conditions. Ibogaine is a natural occurring psychoactive compound derived from the root bark of the ibogaine plant. Multiple studies have found that ibogaine treatments have significant impacts on decreasing disabilities associated with post-traumatic stress disorder, depression, anxiety, and opioid use disorder. We have included significant guardrails to guide the operation of the program and to ensure that the responsible use of taxpayer dollars. Grant funding can only be provided to eligible, reputable research institutions in the state of Maryland. We're not going to send our tax dollars to Virginia or Pennsylvania, and we're not going to give our tax dollars to an institution that won't deliver real results. Grant recipients must match state funds, and they may not use state dollars to support other clinical research. Grant recipients must send quarterly progress and financial reports to the department, and beginning in 2028, an annual report will be issued to the General Assembly. Funding for the ibogaine clinical research grant program will come from the Opioid Restitution Fund, and for fiscal year 2028 through 2030, the governor will include $500,000 in annual budget bill. Today, I ask the committee for a favorable report so that we can better support our veterans that sustain traumatic brain injuries, especially those that fought to protect us from terror in Iraq and Afghanistan. With that, I'll let my panel speak, and then I'll be happy to take some questions.
Thank you, Senator.
Chairwoman Beidel, Vice Chairman Hayes, and members of the committee. My name is Zach Federico, and I serve as the Director of the Veterans and Military Affairs Task Force at the American Legislative Exchange Council. Thank you for this opportunity to share ALEC's nonpartisan research and analysis as you consider this legislation to support clinical trials on the use of ibogaine. This issue has significant momentum in state houses across the country. 11 states are considering similar legislation, and West Virginia and Mississippi have already passed it through one chamber with overwhelming support. In December, the ALEC Veterans and Military Affairs Task Force unanimously adopted a similar version as model policy. These efforts represent a broad national movement to support emerging treatments for veterans who are struggling. Unfortunately, traditional PTSD treatments are limited at best. Trauma-focused therapy, the VA's recommended first-line treatment, has an estimated dropout rate of 27.1%. For those who complete the treatment, around 50% still meet diagnostic criteria for PTSD. Second-line treatments involving FDA-recommended medications only achieve remission in about 20 to 30% of patients and often cause adverse side effects. This reality has led many veterans to seek alternative treatments, including ibogaine-assisted therapy, in countries where it is not regulated. In many cases, the results have been life-changing. There's no shortage of anecdotal stories from veterans who've experienced complete remission from PTSD and other neurological conditions after a single session with ibogaine. In 2024, Stanford Medicine published a study that found an 88% reduction in PTSD symptoms for combat veterans after a single session. While encouraging, these results demand deeper and more rigorous investigation. These developments have spurred state legislators across the country into action. Since clinical trials on Schedule I substances are expensive, and naturally occurring substances like ibogaine have little to no profit motive for pharmaceutical companies, state governments are working together to fund these clinical trials. By joining this national effort, Maryland can help deliver real hope to veterans by advancing responsible, evidence-based research. Thank you for your time and attention. I'm happy to answer any questions.
Thank you, Zachary. We're going to hear from the virtual panelists first, and we'll see if there's questions. So Dylan Hager?
Yep. Can you hear me?
Dylan? Yes, we can.
Perfect. Distinguished members of the committee, my name is Dylan Hager, and as a U.S. veteran, I'm testifying today on behalf of the Law Enforcement Action Partnership, or LEAP, in support of Senate Bill 527, the Veterans Mental Health Innovations Act. This legislation would allow for research institutions in Maryland to participate in FDA-regulated clinical research into ibogaine as a potential treatment for veterans living with serious treatment-resistant conditions. LEAP is an international group of police, prosecutors, judges, and other criminal justice professionals who speak from firsthand experience serving the justice system. Our mission is to make communities safer by focusing law enforcement resources on the greatest threats to public safety, addressing the root causes of crime, and working towards healing police-community relations. I previously served for over a decade with the Colorado Department of Corrections, rising from correctional officer to major. During my time in prisons, I saw firsthand the consequences of untreated trauma, post-traumatic stress, traumatic brain injury, and substance use disorders. These conditions do not stay contained within individuals. They ripple out and affect families, communities, and institutions, including the disproportionate number of veterans who we housed that struggled with these same issues. This mental health crisis is especially acute amongst veterans. According to data from the Department of Veteran Affairs, approximately 17 veterans die by suicide each day. Many others live with treatment-resistant PTSD, traumatic brain injury, and addiction that have not responded to existing therapies. As a corrections leader, I learned that maintaining the status quo in the face of clear suffering is not neutral. When traditional approaches are not enough, we have a responsibility to examine credible alternatives through structured and accountable processes. I speak from direct experience and have witnessed how a carefully administered option like ibogaine can offer a path to recovery where others could not. Senate Bill 527 does not shortcut science, but rather engages it. It creates a structured FDA-regulated pathway to rigorously evaluate ibogaine, a naturally derived treatment that benefits individuals facing severe treatment-resistant conditions according to early research. There's sound evidence that intervention could reduce suicide risk, addiction, and long-term instability among veterans. Then a careful clinical evaluation is a responsible, measured step. Thank you for your time and your consideration.
Thank you, Dylan. Next, we'll hear from Chase.
Thank you, Madam Chair, and rest of the members of the committee. My name is Chase Rowan. I'm a former Army Ranger. I served 3 years in 3rd Ranger Battalion. In 2005, I deployed to northern Iraq in support of Operation Iraqi Freedom. Shortly after returning from deployment, literally 3 months after, I was injured in a nighttime airborne training operation. I suffered a severe traumatic brain injury, had 8 staples to the back of my head, bleeding in the brain. And the first thing the doctors did was put me on opiates. So that was the beginning of a 17-year-long substance use disorder where I struggled tremendously. In 2016, I attended my first inpatient rehab center, 4-week rehab, relapsed within a week of getting out of that. And then 2018, I returned to another rehab center. And shortly after leaving that one, I relapsed again as well. And at this moment, I said, there's nothing that can fix me. If rehab can't fix me, nothing can. I then fast forward to 2022, and I unfortunately overdosed on fentanyl. Yes, I got that far into it. And it was 3 months after that, before I was about to take my own life. I was convinced. I had my suicide letters written and everything. And I heard about Ibogaine on the Joe Rogan podcast with Dakota Meyer. And instantly, I just had a whole huge wave of hope that overtook me. And I traveled to Mexico in 2023, sat with Ibogaine and 5-MeO DMT, completely changed my life. This coming March, I celebrate 3 years sobriety. So these medicines work. You know, it has completely altered and shifted my perception of drugs and alcohol. I now see them as complete poison. I don't see any benefit to any of them. And if everybody, and not everybody, but if people could get just 1% of the experience I had with these medicines, we would see a dramatic shift. So that is all I have to say. These medicines saved my life, and they continue to save so many others' lives. So thank you for your time, and enjoy the rest of your day.
Thank you for your testimony. So committee, do I have any questions for this sponsor or anybody on this panel? I don't see any questions. Thank you, gentlemen. We do have one, Caitlin Becker, the Reason Foundation.
It should be Jeffrey Lawrence from Reason Foundation.
Okay, so it's still, so Caitlin's not going to testify?
No, she's not.
Okay, thank you. Go ahead.
Okay, sure. Thank you, Madam Chair, members of the committee. My name is Jeffrey Lawrence from the Reason Foundation. We are a public policy think tank. We became interested in Ibogaine because very recent research has shown that it has a unique ability to generate healthy brain tissue or to repair damaged brain tissue. That has a lot of implications for serious diseases, neurodegenerative diseases, traumatic brain injury you've heard about, also opioid addiction. One of the reasons that opioid addiction is so hard to overcome is because the opioid addicted brain is no longer able to generate key neurotransmitters like dopamine and serotonin at sufficient levels without continued administration of opioids. And so the existing treatments that are out there, primarily methadone and buprenorphine, just give a measured dose of opioids to people until their brain has had time to heal, which typically takes 18 to 24 months. So it's a very long recovery period. And it has, because it takes so long and people have to have, a measured dose once a day, it has very low success rates. People don't see the program through to completion. So depending on the study that you read, the effectiveness of these existing treatments ranges between 18% and 31%. These are primarily financed by state Medicaid programs because people go through them so often. One person will go through more than once typically. State Medicaid programs will spend roughly $130,000 per person who's trying to recover from opioids. Ibogaine is a complete game changer because within a few days of a single administration of Ibogaine, it repairs a person's brain to the point that they are able to overcome the physical withdrawal effects of opioid addiction and gives them a window to recovery. I'll stop there.
Thank you. Very interesting. Thank you for that testimony. I don't see any questions. Thank you for your testimony. That ends the hearing on Senate Bill 527. Next, we're going to have Senator Charles, Senate Bill 550. I have to find it on here. Senator Charles, you have a panel.
Yes, ma'am.
Darlene Enshield, Teresa Smith, and Dolores Millhouse. This is Senate Bill 550, Healthcare Decisions Act, surrogate decision making.
Good afternoon, Chair Biodo, Vice Chair Hayes, and the honorable members of the committee. For the record, my name is Senator Nick Charles, representing Legislative District 25, and I'm testifying in strong support of Senate Bill 550. There will be an amendment coming to the committee to add the title HER, Parity Act, and that stands for Healing, Equity, and Representation. Senate Bill 550 corrects a gap in Maryland law involving medical decision-making when a patient loses the capacity to understand or communicate treatment choices due to a serious mental disorder. Today, if a person is unconscious, delirious, or suffering from a physical condition that prevents informed consent, a legally recognized surrogate may step in and authorize treatment. And when we say surrogate, this is already clearly defined in law to protect the patient. And the definition includes a guardian, the parent, the patient's spouse, or a member of their immediate family. But if that same incapacity is caused by a psychiatric crisis, families and doctors are often prohibited from acting. In practice, this means Maryland treats mental health differently from every other form of health care. The result is predictable. A patient is brought to the hospital in crisis. The doctors know what treatment is needed. The family understands the patient's wishes, but no one can legally move forward. So the patient waits, symptoms worsen, and what should have been stabilization becomes escalation. Hospitals across Maryland report that this delay leads to prolonged emergency room boarding and longer hospital stays, not because treatment is controversial, but because the laws prevent anyone from consenting on the patient's behalf when the patient cannot do so themselves. Families who are allowed to authorize cancer treatment or surgery for a loved one are told they cannot authorize psychiatric stabilization for that same person. In Prince George's County alone, 1,250 readmissions account for nearly $21 million in preventable spending annually. Each year, approximately 8,200 individuals recycle through Maryland hospitals after around day 30 of their release because their family advocates are excluded from the discharge and stabilization process. These are not isolated cases. They are systemic consequences of a legal barrier that delays treatment until crisis escalates. The bill simply puts mental health on the same legal footing as physical health. Importantly, Senate Bill 550 does not expand involuntary commitment, and it does not remove safeguards. Capacity must still be certified by clinicians. Surrogates must still follow the patient's known wishes or best interests. And if a patient actively refuses treatment, existing civil commitment procedures still apply exactly as they do today. And to further address concerns raised by stakeholders, we will be sponsoring other amendments to strengthen protections, including explicitly prohibiting surrogates from authorizing electroconclusive therapy or psychotherapy without a court order or advance directive, requiring court authorization when a surrogate's decision conflicts with the patient's express refusal or involves life-threatening risk, clarifying that the authority of existing clinical review panels for involuntary committed individuals supersedes surrogate authority, and establishing additional disqualifying criteria for potential surrogates, including individuals with a documented history of seeking involuntary treatment for that patient. What this bill does is it provides a medical pathway when a patient is unable to decide, not unwilling. Right now, the only alternative is often guardianship, a court process that can take months. And a psychiatric crisis, it does not operate in those manners. It does not operate on a court calendar. Treatment delayed is recovery delayed. And recovery delayed often becomes another hospitalization and another emergency visit or involvement with the justice system. Maryland is lagging behind the national standards. States such as Virginia, Maine, and Illinois already allow surrogate parity, recognizing mental health emergencies as medical emergencies and removing discriminatory barriers that prevent timely stabilization. Senate Bill 550 brings Maryland in line with these modern practices. Opponents have raised concerns about patients' rights, and those concerns are important, which is why we are bringing forward amendments that strengthen protections and clarifies oversight. With those safeguards in place, the bill preserves due process while addressing the real gaps in the current law. Today, the system does not protect autonomy when a patient cannot process information or communicate decisions. It leaves patients stranded in a crisis while everyone waits for legal permission to provide care. Senate Bill 550 ensures rights remain intact while allowing treatment to occur in real time so patients can recover and regain their own decision-making capacity. The bill recognizes a simple truth. Mental illness is an illness. When a person cannot speak for themselves, the law should not silence the people who know them best and clinicians trained to help. Senate Bill 550 brings consistency, compassion, and common sense into alignment. It allows stabilization before deterioration, treatment before trauma, and recovery before repeat crisis. For those reasons, I respectfully request a favorable report on Senate Bill 550. Today on my sponsor panel, I have Ms. Teresa Smith, a District 25 constituent that brought me this bill at our pre-session town hall. She is a mother of an adult with disabilities. We also have Ms. Dolores Millhouse, another District 25 constituent with Maryland American Mothers and the 2026 Maryland Mother of the Year. And finally, we also have Ms. Darlene Enchel from Luminous Health, Anne Arundel Medical Center. I pass it on to my panel. We're going to start with Ms. Teresa Smith, who brought the bill forward.
Good afternoon, Chair and members of the Finance Committee. My name is Teresa Smith. I'm here today as a mother of an adult child with multiple disabilities to talk about the cost of silence, as I am in strong support of SB 550, the HER Parity Act. Maryland is currently funding a cycle of fiscal waste. When the law bars surrogates from authorizing mental health treatment, even when holding an advanced health care directive, the system essentially forces decompensation. Other states have already addressed this issue, updating their laws to empower surrogates and maintain continuity of care for mental health treatment. Maryland is lagging behind, and we are paying the price. Without early intervention to maintain stabilization, my child was funneled into the most expensive care, multiple ER visits, acute hospitalizations, and months of partial hospitalization. As a mother whose child's mental illness onset during their transition to adulthood, I have experienced the system ignore me, one person who knows my child best, in order to work with the treatment team. By blocking me from a crisis, the state is not protecting my child's autonomy. It is effectively abandoning them to involvement with the criminal justice system, placing an immense preventable financial burden on our state. Guardianship is not the solution when a patient can regain competency and capacity. We need a system that honors a patient's wishes through an empowered surrogate. SB 550 ensures that mental health is treated with the same legal and fiscal common sense as physical health. I respectfully urge a favorable report on SB 550. Let's stop spending state resources on predictable failures and catch up to the standard of care that our most vulnerable adults deserve. Thank you.
Good afternoon, Madam Chair, Vice Chair, and members of the Finance Committee. My name is Dolores Britt Millhouse, and I'm a resident of Legislative District 25, and I currently serve as the 2026 Maryland Mother of the Year with American Mothers. I'm testifying here as in my individual capacity in support of Senate Bill 550 and in support of Ms. Teresa Smith and Senator Nick Charles' leadership in advancing this important legislation. My statewide platform focuses on strengthening families, building community capacity through education, and advancing youth mental health while reducing stigma around seeking care. Under current Maryland law, when a person has been determined incapable of making informed medical decisions, their authorized surrogate may consent to most medical treatment, but not treatment for mental disorder. The distinction creates unnecessary delays during moments of crisis. I have personally seen the impact of those delays. When families are trying to stabilize a loved one, time matters. Legal barriers should not stand in the way of appropriate mental health care. As also a certified adult and mental health a mental health first aid trainer, I am trained in early identification and timely intervention. Senate Bill 550 aligns Maryland law with the principle that mental health is health and should be seen as such. The bill maintains safeguards. It applies only after a formal determination of incapacity. It simply ensures the entrusted surrogate can act in the best interest of their loved ones, including for mental health care. I respectfully request a favorable report. Thank you.
Thank you.
Chairwoman Vital and honorable members of the Finance Committee, it is my honor to testify to you today in support of legislation sponsored by Senator Charles. My name is Darlene Enchel. I am a registered nurse by background, and I serve as a role as clinical director for case management at Luminous Health Anne Arundel Medical Center. Senate Bill 550 will positively impact the work that Luminous Health does to provide care to Marylanders suffering from behavioral health conditions. While I will keep my testimony brief, I hope it provides the committee members with a better understanding of how this small change in the Healthcare Decision Act can benefit mental health delivery in Maryland. This bill will enable Maryland hospitals to efficiently care for our vulnerable patients who suffer from behavioral health conditions. Every day, Maryland hospitals provide care to patients who have been certified to lack capacity and require another person to provide informed consent to healthcare services being proposed by the patient's attending providers. I have experienced the harsh reality of some of these patients that fit the profile. A patient has been certified to be incapacitated. The patient suffers from a behavioral health condition that requires expedient medical intervention. The patient has a family member available to make healthcare decisions for the patient. But under the current law, the patient's family member is prohibited from authorizing patient's treatment for a mental disorder. In these cases, Maryland hospitals are left with no other option but to seek the circuit court's involvement to appoint the family member as a patient's emergency guardian. Theoretically, this may seem simple, but in practice, it requires a significant amount in time and energy for hospital bedside providers and the circuit court staff. Moreover, this emergency hearing creates a stressful, even traumatic event for the patient in crisis, wherein the patient's family is treated as an adversary and must communicate to the circuit court in front of the patient why the patient's behavioral health diagnosis requires treatment. Passage of the Senate bill will eliminate the need of these traumatic experiences by allowing family members to work with behavioral health patients' treatment professionals to expeditiously deliver the treatment the patients need.
I have some questions for this panel. So Senator Washington?
Thank you, Madam Chair. And Senator, thank you for this bill. And Ms. Smith, thank you for your continued advocacy. You endured multiple of my community meetings to get in front of me to ask about this piece of legislation. So I appreciate that because I know you care so much about your family and friends. And just, is it true that you offered this bill to me first before you asked Nick Charles?
That is true.
That's a joke. No, I'm joking. In all seriousness, I was looking up some of the testimony from some of the folks here. I think it's the Disability Rights Maryland, and I want to just give you an opportunity just to be able to reply to some of the things that they said. In their letter in opposition, they said to permit a healthcare surrogate to make decisions about commitment and treatment of people with mental illness is an unacceptable encroachment of the right of persons with disabilities to not be subject to the decisions of others without the necessary medical knowledge, making significant decisions about their mental health treatment. Any comments to that statement from this group that anyone might have?
Sure.
Okay.
So, of course, we took a look at their opposition, and we are equally concerned about individuals abusing this authority. Right. So, Senator Charles has already mentioned some of the amendments that we plan to put forward to this committee to address those items. So, I understand that there are different other statutory
disagreements.
Disagreements in place. But our goal is to address that because we don't want the abuse to be in place. We definitely want to ensure that the person that's experiencing the episode, that their rights are still protected.
Right.
So
And so you're hopeful with those amendments that Senator Charles has proposed some of these groups will be favorable with amendments.
Yes.
Is your hope? Okay, thank you very much.
Senator Lang?
Madam Chair, and to follow up on Senator Washington's questions, could you just outline again what the amendments that you're considering? Because obviously they're not in the bill packet yet, but would be helpful to kind of have them as we're looking at the bill.
Sure, stand by one sec. So there are about 4 different amendments. One will be explicitly prohibiting surrogates from authorizing electroconclusive therapy or psychotherapy without a court order or advance directive. So that's number 1. Number 2, it will require court authorization when a surrogate's decision conflicts with the patient's express refusal or involves life-threatening risk. That's 2. And number 3, clarifying that the authority of existing clinical review panels for involuntarily committed individuals supersedes surrogate authority. And finally, establishing additional disqualifying criteria for potential surrogates, including individuals with a documented history of seeking involuntary treatment for that said patient.
Okay, that's helpful. Just a technical question then. So I know in the testimony that's been brought up, there have been multiple instances where this was designated as an authorized surrogate. Is the intention here that we're talking about individuals who have been designated as a surrogate when the patient still has the capacity to do so? Is that what is meant by?
It's when they're incapacitated.
Oh, so they would be incapacitated.
While they're incapacitated or going through a problem, psychiatric issue at the moment.
Okay. And then another kind of technical question. When I was looking at it, it's not really clear that a surrogate, in how this is drafted, could consent to psychiatric hospitalization. And it was the intention here that the surrogate could, because even right now, under current statute, I think a guardian can't even legally, consent to psychiatric hospitalization for someone.
Right, yeah, under the current statute, treatment for a mental disorder, a surrogate is not authorized to do that. So what this change will do is remove the treatment for a mental disorder and allow a surrogate to be able to address that. And when we say surrogate, back to the other portion of the law, it talks about a guardian of the patient's spouse or domestic partner, an adult child of the patient, a parent of the patient, an adult brother or sister of the patient, a friend or relative of the patient who meets the requirements. A friend or other relative may make decisions about health care for the particular patient. So when we talk about surrogates, we're not talking about random people on the streets. We're talking about folks that know these people. And when there is a crisis that is taking place, they would know this is out of character for these particular individuals. So we don't want to put them in a position where they can't get the help that they need. And this bill would allow for them to have somebody to advocate on their behalf when this crisis takes place. If not, they're sitting in the hospital waiting for something to take place. And I know you're a medical professional, and I don't know how many times you've had to deal with having some folks wait in the hospital, but I know the Maryland Hospital Association has come forward with a letter of support for this bill. And we also have Luminous Health here to speak on behalf of those issues as well.
Yeah, I saw that, and noted that as Senator Washington was mentioning, Disability Rights Maryland, I guess, has a letter of concern and opposition. The Department of Health is concerned as well. Office of Public Defender, and so I was just trying to figure out if there was a way to kind of ameliorate some of those. So last question here then, would you be open to some kind of a clarification in the bill that surrogates who could initiate psychiatric care would only be those surrogates that are already identified as part of an advance directive?
Yeah, and I'm fine with that.
You'd be open to that?
I'm open to that. The goal for this legislation is to meet folks where they are and address this issue, this complex issue, obviously, that's impacting folks across the state. And like I said, I'm so happy that one of my constituents brought forth this issue. And a lot of us don't know all of the problems that people are going through throughout our state until folks who've actually been impacted bring those things forward. And so I'm thankful to my resident who brought that forward, and I'm hopeful, prayerful that you all take this under true consideration, and we'll be bringing any amendments that you think needs to be brought forward.
Okay, thank you for bringing forward this. I know it's a challenging situation. Appreciate it.
So I have a question, Senator. It might be for you, and it might be for my senator on my committee. We gave the opportunity a couple years ago that people that are known to have mental illness can do an advance directive when they're, like taking their medication and of sound mind. Is this bill then, in the event that there is no advance directive?
If there isn't one, and that actually makes, because I'm glad you brought that up. I did not know that was an actual provision in law already. That may be something we can make an adjustment to that folks have advance directives, but if there is not an advance directive.
No, because there has to be something when there's not one, but it could be something that we need to, let people know that this is an opportunity. Because there are many times when people with behavioral health, mental health issues are taking their medication, you can work with them, but when they go off their medication or, other things happen, then, you're not in a place where you can negotiate. So thank you. Thank you all for your testimony. We do have some unfavorables, so let me go to those. So
Okay, so we're good
this
to
part
go.
of the bill is complete, and we're going to call some people up to the table that are unfavorable. Sanjeev Varghese, Courtney Bergen, and Neil Rosen. Am I missing Courtney? Okay, not here. Okay, thank you.
Good afternoon. My name is Neil Rosen. I'm an assistant public defender in the Mental Health Division. I'm testifying in opposition to Senate Bill 550. Before I became a public defender, I taught ethics and professionalism for more than a dozen years at 3 medical schools, including 3 years at Georgetown, where I was a scholar in residence at the Pellegrino Center for Clinical Bioethics. The written testimony submitted by the Office of the Public Defender details how this bill runs afoul of current law in Maryland. I want to focus on how the bill violates a fundamental principle of bioethics, respect for autonomy. The bill is patterned after the Healthcare Decisions Act, which expressly prohibits surrogate decision-making in respect to treatment for mental illness. The reason for this exclusion is simple. In respect of physical health care, including decisions about life-sustaining treatment, surrogates can reasonably be expected to base their decision on the patient's wishes, precisely because the surrogate wants to be loyal to the patient who is their parent, spouse, sibling, adult child, or friend. However, in respect to treatment for mental illness, the patient's spouse, parents, adult children, siblings, and friends often want the patient to receive treatment regardless of whether the patient wants the treatment at issue. Given this conflict of interest, it is unreasonable to expect these potential surrogates to regularly be guided by the patient's wishes. They are, in fact, I submit, regularly disqualified from being surrogates due to this conflict of interest. Accordingly, the Office of the Public Defender respectfully requests that the committee issue an unfavorable report on Senate Bill 550 because it would allow for surrogate decision-making by surrogates who do not respect the patient's autonomy.
Good afternoon, Chair Beidel, Vice Chair Hayes. My name is Sanjeev Varghese. I'm the Deputy Chief Attorney with the Public Defender's Office of the Mental Health Division. Following up on what my colleague, Mr. Rosen, has testified to, there are already methods available through guardianships, through emergency guardianships, which do not take months to get. Those are a quicker process, particularly when implemented and sought through a hospital system if somebody needs that level of care. There are already processes in place for involuntary admissions when they meet that level of care. and that need. An individual who's coming to the hospital, to the emergency department, and is presenting with the symptoms of their psychiatric illness, the physicians in the ED are not always looking just for informed consent in that time before medicating. They are weighing the risk versus benefit of continuing medication that that individual had previously been on, that they may have stopped before their hospitalization, and they will continue. They will offer the medications to the individual. If the individual refuses, they won't forcibly medicate at that time. But there's that difference between assenting to taking that medication versus consenting to the risk versus benefit of the medications. These processes are already there to allow that medication to occur in the ED when an individual is suffering. The process is already there for an involuntary admission. The process is already there for emergency and general regular guardianships. These processes are already in place to provide the care for the individuals. We urge an unfavorable report. Thank you.
Thank you. Senator Washington, you have a question?
Thank you, Madam Chair. Thank you both for being here. I've heard from the impetus for this bill from Ms. Smith months ago about this bill and why she's so passionate about making it happen because of a family member. And as we heard from them, families are trusted to consent to surgery, life support decisions, and cancer treatment. Why should we suddenly distrust people currently entrusted with irreversible physical decisions, when it comes to just mental health situations? Because this bill is about mental health, right? Why is that? Why shouldn't we allow it?
Do you want me to speak to that?
Yes, please.
Yeah, so thank you for the question, Senator Washington. I would say that there is often, as I testified, a conflict of interest between the treatment that a surrogate wants to authorize and a history of refusing the treatment under similar circumstances or a current express refusal. And in those circumstances, it's important that there be judicial oversight or alternative means such as an advance directive for mental health care.
The chair mentioned earlier that we recently passed a bill about, when folks are at this mental health issue. I can't remember the bill from a while ago, but it was really 2 years ago, about allowing, taking away the person's ability to make decisions for themselves, but with someone in care. This seems like a similar type of bill. Can you respond to that too? Thank you, Madam Chair.
Senator, they actually would have been of sound mind at the time they agreed to it.
Got it.
I think this is a different situation where it's emergency situations and they don't have one of those directives in force. Thank you.
Thank you. Thank you.
Thank you, Madam Chair. Just one question here then. So I guess, trying to thread the needle here and help with this, would you be more open to this bill if it was clear that medical agents that are making these decisions would have to be delegated that authority while the patient or prior to the patient being totally incapacitated? I know we're trying to deal with folks that may not have any ability to kind of respond, but what's your sense of that?
That's a possibility we can take up with our leadership, but I think the issue is that when they have that ability to make, when are they, so if there's the certificate saying they lack the capacity to rescind then that advance directive, is that part of it too? Because if they've given an advance directive when they have capacity, they should also have that ability to rescind any advance directive. So that would have to be that certificate saying that they lack capacity then, and that rescission. I think that is something we can take up and try to further discuss, but we'd have to see the language of it.
Okay.
Not to be.
Yeah, no, that's helpful. Okay, thank you.
My vice chair.
Thank you, Madam Chair. Had you guys had a chance to talk to the sponsor before appearing here today?
We have not.
I would recommend that after this hearing, you guys I've come into the situation where I've tried to help a constituent and not knowing all that's available out there, introduced a piece of legislation in an effort to resolve the issue and ran into similar situations. I would ask that you all leave here today, get in contact with the sponsor, have a conversation about what he hoped to achieve, and hopefully in doing so, it may come up you may come to a resolution or a solution that could address the problem that he wishes to solve. So if you all would do that as a request of the committee, we would greatly appreciate it.
We have no hesitation in providing information, resources, and access to our team and the information that we have in order to
That
help
wasn't
them.
really a question.
Thank you.
Thank you so very much.
Apologies.
Thank you, Madam Chair.
Does that end the hearing? Okay, we have one virtual witness. Thank you, gentlemen, for your testimony. Flip the pages. I will. Tammy? You want, I know, do you want to call her? I can't, I flipped the page on this. Right here, ma'am. Right here. Okay, so we have Tammy Lynn here, and she is unfavorable. Tammy, you want to give us your testimony?
Yes, hi, can you hear me okay?
Yes, we can hear you.
Okay. Good afternoon, members of the Senate Finance Committee. My name is Tamlyn Kelly, and I'm here today on behalf of Disability Rights Maryland to express our strong opposition to Senate Bill 550. Disability Rights Maryland is a nonprofit legal advocacy organization, and we are the federally mandated protection and advocacy agency for the state. We work to defend and advance the rights of persons with disabilities, including those with psychiatric disabilities. Many of the clients we work with have been determined to be unable to make informed decisions about their own care. We oppose this bill because it would allow a very wide array of people to make mental health treatment decisions for another individual. The bill would allow a surrogate to make medical decisions, including committing a person into the hospital against their will and medicating a person against their will. And I did hear the sponsors that there are some amendments, so we'd be happy to see those. The surrogate would not need to have any knowledge or training in mental health, nor is the surrogate required to have any clinical expertise. As you heard from our friends at OPD, the current system that is in place is there to ensure that our basic rights are protected. This system is in place now in part due to the history of abuses of people who are the most vulnerable. The way it stands now, a clinical review panel makes decisions ensuring that clinicians make the decisions about medical treatment, and only after a person has been involuntarily committed to a psychiatric hospital. Current law also provides a framework for when a person may be involuntarily medicated. This includes, for example, when a person is presenting a danger to themselves or others. And finally, the current law provides for the person to have counsel appointed to them. As Senator Washington said, to permit a healthcare surrogate to make treatment decisions is an unacceptable encroachment on the rights of persons with disabilities to not be subject to the decisions of others. If I may say, just to Chair Bidle's point, that psychiatric advance directives are a great alternative. It's something that folks would need to do before they're determined to be incompetent or incapacitated. But that, as well as supported decision-making, are great alternatives to consider instead of a bill that gives power to surrogates. Thank you.
Thank you. Do I have any questions? I do have a question. Senator Washington.
Madam Chair? I was going to say you can go first. Oh, thank you, Madam Chair. I'm just calling on you. Oh, all right. Thank you, Madam Chair. I know that you said something earlier about the sponsors' amendments. Is it true that you have not seen those yet, right?
No, we have not. I just heard about it just now with hearing,
Okay,
so
perfect.
I haven't seen the language.
I'm sure they'll send it to you. So you can review them and then please give us your opinion on them because we would like to have them. But in your opinion, I mean, we have a family member, they've had a history of mental health issues, they've been noted, you get to a certain point where they're just not listening and they're getting into all types of things and it's hard to get to a point to help them because there's nothing else to do. And in many instances, like I said earlier, we're able to say, be the surrogate for someone if something happens to them physically, and we can give approval. But with this issue of mental health, it's the one thing that we cannot approve on. So I'm wondering, what is the solution here to help with this that the sponsor is trying to rectify?
Like I said, I think the two best options are the psychiatric advance directive and supportive decision making. I think if there are ways that the state could support and encourage the use of those strategies, that would allow for patients' voice to be heard and for their preferences to be clear.
Okay, so thank you very much.
Thank you, Senator. I don't see any other questions. That ends the hearing on this bill. Thank you very much for your testimony. Next, we're going to do Senate Bill 561, Senator Sidnor. Senator, I believe that you have a panel, Kyle Fisher, Zachary Arciaga, Uvalque Radican, and Lydia Watts. I'm sure I murdered some of those names. Senator, you can start when you're ready.
All right, thank you very much. Have any of you all ever introduced legislation, had it passed, signed into law, and then the department did what it wanted to with it, but not what you intended it to do? This is a bill. This is that bill. So I just wanted to lay the groundwork before my testimony. In 2021, the Biden-Harris administration announced support for state reimbursing community violence prevention services via Medicaid. In response, we passed legislation that I introduced in 2022 to require Maryland Medical Assistance Program to provide and reimburse community violence prevention services. As ROCA testified in 2022, community violence prevention is a critical behavioral health service that changes behavior by giving people the skills to think, feel, and act differently. Techniques like hospital-based intervention programs and street outreach reduces gun violence by offering alternatives to retributive practices that otherwise often lead to further contact with the criminal justice system. One Baltimore City program saw that the rate of their reincarceration for their participants was 19% lower than the reincarceration rates of their peers. Medicaid in particular is a vital part of increasing accessibility of these services. A study in 2018 indicated that 2/3 of victims of gunshot wounds who sought treatment were either covered by Medicaid or uninsured entirely. Hospital-based violent intervention programs can engage these victims with cognitive behavioral support, community, and restorative justice solutions. With Medicaid funding, these programs can reach more of the victims who might not otherwise have had resources available. Along with Connecticut, Maryland was a pioneer in creating policy to allow community violence prevention providers to be reimbursed from Medicaid. In fact, I got a call from the White House after we passed this, which was the first time in all the years I've been here that the White House called or took note of something that we did. Unfortunately, being among the first to embrace a new solution also means that we're among the first to encounter some growing pains. When testifying on Senate Bill 350 in 2022, I stated, Senate Bill 350 seeks to expand some services, hospitals, and others. And it's that and others that we've been hung up on are currently providing to those affected by violence. However, upon implementation of this legislation, the Maryland Department of Health required community violence prevention provider affiliation with trauma center hospitals, narrowing their impact. According to the Health Alliance for Violence Intervention, no program in Maryland has successfully received reimbursement for their services from Medicaid. After discussions with members of the Health Alliance for Violence Intervention and with the Maryland Department of Health, we're trying to fix this access problem on two levels. The Department of Health is reevaluating some of its internal policies, and I'm here today with Senate Bill 561 to clarify the intent of our prior legislation that was not intended to be as restrictive as what the department has made it. Senate Bill 561 does 4 things to accomplish this. First, it expands the number of recognized training and certifying organizations to at least 3. Currently, only one organization, HAVI, is authorized to train and certify violence prevention professionals. HAVI focuses exclusively on hospital-based violence intervention programs, causing other evidence-based models like street outreach and cognitive behavioral interventions to be excluded. Senate Bill 561 broadens certification pathways to reflect a full range of proven violence prevention strategies. Secondly, Senate Bill 561 clarifies, not expands, as the department is saying that we're expanding, it clarifies, because this was its intent when it was passed, the eligible programs that do not need to be affiliated with a trauma center. Maryland Violence Intervention Programs operate across trauma centers, community hospitals, and independent community-based settings. National best practices emphasizes meeting patients where they are, particularly those who are hardest to reach. Removing this restriction ensures programs can operate in diverse settings that maximize engagement and impact. Thirdly, it authorizes the delivery of services via telehealth, increasing accessibility and giving providers more flexibility in their efforts. Violence intervention programs often serve patients in non-traditional settings. Lastly, it expands the locations where patients can receive reimbursable services. Current regulations limit reimbursement of hospital-based services, excluding community-based programs from eligibility. Not our intention. Additionally, they fail to reflect how hospital-based programs function. While care may begin in the hospital, most services are delivered over the following 3 months to a full year after discharge. Senate Bill 561 updates the policy to align reimbursement with the realities of effective violence intervention work. In closing, Maryland has made real progress in reducing community violence. We've heard the governor talk about this. To sustain and build on this success, we must ensure our Medicaid violence prevention benefit is accessible and workable for the programs proven to be effective in saving lives every day. For these reasons, I ask for a favorable on Senate Bill 561 and turn this over to my panel.
Who'd like to go next? It's fine.
Hi, everyone. Chair Vidal and the rest of the committee, thank you for having us here today. I'm Kyle Fisher. I'm the Policy Director at the Health Alliance for Violence Intervention, the HAVI. As the Senator just mentioned, we were involved with the original legislation a few years ago, and we've been highly motivated to make sure it works. We're the national organization that represents hospital-based violence intervention programs. We have 8 member programs in Maryland. So I've personally been walking programs through and trying to onboard them onto using Medicaid reimbursement for their programs. But after we got to last year and we didn't have a single program that was able to bill, we convened a working group of folks from all over the state. Programs, MDH came and has been participating as well. And after meeting for about 10 months, what we really discovered was that this overlapping series of regulations that MDH put out just excluded people that weren't able to bill even if they were trying to. And even for hospital-based programs that they explicitly said would be allowed to, based on the nitty-gritty of what was in it, only a small proportion of the work that they did would be eligible for reimbursement too. So this bill, as he just summarized, really does expand it to what was intended when everyone worked on this a few years ago. It eliminates the listing as our organization as the only eligible training and certifying provider. We had no intent of having a monopoly on this, and we want to make sure our community-based providers are eligible to continue doing the great work. It removes the requirement that only trauma centers can operate programs when there's no functional difference between a community hospital and trauma center for delivering these. It expands the locations where patients can receive services, because patients typically don't want to return back to the hospital where they had their initial trauma. And it improves telehealth access. So thank you for listening today, and happy to answer any questions.
Thank you.
I can go next since it really amplifies a lot of what's been said. Good afternoon, Madam Chair, Vice Chair, and members of the committee. My name is Uvelke Radigan. I go by UV, and I serve as the Director of Clinical Services for the Center for Hope. I am here today in support of Senate Bill 561. On behalf of the Center for Hope, Safe Streets Baltimore programs, and our allied community violence intervention partners, I respectfully offer this testimony in support. This bill advances the sustainability and effectiveness of community-based violence services, and it really aligns the Maryland medical assistance reimbursement structure with real-world service delivery. This bill requires the Medicaid reimbursement community violence prevention services to be delivered in person, regardless of location. So this ensures that programs are compensated for services already provided in homes, neighborhoods, and communities, and other non-clinical settings. SB 561 also authorizes reimbursement for services delivered through telehealth, which includes live and asynchronous formats where appropriate. This expands access and reflects how programs engage participants today. Importantly, the bill prohibits denying coverage solely because services are delivered via telehealth, which ensures that telehealth is a viable reimbursement pathway rather than a funding barrier. Current regulations discourage community organizations participating unless they have formal ties to hospital or trauma centers, and SB 561 removes that requirement, allowing trusted community-based entities that employ certified professionals to participate once approved by Maryland Medicaid. This truly expands provider networks serving individuals that are at risk of violence. The bill additionally includes training and certification standards, which expands the provider pool with qualified providers. And lastly, community violence intervention is a proven public health strategy. It is rooted in outreach, trauma-informed services, advocacy, and conflict mediation. And we thank you for your time and consideration and for your support of this bill.
Thank you. UV, that's much easier than
I know,
UV.
Deep breath.
Zachary, you're going to go next.
Yes. Hi, members of the committee. My name is Zach Garciaga. I'm the Trauma Program Director at Johns Hopkins Hospital. And Johns Hopkins supports Senate Bill 561 because it expands the reimbursement and delivery options for community violence prevention services, which includes telehealth, which is important because it's meeting people where they're at. I oversee Break the Cycle, a violence intervention program that provides wraparound support for victims of violence, addressing needs such as bullying support, housing and food insecurities, employment support, and mentorship. And our team includes lived experience survivors, members of the community, program staff, and physicians like Dr. Joe Saccharin, who's a trauma surgeon and a gun violence survivor himself. Together, we're using evidence-based strategies to address both the immediate and long-term effects of violence. Our program has expanded in the last year across multiple Johns Hopkins trauma hospitals, which includes the Children's Center, Bayview Medical Center, and Suburban Hospital. Our goal would be to have a violence intervention program at all JHHS facilities, which include Howard County and Sibley, that are non-trauma centers within the state of Maryland. Our work is growing significantly. We've seen our closed cases nearly fourfold from last fiscal year, and our engaged clients rose from about 50 per quarter to nearly 200. Through our network, we're caring for all patients of all ages across the state, and representing violent injuries representing a significant portion of our volume. We're also seeing an increased need for counties that don't have significant infrastructure and victim services that need that development, and why community-based programs are so important. So supporting survivorship has to extend beyond the hospital stay. Telehealth, which will be my last point, is really become the most critical tool for our violence intervention teams because it allows us to maintain a connection with patients facing transportation, safety, and security needs. It also protects our staff. Patients that are involved in a group and gang involvement that may not necessarily want to be associated with improving their lives, this gives that an opportunity to help with that. So we support a favorable report on 561. Thank you.
Thank you. And Lydia, you're the final witness. Thank you.
Thank you. Good afternoon, Chair, Vice Chair, members of the committee. My name is Lydia Watts, and I'm the Executive Director of the Rebuild, Overcome, and Rise, or ROAR Center at the University of Maryland, Baltimore. I respectfully support SB 561. ROAR provides wraparound trauma-informed services to victims of violent crime in Baltimore City, survivors who are at the highest risk of being harmed again and the least likely to seek help from law enforcement. Since opening in 2019, we've served more than 900 survivors of homicide, non-fatal shootings, sexual assault, and inter-partner violence. ROAR partners with the R. Adams Cowley Shock Trauma Center at the University of Maryland Medical Center through a medical legal partnership. This evidence-based model improves health outcomes by addressing the legal and social conditions that drive injury and poor recovery: unsafe housing, loss of income, medical debt, denial of benefits, and lack of protection from ongoing harm. We understand the opposition is one of cost. Survivors of violent injury are among the highest cost trauma patients, and repeat firearm injury is one of the most expensive and preventable expenditures. Multi-site hospital and community violence intervention programs have shown reductions in re-injury and retaliation, generating millions of dollars in avoided healthcare and criminal legal systems costs for every dollar invested. Preventing even a small number of repeat injuries offsets the cost of reimbursement. Maryland already recognizes, as you know, violence intervention as a Medicaid service. However, statutory and administrative barriers exclude community-based programs like ROAR, even though we provide the ongoing services that make hospital interventions effective after discharge. Without reimbursement, this proven work remains financially unstable. SB 561 closes that gap. For the health of survivors and the fiscal health of the state, I urge a favorable report.
Thank you, Lydia. I have a question from Senator Lamb.
Yeah, thank you, Madam Chair. Just one question for Dr. Fisher. Did the State Health Department work with stakeholders on developing recommendations that are part of this bill over the last year?
Yeah, so the MDH has been joining our working group. We've had an open invitation to them, and we've been really happy. They've had 2 staffers that have been joining the vast majority of calls, and they've been very supportive, and we have been working with them to solve some of the issues. They wrote in their testimony that some things that they are considering adding are additional codes for time spent, removing the trauma center designation, and a few others. I was a little confused, to be honest, when the report said that they were going to oppose based on a fiscal note when they are doing most of the things anyways. The fiscal note doesn't make operational sense to me, but they have been working with us. I'm not sure that they have committed to fixing like the training and certification part of it, which is really important. So like I mentioned, hospital-based violence intervention programs at the Javi, we're the only group recognized to train and certify people, but we only do one model. So we don't train people in street outreach. We don't train people in cognitive behavioral interventions like Lydia's doing. So it artificially excludes 2/3 of the field.
And if I may say, I don't think this is by accident. Again, when they promulgated the first regulations, I wrote to them and said, you all are narrowing this more than what we had intended to do. I mean, when I spoke with Dr. Fisher when we first talked about this, we had ROCA testifying, who was not a hospital-based organization. The purpose was to include everyone. The state expressly took this position, or I should say the department took this position to narrow it. I notified them, and they said, yeah, thanks, and they did what they did. So I've communicated with them over the past couple of years, hoping that they would do right. And it got to the point where I said, you know what, we're going to make certain that we clarify what the intent was, and I reached out to Dr. Fisher, and we did a few other things.
So it sounds like the department's been part of this process and part of the development of these recommendations, but given the track record here, I guess you're not surprised that they're now opposing this bill.
I'm not surprised.
Okay, thank you.
I don't see any other questions. Thank you very much, Senator.
Thank you all.
I think that ends the hearing for Senate Bill 561, and next we're going to do 555. That is my vice chair's bill. Senator Hayes, Health Dimension Services and Brain Health Program. And you want to bring up Megan Peters, Sarah Westrick, Dr. Tanya Brown? No, she's not. Cynthia Fields and Sandra Cohen.
Good afternoon.
Good afternoon.
All right. Good afternoon, Madam Chair, members of the Finance Committee. For the record, I'm George Reith on behalf of Senator Hayes. I'm here to present Senate Bill 555. This bill establishes a dementia services and brain health program within the Maryland Department of Health to lead the state's public health efforts on brain health and dementia. It requires MDH, in partnership with the Maryland Department of Aging, the Virginia Jones Alzheimer's Disease and Related Dementias Council, and other expert organizations to develop and maintain a clinical toolkit for dementia care for health providers by January 1st of 2027. Alzheimer's disease is not a distant issue. It is a growing public health crisis in Maryland, and today more than 127,000 Marylanders aged 65 and older are living with Alzheimer's. Nearly 17.5% of adults aged 45 and older experience cognitive decline in Maryland, and the cost of Alzheimer's and related dementias nationwide reached an estimated $384 billion in 2025. By 2050, nearly 13 million Americans are projected to be living with Alzheimer's, with annual costs reaching $1 trillion. Maryland consistently ranks among the states with the highest prevalence of Alzheimer's disease in the nation. The burden of families, caregivers, and our healthcare system will only intensify if we do not act now. Senate Bill 555 aims to strengthen Maryland's infrastructure for addressing Alzheimer's disease and related dementias by moving forward with structured program leadership. This bill is not simply creating a toolkit, it's about changing the experience of a diagnosis. It means earlier detection, more coordinated care, and fewer hospitalizations. It also means caregivers receive support before burnout. Maryland is taking a proactive, equity-centered approach to one of the fastest-growing public health challenges of our time. For these reasons, I respectfully request a favorable report on Senate Bill 555.
Thank you. Megan?
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. My name is Megan Peters. I'm the Director of Government Affairs for the Alzheimer's Association, here in strong support of Senate Bill 555. First, I want to thank Senator Hayes for sponsoring this important legislation and thank this committee and George for your commitment to supporting Marylanders impacted by dementia. Last year, we came before many of you to advocate for reporting state-specific dementia prevalence, especially given that Maryland is estimated to have the highest prevalence of Alzheimer's in the nation. Today, we have that data, and it shows that 15% of Marylanders aged 65 and older are living with dementia. We also know that this is likely an undercount because dementia is often undiagnosed. These findings underscore that dementia is a significant and growing public health crisis, one that requires upstream action to reduce risk and improve outcomes. This bill will help Maryland do just that by strengthening Maryland's response in two important ways. First, it directs the development of a clinical toolkit for dementia care. Families often tell us that the path from noticing early symptoms to receiving a diagnosis can be confusing and fragmented. A clear evidence-based toolkit with support for providers and patients through guiding them throughout the journey, whether it's discussing brain health, risk reduction strategies, or recognizing early signs and symptoms, is really vital. This can make a difference now and improve future outcomes. Second, the bill establishes a dementia services and brain health program within the Department of Health. Currently, Maryland's statewide dementia response is coordinated by a single director. That role is essential, but the scope and urgency of dementia requires a more significant response. Establishing this program builds out the state's capacity and aligns our dementia response with other major chronic disease efforts like cancer and diabetes. Together, these components will give Maryland the structure and tools needed to reduce our dementia risk and improve health outcomes. For these reasons, we urge a favorable report. Thank you.
Good afternoon, Chair Vidal, members of the Senate Finance Committee. My name is Sarah Westrick. I'm the Advocacy Director for AARP Maryland, and I'm here today in support of Senate Bill 555. Thank you to Vice Chair Hayes for sponsoring this bill. Alzheimer's and related dementias affect more than 127,000 Marylanders, and that number is rising as our population ages. Families, caregivers, and health systems are already stretched thin, and too many people struggle to get an early diagnosis or dementia-capable care. Senate Bill 555 gives Maryland the coordinated strategy that we need. By creating a dementia services and brain health program, along with establishing a clinical toolkit, this bill ensures that healthcare providers have the training and resources to detect cognitive impairment early and deliver culturally competent care. This bill is also about real people. In a moment, you'll hear from one of AARP Maryland's dedicated volunteer advocates, and I want to share words from another AARP volunteer, Marcia Goldberger, who cared for her mother who lived with dementia. Her rapidly progressing disease required around-the-clock support, and she frequently saw how staff, though kind, lack the specialized training that this bill would support. Senate Bill 555 meets an urgent need. It strengthens Maryland's response to this growing public health crisis. It helps providers understand, diagnose, and to treat the disease, and ensures that families are better supported. For these reasons, AARP Maryland respectfully requests your favorable report.
Thank you, Sarah. And I guess this is Sandra Cohen next. Thank you.
Good afternoon, Chair Beidel and members of the Senate Finance Committee, and a thank you to Vice Chair Hayes for sponsoring Senate Bill 555. My name is Sandy Cohen. I live in Anne Arundel County and volunteer with AARP. I cared for my late husband, Joe, throughout his Alzheimer's journey. The tools and support envisioned in this legislation could have brought him earlier diagnosis, sparing years of frightening confusion from unrecognized pathology. Too many families face the same struggle with dementia, for far too few are trained to diagnose it. Even neurology residents are not routinely taught dementia diagnosis. Our primary care physicians need the training, resources, and confidence to explore dementia early so families can plan, but also to settle immediate suffering from lack of diagnosis. My Joe's volatility showed something was wrong, but his doctor would only recommend marital counseling. It took years to get to Johns Hopkins, where on the first visit, one word, Alzheimer's, was both devastating and curative, for knowing restored Joe's calm, steady nature instantly, showing there had been no personality change. He had endured terror from undiagnosed symptoms. Senate Bill 555 will help Maryland address a public health crisis by giving providers the tools and training and enabling our Department of Health to treat Alzheimer's and other dementias more seriously. We need to address the trends that currently leave Maryland among the highest with dementia prevalence in the nation. I respectfully urge a favorable report on Senate Bill 555. Thank you.
Thank you, Sandy. We're going to hear from Cynthia Fields virtually, and then we'll have questions. So Cynthia, you want to unmute? Go ahead.
Thank you. Good afternoon, Chair Beidel, Vice Chair Hayes, members of the Finance Committee. My name is Dr. Cynthia Fields. I'm a board-certified geriatric neuropsychiatrist with an expertise in Alzheimer's disease and related dementias. I'm testifying in strong support of Senate Bill 555, the Dementia Services and Brain Health Program and Clinical Toolkit. I am proud to say that I was born and raised in Baltimore City. I trained here, I work here. So it saddens me that the city of Baltimore and the state of Maryland have the highest prevalence of Alzheimer's disease in our nation. As you know, dementia is brain failure, and it robs people of their independence, and it burdens their families with care. And I've treated patients with dementia for over 15 years, and it's a devastating disease. And there are not enough of me to go around. Myself and my colleagues, we have very long waiting lists if we're taking new patients at all. So it's imperative that we better train and equip other healthcare providers, especially primary care, to diagnose and treat dementia. So this bill will establish a clinical toolkit that will literally give providers the tools that they need for everything from early detection to advanced planning to person-centered care. And the toolkit will be evidence-based, kept up to date, and widely available to providers across the state. And my last point is that although we have some exciting new treatments for Alzheimer's disease, that those treatments are available to only a small fraction of those affected by dementia. And so we have to get ahead of this disease by investing in prevention. And research shows us that prevention works. And so this bill would give the resources to providers to counsel their patients in early to midlife on ways to reduce their own individual risk of developing dementia. And it would also establish a statewide public health infrastructure for our long-term prevention strategy, ultimately helping to reduce dementia prevalence in Maryland. And so I'm requesting a favorable response to Senate Bill 555, Dementia Services and Brain Health Program and Clinical Toolkit, so that we can better support Marylanders at risk of developing and who are living with dementia. Thank you.
Thank you, Dr. Fields. I don't see any questions for this panel or virtually. It's important legislation. Thank you very much. We have two more virtual. Oh, you have a question? Okay, no, go ahead.
Yeah, no, thank you, Madam Chair, and I apologize. I don't have a question, but I just want to thank this panel. Many of you all know that my grandma, who raised me from a very young age, suffered from dementia. So the work that you all do is really, really important to me and personal. And so I appreciate the effort that you all have brought before this committee today. And thank you, George, for presenting this bill before the committee. Appreciate it. Thank you, Madam Chair.
Thank you. George, you did a good job. Thank you. We have one more person, virtually, Dr. Cross, favorable, and she's the councilwoman at large in Glen Arden. So, Dr. Cross.
Thank you, Madam Chair and members of this committee. I am so honored to be able to speak on behalf of Senate Bill 555, Health, Dementia Services and Brain Health Program and Clinical Toolkit. I am a once neighbor of a woman who unfortunately met demise and suffered from dementia. It was my first introduction to dementia. It was my first introduction to the deteriorative nature. And it was my first introduction to just how much life is left in those that do have it. I respectfully submit this testimony in support of this particular bill favorably because it has taken an important step in establishing the coordination services. That modern public health approach recognizes that dementia is not only a medical issue, but it is a community and an economic challenge. I attended birthdays, I attended celebrations, graduations, and she always knew my voice. I wanted to say that because it was the creation of that relationship that showed me that even with cognitive decline, there is stability still left. Caregiver capacity is one of high concern. The creation of a clinical toolkit and the requirements to promote this capable care across our healthcare system is a strong provision that will help stabilize knowledge and improve outcomes. We are grateful that this bill has a form of coordination with local governments as well as municipal associations, which I believe is key because they are going to be the first line. Cities, towns frequently identify vulnerable residents before the state systems can even become involved. We are grateful for you bringing this bill and the implementation to prioritize equitable geographic access to services so that suburban as well as smaller municipality communities receive the same level of outreach and program visibility. I do submit a favorable report.
Thank you, Doctor. I don't see any questions. Thank you all for this bill hearing. And this ends the bill hearing on 555. Senator Giles is going to take over and chair the next bill, which is my bill, Senate Bill 4.
All right, Madam Chair, Senate Bill 492, whenever you're ready to get started.
Okay, thank you. I'm going to start with the two easy bills, and I can see going to have a lot of questions in the room. My first two bills are all favorable, so hopefully these will go quickly. But Senate Bill 492 is a health occupations bill for massage therapy advertising. And thank you for the opportunity, Madam Acting Chair Guile and members of the committee. Health occupations massage therapy advertising, Senate Bill 419 strengthens state standards for advertisement by licensed massage therapists and registered massage practitioners. It also clarifies the State Board of Massage Therapy Examiners' authority to enforce those standards. This bill aims to address sexually explicit and misleading advertising that undermines legitimate practitioners, confuses the public, and can hide prostitution and human trafficking behind the word massage. I've had two of these in my district, and they're very, very difficult to shut down because police officers don't like to go in and observe the work they're doing. And so I think it's much better if we limit the advertising so that they can't encourage people to come to their parlor. So under current law, the board must set standards for advertising and solicitation. However, the statute does not explicitly prohibit ads that offer or imply sexual services as part of massage therapy. This bill amends Health Occupations 6-401 so that a licensed massage therapist or registered massage practitioner or any third party acting at their direction may not place, publish, or distribute an advertisement that states or implies that prostitution, escort, or sexual services are available, or that sexual activity is part of the massage service. Additionally, Senate Bill 492 authorizes the board to adopt regulations and guidance to further define prohibited language and content, establish procedures for licenses, registrants, and the public to report violations, and establish appropriate disciplinary actions. Importantly, the board will be able to identify and investigate potential violations on its own and communicate enforcement timelines and expectations. I respectfully request a favorable report on Senate Bill 492.
Thank you. Who would like to go first?
Chelsea. Hello, good afternoon, Chair, Vice Chair, and members of the committee. My name is Chelsea Adams-Cook. I'm a licensed massage therapist in Maryland and currently serving as the president of the American Massage Therapy Association, Maryland chapter, representing professional massage therapists across our state. I'm here in strong support of SB 0492. As a licensed massage therapist, we are healthcare professionals dedicated to providing safe and quality care to the public. We complete extensive education, pass national examinations, undergo background checks, and adhere to strict ethical standards. Maintaining the trust of our clients and our communities is foundational to our profession. Unfortunately, in the current statute, there does not include a provision against the misuse of the word massage in advertising of prostitution or sexual services. Without clear language in the statute, consumers are not protected from the harmful advertisement of illicit businesses that aim to undermine the integrity of our profession. This bill establishes clear enforceable standards for advertising by prohibiting advertisements that state or imply that prostitution, escort services, sexual services, or sexual activity is part of the massage. This bill provides clarity to the public and law enforcement alike. It draws a firm but necessary line between legitimate massage professionals and illicit activity. Additionally, it will require that all advertisements include the full name of the licensed massage therapist or registered massage practitioner as a critical transparency measure. This allows consumers to easily verify a practitioner's credentials through the Maryland State Board of Massage Therapy Examiners License Lookup System. This simple safeguard empowers the public to confirm that they are seeking care from a licensed professional and guards practitioner from inappropriate advances. This bill makes it significantly more difficult for unlicensed or illegal operations to conceal their activity. The American Massage Therapy Association Maryland chapter supports strong, consistent protections to address illicit practices and put practitioners and the public at risk and erode professional credibility. SB 0492 is a practical, reasonable, and enforceable step to ensure public safety. For that reason, I respectfully urge a favorable report on this bill. Thank you to Chair Beidel for sponsoring our bill, and thank you for your time and consideration.
Thank you, Chelsea.
Thank you.
Next.
Thank you, Chair Guile and Chair Beidel. Yes, I am Lisa Smith with HB Strategies representing AMTA Maryland, and I will be quick since Chelsea covered all of the main points. I would just note that Department of Legislative Services reported no fiscal impact, and I also wanted to note that AMTA Maryland has no opposition to the amendment language from the board, which Sabrina Lopez will address on the panel as well, and happy to work with the committee on this bill. Thank you.
Thank you, Lisa. Who's next?
Sabrina, you can go ahead.
Good afternoon, Acting Chair and members of the committee. My name is Sabrina Lopez, Vice Chair of the Board of Massage Therapy Examiners, and I am here today to request a favorable with amendments report on SB 492. SB 492 seeks to modernize and clarify advertising standards within our profession. By requiring advertisements to align with official licensure records, we protect consumers and ensure that Marylanders can easily verify the credentials of their healthcare providers. However, to ensure this bill is both enforceable for the board and practical for practitioners, I respectfully request the following amendments. Amendment 1 on page 2, lines 15 through 26, replace with, if an advertisement lists the names of a licensed massage therapist or registered massage practitioner, the name displayed must be consistent with the names in which the board issued the license or registration. We would also like to strike section F on page 2 as well. This simplifies the requirements for practitioners and ensures that the public can cross-reference and add directly with the board's database without the confusion of nicknames, aliases, while removing redundant or overly prescriptive language in section F. The second amendment would be in 6-401A to add section 4, establish administrative penalties for any violation of this section subject to the hearing provisions in 6-309. For the board to effectively uphold these new standards, we must have the authority to issue administrative penalties. This amendment ensures that there are clear consequences for noncompliance while maintaining due processes through established hearing provisions. These amendments provide the board with necessary tools to regulate the profession effectively while providing practitioners with a clear, singular standard for identifying themselves to the public. I respectfully request a favorable with amendments report on SB 492.
Thank you, Sabrina. Last but not least, Rachel.
Thank you. Thank you, Madam Chair Bidle, and good afternoon, members of the committee. My name is Rachel Sy, and I'm Chief Operating Officer at Turnaround, where I've worked for the past 10 years. Turnaround is a nonprofit organization that has served the community for over 45 years, providing services to survivors of sexual violence, sexual assault, and intimate partner violence. Turnaround was among the first providers in Maryland to begin serving survivors of human trafficking statewide in 2011. And for the past 15 years, we have remained committed to this work, which is why we're here today. Our program has supported hundreds of adult and minor victims of human trafficking annually and facilitate numerous human trafficking trainings in Maryland to bring awareness and help communities better understand what trafficking looks like in this state. When people think of human trafficking in our country, many still picture commercial sex work in hotels or large criminal enterprises. However, there are also other disguised business models used by traffickers, including illicit massage parlors. These businesses often operate in strip malls and shopping centers, locations that many of us pass every day. Illicit massage parlors cases do exist and have been found in Montgomery County, Ocean City, Frederick, and Baltimore County, to name a few. Investigations that uncovered one illicit massage parlor would then uncover other connected locations where many women, often Asian foreign nationals, are moved between sites, coerced or forced to engage in sex acts. These women face language barriers, isolation, threats, constant monitoring, preventing them from leaving or receiving help. So for us, it is about the victims. To turn around, Senate Bill 492 is about ensuring that licensure and advertising channels are not used as cover-ups for human trafficking operations, which will result in the protection of many vulnerable victims. For these reasons, I respectfully request a favorable report on Senate Bill 492. Thank you for your time and consideration.
Thank you very much. Do we have any questions for the bill sponsor or her panel? Seeing none, thank you very much. All right, next we have a group of favorables: Nick Steigerwald, Jody Finkelstein, and Amanda Rodriguez.
Mr. Steigerwald is not going to be here.
Okay, thank you. And are you Jody?
No, Amanda.
Okay, sorry. All right, thank you. Ms. Rodriguez, you can go ahead and get started.
Thank you. Vice Chair Guile, members of the committee, my name is Amanda Rodriguez. I am the co-chair of the Maryland Human Trafficking Task Force Legislative Committee. Our task force was formed in 2008 and is composed of law enforcement, victim service organizations, survivor leaders, government agencies, and local task forces. Together with the task force helps facilitate the recovery of thousands of survivors and the prosecution of hundreds of traffickers across Maryland. The establishments that are referenced in this bill often advertise on sites such as USA Sex Guide, which is used by law enforcement to interdict in instances where we believe there to be sexual acts occurring within illicit massage businesses. Based on my years of prosecuting these cases and serving survivors of trafficking, the survivors from these establishments who report performing sex acts for 10 to 15 men per day, and many describe being made to live in deplorable conditions, including being denied food if they fail to meet daily quotas. This bill provides practical and effective tools for authorities to address human trafficking in these locations. For the foregoing reasons, the Maryland Human Trafficking Task Force and the survivors we serve respectfully request a favorable report. Thank you.
Thank you very much, Ms. Rodriguez. Just want to call once again, Jody Finkelstein. Is Ms. Finkelstein here? Okay, I don't see her. It's my understanding from our committee manager that the one unfavorable, Tom Swiss, is not on. So were there any questions at all for Ms. Rodriguez? Seeing none, that ends the bill hearing on Senate Bill 492. Thank you very much. And next up, another one from our chair, Senator Bidle's bill, Senate Bill 493, Nursing Facilities, Involuntary Discharge or Transfer. We have on the panel Carrie Craig, Dana Kaufman.
Madam Senator, let's call the rest of the group. We have enough chairs that'll move
Will
things
do.
along.
Sarah Westrick and Megan Peters. Do you want the favorable with amendments to the last one? Viola Woolums from Maryland Legal Aid.
Thank you. Considering it's late in the day, I'm even going to shorten my testimony. So thank you, Madam Senator and members of the Finance Committee for hearing Senate Bill 493, Nursing Facilities Involuntary Discharge or Transfer. Senate Bill 493 is about process, transparency, and protection for residents living in Maryland's 220 nursing homes. An involuntary discharge is defined in federal regulation as a transfer or discharge initiated by a nursing facility without the consent of the resident or their representative. Under law, this can happen only for 6 specific reasons, yet the process continues to create serious concerns for residents and families alike. Involuntary discharge from nursing facilities is one of the most common and distressing complaints reported by residents and families. According to the Maryland Long-Term Care Ombudsman, who's with us today, involuntary discharge remain the #1 complaint both in Maryland and nationwide. Too often these charges happen abruptly, leaving older adults without a safe place to go and families scrambling for options. Residents with complex medical needs are sometimes told to leave with little practical say in where they go, and families, if any, must find safe care on short notice. While Maryland law already limits involuntary discharge to a short list of reasons and requires written notice, we continue to see residents discharged to motels, shelters, or other unstable settings that cannot meet their medical and personal care needs. These failures turn a lawful discharge into a serious health and safety risk. I'm going to let the panel go ahead, and I just ask for a favorable report. I know there's a couple amendments that we'll be happy to work with, but asking for a favorable report on Senate Bill 493.
Thank you very much. Who would like to go first?
I'm going to go, if that's okay.
Sure.
Thank you, Chair and members of the committee. I'm Carrie Craig. I'm the State Long-Term Care Ombudsman, and Senate Bill 493 is really important to the residents in long-term care across the state. It's critical. Provides a critical safeguard by requiring nursing homes to give every resident a 30-day written notice before an involuntary discharge notice is given. So currently, the resident only has a right to receive a 30-day involuntary discharge notice if they have lived in the home for 30 days. So this bill will require that every resident can receive that right. This also gives the time that the residents need to work together with the home to create a really good, solid discharge plan. Because without that discharge plan, what we see is that residents end up in the community and unfortunately they fail, and then they cycle back through to the nursing home. So nobody wants to see that happen. Every nursing home resident deserves a safe, secure, and sustainable discharge process. Unfortunately, the Ombudsman program has had a few cases where residents were discharged to homeless shelters, and a resident who was diagnosed with diabetes had no place to refrigerate their insulin, and that's not safe. Or a resident who is discharged to a motel for a few days where the nursing home says, we'll pay for the hotel for a few days, and they don't have an income, and that's not sustainable. So we're trying to get on top of this to help protect residents. This bill strengthens accountability, protects resident rights, and helps prevent unsafe discharges that can have really devastating consequences. So for these reasons, the Office of the State Long-Term Care Ombudsman urges a favorable report. And I just want to thank the committee for all your continued commitment on protecting Maryland's nursing home residents.
Thank you very much. Next, Dana, do you want to go ahead?
Thank you. For the record, my name is Dana Kaufman. I'm here on behalf of Lifespan Network, and we do support with amendments this bill. And I want to thank the Long-Term Care Ombudsman, Ms. Craig, for working with us. We had a few concerns, and we were able to work together to come up with some amendments that are part of my written testimony that both still allow for the intent of the bill, but also make the process still manageable. Involuntary discharge is never where either resident or the facility wants to be, but unfortunately at times it is required. And we do think that the protections of this bill are necessary. And again, we thank her for working with us to still allow the process to continue. Thank you.
Thank you, Dana. Megan, do you want to go next? Go ahead.
Yes, good afternoon. For the record, Megan Peters on behalf of the Alzheimer's Association here in support of Senate Bill 493. Echo what the fellow panelists have shared. And just want to share from the perspective of people living with dementia, stability and predictable care are important, and any abrupt or poorly planned care transition can cause confusion, distress, decline, or even hospitalizations. So the provisions in this bill that allow proper notice and additional discharge planning requirements is not just procedural, but a matter of well-being. And this bill takes vital steps towards strengthening care transitions and protects nursing home residents and their families who are already impacted and navigating a very challenging disease. So for these reasons, we urge a favorable report. Thank you.
Thank you, Megan. Sarah, you want to go ahead and go next?
Good afternoon. Thank you so much for the opportunity to testify in support of Senate Bill 493. Thank you, Chair Beidel, for sponsoring this important legislation. My name is Sarah Westrick, Advocacy Director for AARP Maryland. I'm also a member of the Oversight Committee on Quality of Care in Nursing Homes and Assisted Living Facilities. AARP strongly supports this bill because it addresses one of the most harmful issues families report, residents being discharged to unsafe, unsuitable, or unprepared locations. This bill ensures that a resident may only be discharged to the specific location in the written notice and only once the receiving facility confirms it can safely accept them. This prevents inappropriate discharges to shelters or other temporary settings without adequate support. The bill also modernizes discharge notice requirements. The notices will provide clear and complete information, including contact information for the ombudsman. Requiring updates and 30 days notice ensures transparency and protects residents from abrupt and destabilizing moves. The bill also strengthens post-discharge planning, requiring a detailed plan developed with the resident, their care team, and representative when appropriate. And this helps ensure the residents transition to safe, stable, and medically appropriate settings. Involuntary discharge is one of the most traumatic experiences a nursing home resident can face, and Senate Bill 493 provides urgently needed safeguards. We therefore respectfully urge a favorable report. Thank you so much.
Thank you, Sarah. And Viola?
Good afternoon, Chair Beidel, Acting Chair Guile, and members of the committee. My name is Viola Willems, and I serve as the Deputy Advocacy Director for Public Benefits with Maryland Legal Aid. Maryland Legal Aid is a nonprofit law firm that provides free civil legal services to low-income and vulnerable Maryland residents. And among our most vulnerable Marylanders we serve are the residents of nursing facilities. These clients need nursing facility level care because of their disabilities, but they rely on their nursing facility for more than that. The nursing facility is their home, and it has a duty to safely house them and maintain their dignity in the process. Maryland Legal Aid often receives calls for assistance from residents whose moves are chaotic and dangerous because nursing facilities are not giving appropriate notice to prepare. The facility leaves them in limbo about their destination, sometimes until 48 hours before they're on their way to a new and unfamiliar place. Senate Bill 493 does three things that would make these moves safer and more dignified for our clients. First, it specifically prohibits moving residents to homeless shelters and reinforces that prohibition by requiring their destination to be safe, secure, and sustainable. These are temporary shelters, often only places where people stay for a few hours, and they're never safe and secure. We've seen nursing facility residents discharged to homeless shelters, and at least one of our clients die as a direct result. Secondly, the bill makes sure all residents are protected by notice, not just those who have resided in a facility for 30 days. And finally, it resets the clock for evictions when facilities change the location to which residents will be moved. In our experience, nursing facilities often exploit the weak language of the existing law to make last-minute changes to destinations. We have suggested one friendly amendment that would clarify the language of the bill and included it in our written testimony. Thank you.
Thank you very much, Viola. Do we have any questions on this bill? Oh, thank you. Senator Lamb.
Thank you. Just briefly, I've heard of cases where individuals have been discharged from a nursing facility out to a hotel, which just seems absurd. Like, it seems disgraceful that folks are discharged without an actual discharge plan. I don't think discharge to a hotel is a real discharge plan. So just want to commend all of you for supporting this, and also the sponsor for bringing this bill forward. I think it addresses a real problem that's out there. So thank you.
Thank you. See no other questions. That ends the bill hearing on Senate Bill 493. Next, we have also with our chair's bill, Senate Bill 494, Maryland Healthcare Commission Certificates of Need and Material Change Transactions. It looks like Senator only one, Douglas Jacobs, Maryland Healthcare Commission. Did you want anybody else to come up?
No, we can just do Dr. Jacobs and I, and then.
Okay.
I'm not accustomed to having my friends in opposition, so this is going to be an interesting hearing.
Don't they know who you are? All right. Go ahead.
Thank you, Senator Guile and members of the Finance Committee. Thank you for the opportunity to present Senate Bill 494, the Maryland Healthcare Commission Certificates of Need and Material Change Transaction. This legislation is about protecting Maryland patients, workers, and communities from the harmful effects of unchecked healthcare consolidation. You might remember a few years ago, we worked on bills with nursing homes being purchased by private equity firms, and we saw a real decrease in quality of care, an increase in expense, lots of profits to private equity, and not particularly good care. And it really helped that we put in a process that before they can be transferred from a private equity, that it would be reviewed by the MHCC. And I don't think we've seen any transfers since that bill. So it's really interesting. But across the country and here in Maryland, consolidation of facilities, especially through private equity, have been shown to raise costs, increase unnecessary utilization, and strain clinical decision-making without improving quality. While transactions to merge and acquire healthcare facilities can theoretically, it's late in the day, allow for a facility to receive the capital it needs to improve its delivery of services. And there is growing evidence that these transactions have the opposite effect. In many cases, these transactions restructure healthcare organizations focusing on extracting money so they can be sold for profit. This is not better care, and it's not good for our communities. I think often, though, we see the consolidation and private equity firms come in and they purchase medical practices because it does help to save costs and streamline processes. So the really focus of this bill is to be able to review these transactions and decide if these are good transactions for the benefit of our Marylanders and our patients, or if it needs other work, that would give the Healthcare Commission the opportunity to review and suggest changes. So in Anne Arundel County, for instance, more than 50% of my ophthalmologists and dermatologists are owned by private equity. And so it's true in many other counties too. Prince George's County, over 75% of dermatologists and 50% of ophthalmologists are private equity owned. So why is it important? When we get spot checked for skin cancer, we need cataract surgery, we're more likely to get upsold on high profit procedures that we don't need. Visits may get shorter, more follow-up visits required, leading to more co-pays. We might have longer waits and less attentive care. We may end up paying a lot more, but getting less. Medical groups, outpatient surgery centers, and independent physicians are seeing the same trends across all of Maryland. The number of independent providers is going down, and the influence the corporations have over our healthcare practices are going up. We've already recognized this challenge, as I said, the danger for nursing homes. Genesis Healthcare, for example, with nursing homes in Maryland and other states, was sued repeatedly for negligence and safety issues. Maryland currently has oversight on these nursing home transactions, allowing us to protect Marylanders against these financial moves that undermine long-term care delivery in nursing homes. This legislation parallels the Nursing Home Regulatory Authority for other healthcare settings. We need the same oversight to protect our communities, to safeguard our health care, and to make sure these consolidations, mergers, and other transactions don't drive up costs and they drive down quality, safety, and access. Some states have started to tackle these challenges. California, New York, Connecticut, Iowa, Wisconsin, Washington, Massachusetts, and a handful of others have introduced and in some cases passed legislation for a public interest review process. The National Academy for State Health Policy has given us some good models. Senate Bill 494 molds these ideas into the solution Maryland needs. It creates a targeted, streamlined oversight process for large healthcare transactions, what we define as material change transactions. This type of change would be things like mergers, acquisitions, joint ventures, management service organizations, or contracts that transfer control of a healthcare entity with at least $10 million in assets or revenue. Our goal with this bill is not to block transactions. It's to identify and address the subset of these type of transactions that pose real public health risks. The Maryland Healthcare Commission already has statutory experience overseeing nursing home acquisitions, including approving, conditioning, or denying deals when necessary, and they are well suited to take over this critical oversight. This public interest review focuses on those factors that matter most to health and safety for Marylanders: affordability, quality, equity, staffing, access, and the types of services delivered. This lets MHCC review and then approve, condition, or deny a transaction only when necessary to ensure health and safety of Marylanders is preserved. I just ask that we have some work to do. I know that there's going to be some amendments offered, and I'm happy to work with the requested amendments, but I ask that we respectfully request a favorable report on Senate Bill 494.
Thank you very much. Dr. Jacobs.
Good afternoon, Chair, Acting Chair, Vice Chair, members of the committee. My name is Doug Jacobs. I'm the Executive Director of MHCC and a practicing primary care doctor. MHCC is in strong support of Senate Bill 494. Right now, we're seeing a rapid shift in who owns and operates facilities and healthcare delivery in Maryland. MHCC has studied these trends for years. Physician practices, home health agencies, hospice providers, ambulatory surgery centers, and non-hospital facilities are increasingly being purchased by private equity organizations. And some of these transactions could represent important access to capital. But research has shown that more often acquisitions like these can lead to reductions in staffing, reductions in service lines, or limitations in taking Medicaid patients, all of which can affect patient access, affordability, and also quality. And today, Maryland has no consistent oversight process for these types of transactions outside of nursing homes. And so Senate Bill 494 fills that gap. It would create a streamlined process for public notice. After the notice, MHCC would have 30 days to see if that transaction needed to progress to a public interest review. Most would not. It's only for those potentially problematic transactions, those involving significant impacts on healthcare quality, access, affordability, that MHCC could conduct a 60-day review and either approve with conditions, or deny the transaction. But this is not about blocking investment. It's about making sure that significant ownership changes support rather than undermine Maryland's access to high quality and affordable care. The General Assembly recognized the importance of this approach last year when it established a similar public interest review framework for nursing homes. And SB 494 simply extends that to the rest of the care continuum. Before rising acquisitions reshape care delivery in ways that are difficult to reverse. SB 494 provides the right solution for Maryland at the right time. We've engaged with stakeholders throughout the process and remain committed, as the chair mentioned, working with them going forward. And so for all the reasons discussed today, MHCC requests a favorable report.
Thank you very much, Dr. Jacobs. Does anybody have Senator Lamb?
Thank you. And I guess to Dr. Jacobs, good to see you again. Thanks for being here. I'm just looking at some of the testimony that's in the bill folder here. And, one of the concerns that was brought up was that this kind of a transaction review process might hinder the ability of independent practices to grow or expand. What's your response to that?
Thank you so much for the question. So in designing and crafting this legislation, we thought that, number one, there needs to be transparency into these types of transactions. So if it's an independent practice and they're acquiring another practice, it might fall below that 10 million threshold, and it might not even have to be posted. But by and large, the idea here is to get transparency into a lot of these transactions where we're currently blind to them. And it's only for those select few areas and potentially problematic transactions that we would move on to a 90-day review process. So we feel like it's pretty streamlined, low burden, but gives us the transparency we need and the tools for oversight.
Some of this testimony also points out that, that there are only a very few other states that have this kind of a mechanism where approval is required for transactions involving physician practices. And one of those examples is Minnesota, where they set a much higher threshold. You just referenced one of 10 million. They set a threshold of 80 million. How did you arrive at the 10 million? Why 10 million? Why not a little bit higher than that?
Yeah, it's a great question. So in designing this bill, we talked with several states. We talked, the states with the most mature processes are Oregon and Massachusetts. And so we discussed their processes and what we could learn from them. What we learned is that it would make a lot of sense to have a fairly low bar for just public transparency about the transactions so that we can study the effects of them over time. And then it's only for those select few that we could move on to that public interest review process. This was also based in part on the National Academy of State Health Policy model legislation and also our own experience in skilled nursing facilities. And so in designing that $10 million threshold, we're open to working with stakeholders if someone feels like there's another number that would be more appropriate, but we really want to gain more transparency, and that lower number would allow for that transparency to happen.
And how does the public interest review process, I guess, compare to the nursing home transaction review process that we currently have?
Thanks for the question. It's fairly similar. I think what's important about these processes is that they're streamlined. If we move on to a public interest review process, we have 60 days. That's very similar to the nursing facility acquisition review process, public interest review process, where there's a similar amount of time. And it's transparent, the transactions get posted. So there's a lot of substantively similar aspects, and which is important because we've already learned a lot overseeing the skilled nursing facility transactions that we brought to bear in this bill.
And what requirements does the bill have for the Maryland Healthcare Commission to consult with the stakeholders? If you could just kind of outline how you envision that process might actually work here.
By stakeholders, in terms of so I should say the process in the bill, there's some aspects that would need to be defined via regulation. And so we would certainly have
that up to, right. So
we would certainly have the proposed comment period, take those comments into consideration. And the other piece of this is that because the transactions would need to be posted publicly, if we were to go on to a public interest review process, there would also be the opportunity for public comment. We've seen with the skilled nursing facilities and our oversight there that that's really important because that gives an opportunity for the residents of skilled nursing facility, for example, to actually comment on the impending sale of the place where they might be residing. And so that is also another opportunity for also staff to comment in a public interest review process, and for us to really take all of those comments into consideration in our oversight process.
I guess to that point, one of the things that MedChi has brought up is that a lot of these physician practices are acquired by like hospitals or health systems, and one of the things that they would prefer to capture in this then is that when you define material transactions, that this should include a review of hospitals and insurance companies, and that's not really clear in the current way that this is drafted. What's your kind of perspective on whether that should be included or not as part of that review process?
Yeah, I think our approach to this is for the acquiring parties, we didn't exclude anyone from the acquiring parties. The reason was we want to have a fair and balanced approach. So if a hospital is acquiring a physician practice, if a payer is acquiring a physician practice, if a private equity organization is acquiring one, they would have to go through the similar notice, and MHCC could then decide if it was a potentially problematic transaction. The reason why that fair and balanced approach is important is that, private equity is not a monolith. There are some private equity organizations that are not trying to very much restructure it and disrupt the way that care is delivered. It can be, as we both mentioned, it's important access to capital in some instances. And similarly, you can have nonprofit organizations where there's a a subsidiary that's a for-profit private equity group, or you can have a parent organization. And so, and there can be problems with all types of different transactions, and private equity groups can consult. And so I think the ability to differentiate and really identify when transactions have occurred in other states, for example, where after a facility was acquired, quality significantly decreased, to apply just similar principles and really differentiate good actors from bad actors, and in some ways deter bad actors from entering the Maryland market as part of this as well.
Mm-hmm. Yeah, I mean, I think, and this is, just to close on this point, I think that's where we're trying to all thread the needle, right? That I think the point being that not all private equity is necessarily always bad, to your point, that like some of it is helpful, right? I've heard from some practices where having access to capital certainly helps them accelerate some of the improvements to their exam rooms or to their, equipment, and to be able to invest in new, CT scanners and those kinds of things that can really help the practice as well. And so, it's a matter of kind of weighing those considerations and kind of keeping in mind that not, when people hear about private equity, there's like an inherent kind of visceral reaction to that. It's not always necessarily in the negative, but it has to be properly kind of balanced, and that's just an important thing to kind of keep in mind.
Yep, exactly. Yeah, thank you.
Okay, thank you.
Thank you, Senator. Senator Reedy.
Thank you. I had a question, and just on this overall issue. I think private equity, definitely a legitimate concern that's growing. As much as I'm a free market guy, I think we've seen there's some challenges with private equity we've got to figure out as societally, honestly. I do think there's some interesting testimony here about how consolidated some of our other health markets are. So there's testimony in the file about, for example, CareFirst and Kaiser Permanente control 82% of our insurance markets here in the state. And that doesn't mean that that's bad necessarily. Generally, you like more competition, but it's kind of a reality. So how do we decide what we're going to get into versus what we're not going to get into? And I think because there is the question of independent physicians needing to be able to meet the needs of their practice and not get slowed down excessively. I do have some concerns about government getting involved to that level. So I don't know if you could comment on that or that concern.
Yeah, no, that's a great question. So MHCC actually came out with a report on consolidation this last year. We looked at not only provider consolidation, also insurer consolidation. We'd be happy to share the results of that report with you and go in depth into all of these issues. And we looked at the effects of consolidation. What we also saw in that report is that private equity groups for medical group practices, corporate parents are now represent 40% of medical group practices across the state. 40% of ambulatory surgery centers across the state are now acquired by corporate parents, including private equity. And what we know from the national data, including data in Maryland, is that for ASCs, for example, after acquisition by a private equity group, costs go up by 50% without any improvement in quality or change in the type of services delivered.
When you say cost, you mean how much they're charging?
It's both. It's like how much they're charging, and some of those dollars then get passed down to patients in the form of co-pays or co-insurances.
But why did they purchase there? Why did those particular practices sell out? I guess they sold, I don't want to say sell out. I mean, why did they sell? Did they make money, I suppose, but also at times there are practices that need to figure out how they can scale. So I guess how do we keep?
So to your earlier question too, so your question is how do we differentiate basically?
Yeah.
And part of what we've realized in the skilled nursing facility space, and actually we just posted publicly the first skilled nursing facility acquisitions now, so we're going through this process in the skilled nursing facility space. The ability to, when we undergo the public interest review, to actually ask those questions: what have you bought in other states? What did the quality look like after you bought those facilities? Did you significantly change the services that were delivered? What did your staffing ratios look like? If we were to actually have a worry about a specific type of purchase, we could go into that detail in a back and forth with the acquiring party, and And because MHCC is a very data-driven organization, and we let the research and evidence guide us, and so for a lot of these practices, after we have transparency into when the transactions are happening, it also allows us to continuously study going forward. Where are the issues, where are the problems, and how can we think about our oversight as a result?
Okay, I'm interested, we can talk more offline. I'm
Yeah.
concerned about too much constriction of independent folks being able to do what they need to do, what they want to do. I do understand in our system of the all-payer system, it's not complete, it's not a free market, so we do have that to look at as well. So I appreciate your answers. Thank you.
Yeah, thank you.
All right, seeing no other questions, I just have one quick question. I know that we've talked about here a lot about ED wait times, and I'm wondering if you could discuss how the acquisitions of post-acute care settings, particularly by private equity, may have an impact on ED wait times, Doctor.
Yeah, absolutely. So we've seen that, and the evidence shows that when post-acute care settings, not only skilled nursing facilities, but also home health agencies, hospices, when they're acquired by private equity, they become much more choosy in what kind of patients they're willing to accept. Much less likely to accept patients on Medicaid that have complex needs and conditions. And what we also see is that hospitals have difficulty discharging those very same patients. And so if a hospital is having difficulty discharging a patient, that means patients get backed up through the hospital, leading to long wait times in the emergency department. This is, as folks know here, a huge issue in Maryland. And so having kind of these unchecked transactions over time, if we don't start thinking quickly about how we improve our oversight, we worry that that can really exacerbate the issue of ED wait times and could be something that we think about in response.
Okay, thank you. Seeing no other questions, thank you very much, Dr. Jacobs and Madam Chair. Next, we have Jamie DeMarco, Stephanie Clapper, and Sarah Westrick. I wonder if we can just keep. We'll also call up Matt Celentano, Allison Taylor, and Kimberly Robinson. Whoever wants to get started, go right ahead.
I'll go first. Good afternoon, members of the Senate Finance Committee. My name is still Sarah Westrick, Advocacy Director for AARP Maryland. It's great to be with you. I am here representing our approximately 850,000 members, and we are also a member of the Maryland Senior Citizen Action Network, and I want to mention that they are also favorably supporting this bill. Maryland is seeing rapid growth in acquisitions of healthcare entities across many sectors. These changes are raising real concerns about affordability, access, and patient safety. We've witnessed the consequences in nursing homes where private equity ownership has too often led to declining quality of care. Similar patterns are now emerging in other areas of the health system, including physician practices. And that's why AARP Maryland strongly supports Senate Bill 494. Consolidation and private equity acquisitions have consistently been linked to higher cost, reduced staffing, and lower quality of care. This bill requires public notice for major transactions. This gives patients and communities time to understand how changes could affect their care. And it also directs the Maryland Healthcare Commission to evaluate whether a transaction would increase market power or reduce competition. Importantly, the bill ensures that reviews consider cost, quality, continuity of care, staffing, and access, aligning with Maryland's broader healthcare goals. The Commission can bring in outside experts without using state funds, and the bill provides flexibility for expedited review when appropriate. Too many Marylanders have already felt the negative effects of healthcare consolidation. This bill ensures that the state has the tools to protect patients and maintain high-quality, accessible care. For these reasons, we respectfully urge a favorable report on Senate Bill 494.
Thank you, Sarah.
Acting Chair Guile, Vice Chair Hayes, members of the committee, thank you for the opportunity to testify. My name is Jamie DeMarco. I represent the Maryland Nurses Association. We urge a favorable report, and we thank Chair Beidel for bringing this important legislation. I appreciate the conversation that was happening earlier that not all private equity is bad and not all private equity acquisitions are bad, but the horror stories do exist. And there is still a very real problem that needs to be addressed and we believe can't go unaddressed. We hear stories about private equity purchasing a medical facility and instead of managing it to provide quality, affordable care over the long term, squeezes it to get a cash flux for that private equity and then walks away, leaving debt and burdens on that hospital facility. Examples include selling the land underneath a hospital. A hospital could own its land. Private equity purchases the hospital, sells the land, takes the money, already gets a return on investment for themselves, but then leaves the hospital having to pay rent on a property they used to own. This affects our members because when hospital budgets are strained, they cut staff. And we have data showing that private equity acquisitions are highly associated with reduced staff, which loses livelihoods for our members. And for those who remain, there's higher turnover, higher burnout, higher stress loads, higher patient to nurse ratios. We again appreciate that not all private acquisitions are bad or need to be blocked, but there is a real problem that is getting worse. And we think this bill is a very intelligent and well thought out approach to addressing that problem. We urge a favorable report.
Thank you, Jamie. Let's go to Stephanie.
Thank you, Acting Chair Guile, Vice Chair Hayes, members of the committee for this opportunity to testify in favor of Senate Bill 494, and special thank you to Chair Beidel for sponsoring this important legislation. I'm Stephanie Clapper, Deputy Director at Maryland Citizens Health Initiative, and our mission is achieving quality, affordable health care for all Marylanders. The increased oversight by MHCC that this bill provides will be critical to help protect consumers as private equity ownership in the healthcare sector can be associated with increased costs and harmful impacts to quality. Private equity investments in physician practices are increasing in Maryland, with over 50% of all physicians in Prince George's County and over 60% of urologists across the state affiliated with private equity as of 2021. Containing costs while maintaining quality is increasingly important, as a recent poll by Kaiser Family Foundation found that 1 in 3 adults say they have skipped or postponed getting needed health care because of the cost in the last 12 months. Increasing transparency and oversight of mergers and acquisitions of healthcare facilities and physician groups will help ensure that Marylanders have access to quality, affordable health care. Thank you to the committee for your leadership on healthcare in Maryland, and we urge a favorable report for Senate Bill 494.
Thank you, Stephanie. Kimberly?
Good afternoon, Acting Chair DeGile, Vice Chair, and to our sponsor, Senator Beidel. I'm Kimberly Robinson on behalf of Care First Blue Cross Blue Shield. I'm here favorable with amendments on the bill today. Also, thank you to Dr. Jacobs, who has been in conversation with us about the bill. The things that we are concerned with the bill start really with a matter of process. Care First Blue Cross Blue Shield, as the state's only statutory not-for-profit health service plan, is already subject to a review of any of our business transactions by the Maryland Insurance Administration. And so we did approach the Healthcare Commission about wanting to make sure we weren't creating a double regulatory scheme where our business transactions were concerned. And so Dr. Jacobs did recognize the fact that the MIA does have that primary statutory responsibility to regulate the work of our business. And we are discussing ways to make sense of how to take the additional look that this bill seeks to have about transactions, business transactions, and perhaps incorporate that into the statute with the Maryland Insurance Administration. We would suggest keeping the Maryland Insurance Commissioner as our primary regulator, who then would work in partnership with the Healthcare Commission on any type of review that expanded the scope so that they could bring their expertise to the work overall that the MIA is doing where we are concerned. And so we look forward to continuing that conversation to ensure that we are able to move as nimbly as one would want to when a business transaction is on the table, but also provide the full look as it is necessary. And I will leave it there, and I'm happy to answer any questions.
Thank you very much. Matt?
Madam Chair, members of the Senate Finance Committee, Matt Celentano, today here on behalf of the League of Life and Health Insurers in support of Senate Bill 494 with amendments. First and foremost, we want to thank Dr. Jacobs and the MHCC team for the collaboration. We've had multiple calls. We've passed along discussions and had discussions on multiple sets of amendments. The conversations continue. We are committed to continuing those talks. But like many people in this room, including I think the people that are come after, we're concerned about the impact of private equity in healthcare and the cost and quality measures that are impacted. In the past decade, we've seen an explosion of private equity in ownership. And after acquisition, it's common to see dramatic increases to provider group patient volume with higher prices, staff cuts, and prioritization of higher margin procedures. We're getting away from value. This cost cutting impacts patient experience and is certainly focused on the shorter term to sharpen balance sheets at the expense of quality. We applaud the focus of Senate Bill 494, but we want to continue the discussion to make sure that we have the right sized amendments to make sure that carriers aren't brought into a scheme that doesn't really impact them and isn't the focus of the bill. So we urge a favorable report with amendments. Thank you very much.
Thanks, Matt. Allison.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor. I'm here on behalf of Kaiser Permanente. I also want to thank the MHCC for their collaborative nature. I'm mostly here on behalf of Kaiser as a health system today rather than a payer. We do share a number of the concerns related to private equity, although Kaiser is a nonprofit system and this bill is more expensive than private equity. Our amendments are sort of in three categories. One is bringing in some language from the model bill that we thought would be beneficial to this. Second, we are somewhat concerned with the scope. Is there a chance to lower the scope? Senator Lamb, along your line of questioning about the monetary threshold, $10 million, that was a concern to us. And third, just wanting to make sure that there is protections in place for competitively sensitive information. So with that, happy to continue to work with the sponsor and MHCC and everybody here. Thank you.
Thank you, Allison. Senator Reedy.
Follow up on my line of questioning. I definitely understand the need for balance, and so I think very open to the conversation. One thing I am concerned about is that there are times where investments or consolidation is sought as a way to scale. And we have access issues in some parts of our state, not all, but particularly on the sort of the primary care and some of the other sides, we have issues with access. So looking at, we obviously have the insurance folks here supporting the bill. I think there's concern about costs rising, which is totally fair, and we want you to be concerned about that. At the same time, it concerns me that we really want good quality care and good access to care. And so I'm worried about going that direction. So I don't know if someone can, and maybe Jamie, maybe it's you, but it can help, can help me with this, because how do we, I think the bill's well-intentioned. If we were in a totally free market setup, I would be against the bill, but because we have this all-payer system and we have, obviously it's all balanced, right? Mm-hmm. So we hear that all the time. I even have people come on my bills that are excellent bills, and they oppose them for some reason because they want balance. So, I don't know if you could speak to that issue. How do we maintain that balance? You talked about the concerns of private equity, mm-hmm. but it's not just private equity that would be subject to this bill. So, please.
Yes, thank you for the question, Senator, and we share your interest in balance and making sure that overreach doesn't happen here and that it's a measured approach. We appreciate Chair Beidel saying that she's happy to work with everyone coming with favorable amendments to find that, to talk about scope, to talk about how we can not, make sure that this is creating duplicative processes where processes already exist. So I think you have those amendments in front of you and favorable with amendments of some ways to create more balance, and we defer to the chair and the sponsor in sort of selecting among those. And I also think that by having a review process that the Maryland Healthcare Commission looks at every project, they can decide which ones, this is beneficial, this is going to provide scale, and give it the approval to move forward.
But do you think that they'll know better than the people who are making those deals?
Well, I think that sometimes there's someone who owns a facility who, is presented with a pile of cash, and it's really hard to turn it down. Even if the person acquiring it isn't looking to scale, they're just looking to sell for parts.
I wonder if I could maybe ask one more question to Mr. Celentano, because I think he would like, I'm just betting he would like to weigh in on. Can you talk to me about why you all are at the table here that is not a cost argument? Or is there, your job is partly cost, but can you go beyond? Why should I, if I'm concerned about quality and access, why is this bill the right, why is this approach right? Obviously, we're going to make tweaks to it, but I'm assuming.
So, Senator Reedy, I think I've said this to you a bunch of times, but health insurance is really expensive because healthcare is really, really expensive. And if we don't take dramatic actions to bend the cost of healthcare, then we're not going to be able to have accessibility in the marketplace. Private equity is of concern to, I think, even the folks who are going to come up in opposition to this bill, because it is the squeezing of care to maximize profit. And because of that, we have seen costs explode in a lot of areas in the healthcare system. It's why we had Senate Bill 515 earlier today.
Well, if we're squeezing care, how is the cost exploding?
Because they're charging more and you're getting less quality. So the people are end up getting sicker and they're utilizing more services in the long run, which is going to cost everybody more. So to have a balanced approach to figuring out what is the right way to address this kind of situation is something I think we should continue to discuss. As an insurer, one of our responsibilities is to make sure that we can have as many products as accessible to as many Marylanders as possible. And if we don't, like I come back to, if we don't address those exploding healthcare costs, we're not going to have a product that will be accessible to Marylanders.
Thank you very much.
Don't see any other questions for this panel. Thank you very much. Next, we will call up the unfavorable. Joe Bryce with Dr. Ben Lowentritt, Steve Wise, and Andrew Nicholas. These are the not friends of the chair.
Oh, man. Now, that's unerasable on the video.
All right, Mr. Wise.
All right, thank you, Madam Chair, Mr. Vice Chair, members of the committee. Steve Wise on behalf of MedChi. I want to first thank Senator Bidle for talking with us a couple of times about this, Dr. Jacobs and Tracy DeShields as well. We are opposed to the bill, but not the idea. We just think this needs to be discussed and thought through a little bit further because it is a big regulatory change. I'm going to give you a couple of examples of things that we think need to be talked through a little bit further. The insurers who were just at the table in support of the bill, it's a question mark to us whether they're covered as someone who would be looked at if they were to acquire a physician practice. We think they should be covered. 90,000 out of 900,000 physicians in the country are now, according to an article, part of the United Healthcare Arsenal, as they called it. More so than hospitals in recent years, the health insurers are acquiring physician practices. So if we're going to be looking at acquisitions, they definitely need to be included within the bill. Private equity, which was talked about a lot, is part of what this covers, but it really covers all acquisitions. And those physician practices that are bought up in surveys by the AMA, that's driven by the fact that their reimbursement rates are so low. So when we talk about cost cutting, the insurers talk about that. That's also a cause of this. It's not just a symptom. So when the executive director, another part of the bill we think that should be looked at is when he reviews these proposals for acquisition, he should also be considering the things that drive the physician practices when they want to be acquired, because it's those low reimbursement rates that are a factor in that. So thank you for the opportunity to comment. We look forward to continuing to work with the sponsor and the MHCC.
Thank you, Steve. Doctor, you want to go next? Go ahead.
Oh, sure. Thank you. Good afternoon, Madam Chair, Vice Chair, and Senators. I really appreciate it. My name is Ben Lowentritt. I'm a urologist practicing in the Baltimore area, former president of MedChi, and here today as president of the Maryland Patient Care and Access Coalition, asking to respectfully oppose Senate Bill 494. My practice is Chesapeake Urology Associates, one of the founding members of MPCAC more than 20 years ago. And MPCAC is a group of independent medical practices that care for hundreds of thousands of Maryland patients each year in our community-based practices and employ thousands of Marylanders. We share the committee's concern about protecting our system, but we had hoped that the legislative process and frankly the studies that led to it would have been a little bit more of a collaborative discussion. There was really no opportunity for stakeholder discussion up until the very last minute. And this bill was presented, days before session, basically, without any chance for input. Now we have to deal with legislation that really fails to respond to the realities of the Maryland healthcare market that medical practices, hospitals, and others now compete in. We've heard about Maryland's consolidation, and I think we need to just to reiterate, the Maryland physicians are paid at roughly 85% of what the national average would be. So that is a part of driving this. Our specific concerns with the bill include the revenue thresholds, the lengthy review periods, and broad approval authority. And the effect of this would be to effectively allow only hospital systems and major insurers with their larger pockets and presence to absorb those costs. So you would effectively be driving investment outside of Maryland for anything outside of consolidation within what is known to be more expensive hospital and insurer-based care. So in closing, I just want to say that I hope we can issue an unfavorable report, and I look forward to engaging, though, because we do want to support future efforts to solve this problem.
Thank you very much, Dr. Andrew.
Absolutely. Thank you so much, Madam Acting Chair, Mr. Vice Chair, Madam Chair, and members of the committee. Just for the record, my name is Andrew Nicholas, representing the Maryland Hospital Association here in extraordinarily respectful opposition to Senate Bill 494. First, I do want to acknowledge the MHCC and Madam Chair reached out to us proactively on this bill. We've had several conversations, and we really appreciate that engagement. We do share a number of the concerns that you heard from the proponents panel around the increased private equity investments in the healthcare landscape and potential negative implications thereof. However, we just have concerns with the bill as drafted. It is very broad, as you've heard. And so while we appreciate that acute care hospitals are exempted under the bill, many of our members, as you know, are part of larger healthcare systems, which are not exempt. And because, Senator Lamb, as you mentioned, the threshold for this review is only $10 million in assets, virtually every transaction of a healthcare system that's named under the bill would be subject to this review. And we do think that represents a fairly significant burden for such low-risk transactions as leasing office space. And I think that the breadth of the bill actually may hinder its ability to accomplish its purpose by casting such a wide net. It could be harder to actually target the private equity investments that the bill's seeking to address. And so, with that, while we are opposed, I think the main reason I am here at the table is to reaffirm our commitment to working with the committee and with the MHCC on this issue. I think that through additional thoughtful stakeholder engagement processes, there is an opportunity to develop a more targeted bill that effectively addresses the issue that the bill seeks to address. So, thank you.
Thank you, Andrew. Do I have any questions for this panel? Seeing none, thank you very much for your time. Next, we have one information only. Dan Shattuck.
Good afternoon, Acting Chair Guile, Vice Chair Hayes, and Senator Chair Beidel. I'm here today on behalf of Bricado and Shattuck. We represent a number of healthcare providers, really that represent the whole spectrum, whether they're small practice groups or statewide professional membership groups. And we've heard today in this committee and other bills, there's a real concern about workforce and making sure that the provider workforce is here in Maryland, is able to sustain their business I don't want to repeat a lot of what's already been said by the panelists before me. We have, some questions about this bill, the scope, the breadth of it, some concerns that where do providers go if they're looking to be purchased, or if they want to try and increase their scale or build up their ability to negotiate fairer rates with the insurers. If that purchase is denied, where do they go? Where do the big pockets, remain? And I think that's a real concern, and I think that's where we want to be part of the discussions to continue to shape this legislation. I think it does need a little more time and more input from across the whole spectrum of the workforce. It was reassuring to hear the health insurers talk about wanting to make sure that they're able to offer as many products to the people of Maryland as they can. My addition to that is, well, on behalf of the providers we represent, we want to make sure that the providers are there to support those products. You can have as many insurance products as you want, but if the payment isn't there, if the reimbursement isn't there, if the workforce isn't there, then we have a bigger problem. So understanding the broad goal of maybe rooting out the bad actors, I think that's very laudable. We just want to make sure that we don't create a process that further complicates the landscape in Maryland. So with that, thank you.
Thank you, Dan. Do you have any questions for Dan? Okay, seeing none, that ends the bill hearing on Senate Bill 494, and I will give the chair. Oh, yes, well, we have one more bill left, right? Sorry. Madam Chair, would you like your chair back? All right. We will now call up Senate Bill 707, Mental Health Law, Danger to the Life or Safety of the Individual or of Others, Definition, Right to Treatment. Senator Reedy, looks like on your panel is Evelyn Burton, Michael Gray, and Laura Shears Coates. Is there anybody else, Senator, you wanted to?
Maryland is going to join.
Right, Michael Gray.
Oh, Michael Gray, yeah.
Yep.
Yes,
Okay.
Thank you. I'll
Yep.
start down here. They've hustled over because they had the hearing in the House today, too.
Oh, busy day.
See you.
You too.
All right.
I'm glad I made it.
Yeah, I'm glad you made it.
Some might still be.
Whenever you're ready.
Okay, thank you. Madam Chair, Mr. Vice Chair, and members of the committee, great to be before you today on a bill that's really very serious, about a very serious issue. Of course, we've been dealing with a lot of that today. But I think we have an idea whose time has really come. Senate Bill 707 would facilitate access to treatment for those with serious mental illness, such as bipolar disorder, severe bipolar disorder, or schizophrenia, who are unable, because of their illness, to recognize that they are seriously ill and need treatment. The goal of this bill is to help provide timely treatment to prevent the current consequences of treatment denial that are being experienced. And those consequences include things as terrible as suicide, harm to others, incarceration, homelessness, and brain deterioration from psychosis. In addition to maybe a step down from that, which is frequent utilization of hospital and or law enforcement resources. What we're trying to do with the bill is really have a danger standard in the law. We have an AOT program that we created. Maryland was one of the last states to do this. But what we did not do is Maryland is one of only 2 states, along with the District of Columbia, that have no definition for the danger standard for involuntary evaluation and inpatient treatment. Those stats are according to the Treatment Advocacy Center study from 2020. The result of us not having a clear danger standard in the law is that there really is not a consistent interpretation of dangerousness across our state. Very often it is interpreted in the legal process, the AOT process, as requiring imminent danger, even though the legislature actually removed that imminent standard as a requirement for being committed back in 2002. And in addition, unlike 48 other states, Maryland has no explicit language specifying that the inability, not the refusal to, but the inability to meet one's basic needs constitute a danger to self. And 30 states actually have an even higher step of an even more severe step, I would say, of psychiatric deterioration standards that they set in law. In Maryland, danger is frequently considered. It's the reason and what I'm about to say was the reason we wanted to do AOT here. In Maryland, danger is frequently considered only explicit suicidal or homicidal behavior, with no consideration of the ability to meet your own basic needs or how often you are interacting again in the community with having a break that requires you to be hospitalized, or many times these folks end up being incarcerated briefly or even in a lengthy period of time, which not only is that really bad for them, also exhausts our resources, and it's very difficult for these families that care about them. So consequently, loved ones with serious mental illness who lack the capacity due to their illness of being able to recognize their need for treatment are often denied the timely treatment that they need. Untreated psychosis results in brain damage, and frequently, psychosis, of course, leads to the inability to recognize dangerous and unlawful behavior. Our county jails report being overwhelmed with up to 50% of inmates having some sort of mental illness, and some of the ones dealing in this very category. We have what are called super utilizers in our hospitals that utilize the emergency room frequently. It's actually interesting. I found some interesting stats on hospital utilization. From MedStar, they had a report from a couple of years ago that showed 4 to 8% of patients visit the ER 4 or more times a year, which is between 21 and 28% of all ER visits. Now, that's not just people with this kind of situation. It could be other people that visit the ER 4 or more times a year. But the point is that group, if you're utilizing the ER, and many of these folks are utilizing the ER oftentimes in some of our areas 5, 6, 7 times a year or more, that is helping to drive our ER problem. It's certainly not the only issue, but it's a big suck of resources. Our state psychiatric hospitals are overwhelmed with court orders to restore competency and no longer accept civil patients for treatment to present behavior that can lead to criminalization. Maryland families are left to helplessly wait for senseless tragedy to occur to establish danger. They have to wait for something really bad to happen, even though we know we can see it coming when someone really cannot take care of themselves and function. So I also, though, know we have to be careful. We have to be very careful where we draw that line. And if we were one of 25 states that had no danger standard, this would be, I think, a different issue. But we have 48 states that have shown us that you can define the danger standard in law, and you can get good results. So we can talk about where that line needs to be, but this bill clarifies that the danger need not be imminent, that personal, medical, and psychiatric history be considered when available as we're adjudicating this. It defines danger to include that as a result of a mental disorder, there is serious risk of bodily harm to self or others, or the inability to meet basic needs, or lacking the capacity to make treatment decisions, and without treatment, they would likely meet the previous criteria. The fiscal note lays out some interesting potential objections, and I wanted to go through that. We have opposition from some groups, and look, everybody here, I believe, that comes to the table, both those that support this bill or have desire for some amendments, or even those that oppose the bill, I believe everybody wants what's good, what's best for our loved ones, our members of the community. There is sometimes a philosophical difference, and I acknowledge we have to be very careful with these items. But part of the fiscal note that says it's going to cost some funds is the Office of Public Defender saying they would have to take on more work. But when we have these individuals who are, when there's no danger standard and we have people wandering around and getting into trouble, that is a burden on the Office of Public Defender. When people with undiagnosed or properly treated mental illness enter the criminal justice system for crimes related to that behavior, particularly if the behavior at times is intermittent, the public defenders already have to serve that population. So this bill is designed not to increase the number of hospital commitments, but instead we want to facilitate earlier, more effective treatment for the same individuals who would otherwise end up in the criminal justice system and have to be represented often by public defenders. The state, talk about the cost to the state. Under current law, individuals are often not hospitalized until they reach a very acute stage of mental illness. So we talked about these frequent utilizers. So when we don't deal with it and it gets worse and worse, they end up in a situation where it requires these extended hospital stays, which we all know we're all trying to reduce the size and scope of. We're trying to bring down cost. We always also talk about we want to get better outcomes. Obviously, we want to bring down costs. Enabling hospitalization at an earlier stage of psychiatric deterioration would allow these individuals to be stabilized with shorter stays, reduce the risk of repeat hospitalization. Ideally, ways that you could avoid hospitalizations altogether for some. So prevention of hospitalization and prevention of criminalization are what's known as, we don't have dynamic scoring on these fiscal notes. We have static scoring. So it's very hard to calculate, but we can see that when MedStar, for example, invested in MedStar, Sinai, and Johns Hopkins Bayview, made some very strategic investments in, MedStar calls it their ED MVP program, where they would really get very clinical about some of these frequent utilizers on the mental health side, but also some other people chronically ill. When they would invest, now they had to invest a significant amount of money to do this, but they still found savings. So imagine if we could reduce the flow of these really serious mentally ill individuals, get them the right treatment. It's the same argument we make for why we've debated, and of course I've sometimes not always been for this, but we have more of a generous Medicaid package. The argument's always, let's get people into primary care, let's get people treated early so they don't have chronic illness and ER visits. This concept is very, very similar. And then finally, local government savings. The fiscal note doesn't address this, and I understand that they don't project this way, but reducing criminal justice involvement in our county and city jails, it absolutely would be a saver. So I wanted to address that. Just in closing, and I know it's been a long day, but this is really an important issue for so many families. And we've had a lot of that today. We've had a lot of folks telling their story. And I know we want to get to the right place. Multiple state expert panels and stakeholder groups over several gubernatorial administrations. I know going back to the Governor O'Malley's administration, Governor Hogan, Lieutenant Governor Rutherford was very involved with my friend Evelyn here on, and we worked on a lot of issues in the Hogan administration. And I know the Moore administration. There's been recommendations that the danger standard be defined, at least in some way. But yet adult sons, daughters, wives, and husbands still die by suicide after being refused involuntary hospital admission to treat psychosis because we have such a often narrow interpretation. And I get it a lot of times. The courts, they want to be very careful, and we want them to be careful, but they need guidance. A danger standard that promotes timely treatment would improve outcomes significantly, help prevent criminalization. We talk about the school to prison pipeline. There's a hospital to prison pipeline, unfortunately, with this population because it's just so difficult to deal with. Prevent criminalization, save lives, and ultimately we want to promote recovery. That's the goal. So I know there's opposition. We're open to discussing options. And I look forward to an ongoing discussion with the stakeholders about this bill. It's crucial that we prevent tragedies, reduce criminalization and homelessness, and save lives. So I'd respectfully request a favorable report on Senate Bill 707 and turn it over to my panel.
Thank you very much, Senator. Evelyn?
Thank you. Been a long day. Hello, I'm Evelyn Burton, the Volunteer Maryland Advocacy Chair for Schizophrenia and Psychosis Action Alliance. I ask you to please look at the big picture of the devastating consequences of our current danger standard, which prevent early treatment of psychotic illnesses and creates a literal highway to criminalization. Our jails and prisons are overwhelmed. Please see the MCAA testimony. State hospitals now only treat forensic patients. That leaves high-need ER patients to cycle in and out of our community hospitals, costing millions of dollars in Medicaid funds and increasing ER wait times. Over the last 23 years, families have asked 4 times for legislation to provide timely treatment before tragedy. Legislators wanted all the advocates to agree, which will never happen in this issue. 3 times instead, stakeholder groups were established, but 100% support never happened. And each year, the suffering, the incarcerations, and the suicides continued. We have enough recommendations. It is time to pass something that at least the majority can support. The first paragraph of this bill is based on the 2014 Stakeholder Group Report. Section C3 is based on the 2021 Stakeholder Group Report. And Section C4 is based on the Equitas Project Report endorsed by the Conference of Chief Justices. In 2023, when I worried about the adequacy of the amended AOT bill, Delegate Pina Melnick said, "Don't make the perfect the enemy of the good. It can even be improved next year if you want more stakeholder groups, but it will save some lives now." Families ask that at least the passage of key sections of this bill be done this year to reduce the criminalization, the suffering, and save the lives of my loved ones. Excuse me.
Thank you.
But I will take questions.
Thank you for your testimony, Evelyn. Michael.
Thank you, Madam Chair and Madam Chair and Mr. Vice Chair. My name is Michael Gray. I'm with NAMI Maryland. That's the state organization of the National Alliance on Mental Illness. We're here to ask for a favorable report on Senate Bill 707. We thank Senator Reedy for bringing this bill and the committee for considering it today. Now, this is a tough topic. We're not going to pretend otherwise. This is a difficult topic. This issue of civil inpatient commitment is difficult because it asks the court and healthcare providers to balance a person's God-given and legal right to personal liberty with medically necessary treatment that will save their life, certainly improve their life. And this is going to be an issue where you're going to hear arguments very similar to what this committee heard for many years on AOT. This is different from AOT, though, because AOT was creating a new program. This is not near as heavy a lift. This is just clarifying current law, a very, very important clarification that will save lives. The current law is so vague as it defines dangerousness that it leads to inconsistent interpretations around the state. Now, that's not just my opinion. It's not just NAMI's opinion. It is the part of the recommendations from the 2021 stakeholder work group that Evelyn mentioned in her testimony. We urge the committee to take a look at that work group report. It had some great recommendations, including pieces that are almost verbatim to parts of Senate Bill 707. The current law denies a type of due process that 49 other states give people who are subject to involuntary commitment hearings, and that's substantive due process, the reason that the state must give before depriving someone of liberty. Other states have that. Maryland does not provide that clarity, but Senate Bill 707 would. So we urge a favorable report, and NAMI looks forward to working with committee members and certainly organizations in favor and opposed to this bill to reach a compromise that can improve lives. Thank you so much.
Thank you, Michael. Laura.
Good evening, everyone, and I appreciate the opportunity to be here to testify today. My name is Laura Shears Coates. I have a master's in social work. I also own and operate an outpatient mental health clinic in the state of Maryland that currently serves 781 adults and children with severe mental illness. However, I'm here on a more personal note today. My only sibling, his name was Joshua Carey. He suffered from schizophrenia for several years. I tried desperately to get him treatment that he needed. Part of his illness was he was very scared to take needed medication. My brother's schizophrenia deteriorated to the point he started having epileptic seizures that he never had in his life, and they diagnosed him with brain deterioration from not taking medication from several years. At that point, it was more critical than ever. He now takes his mental health medication in conjunction with seizure medication. From the time he started getting the psychotic seizures, he had 276 admissions into an ER and was sent back to our home, despite the fact that BHA determined he should live in a skilled nursing facility the rest of his life due to his brain deterioration. Every time they sent my brother home, I would beg and plead, my brother is sick, he's gonna come home, he's not gonna take his medication, he's going to have another psychosis seizure, he's gonna end up dead. They kept apologizing to me time and time again, we're sorry, we understand, our hands are tied due to the law, your brother doesn't have intention to harm himself or others. My brother didn't have intention to do anything because he didn't even know he was mentally sick. A court judge ordered me as his full legal guardian and determined my brother had no brain capacity to even make decisions related to his mental health or his medical care, and that still meant absolutely nothing. 48 hours before he died, he was discharged from Baltimore Washington Medical Center. 2 days later, he had a psychosis seizure that resulted in his death. His autopsy report reads that he died for failure to take life-saving medications. I came here several times before to the AOT law. Thankfully, that's now passed, and that's something we don't have to fight. But I pray that you guys can change the imminent danger standard so somebody else's family member doesn't have to experience what we have. Thank you.
Thank you very much. Do I have any questions for the sponsor or this panel? Seeing none. All right, thank you very much. Calling up another group of favorables. We have Philip Nash, Emilian Ireland, and Liz Montaner.
Liz couldn't make it.
Oh, well, thank you, Evelyn. Appreciate it. Philip, yes, you can go ahead and get started.
Thank you, Madam Chair and committee members. My name is Phil Tajitsu Nash, the stepdad of Matthew Heiner. My wife, Emmy, and I will be giving sequential testimonies in support of S707. Our son, Matt, was a high-functioning young man with a steady girlfriend, an apartment, a car, and a job he loved. Through no fault of his own, he lost everything. 2 years ago, he needlessly died a painful death because of untreated schizophrenia. Though his parents tried to get him the treatment he urgently needed, Maryland laws require that he consent before receiving medication. In his delusional state, he did not realize he was ill and would not consent. As his untreated disease got worse, Matt's delusions became threatening. On one occasion, to quiet the voices that tormented him, he smashed things in our house. He suspected that we, his parents, were alien lizard creatures from another planet. We went to court to help him get the treatment he needed, but thanks to Maryland's current law, he simply refused all medication when he was taken to the hospital. We sought help from Dr. David Picard, a schizophrenia expert, who talked with Matt and believed that he would benefit from antipsychotic medication. Matt moved to an apartment, but soon he was evicted for starting a huge bonfire just outside the building. At his next apartment, Matt was cited by a safety inspector for disabling a smoke detector and illegally storing an explosive device. At the court hearing, Dr. Picard said that Matt needed treatment. Without it, he was a risk to himself and others. Matt presented himself as a calm young man, arguing that the explosive material was just below the legal amount. The judge said he was impressed by Matt's argument and ruled from the bench that, quote, Matt has the right to remain psychotic if he so chooses, unquote. Unfortunately, those words were Matt's death sentence. Despite the explicit warnings from Matt's doctor and the safety marshal, the judge arbitrarily decided that Matt did not pose an imminent danger to himself or others. Tragically, the judge was wrong on both counts.
Good afternoon, and thank you for listening to our testimony. I'm Matthew.
Could you just move the microphone over a little bit?
Course,
Yeah,
of
thank
course.
you.
Good afternoon. thank you for listening to our testimony. A few months after his day in court, when the judge ignored the medical advice and decided that Matthew was not a danger to himself or others, even though he had been cited for having an explosive substance, not devices, right? Explosive substance in his apartment, and had disabling the fire alarm, and had been evicted for a bonfire. Obviously, he is a danger to others, even though he didn't mean to be. After that day in court, Matt told us he was leaving for Colorado. I asked him, Matt, why are you going so far away? How will we visit you? Because he couldn't take care of himself. We had to get him groceries every week, make sure that he was okay. He turned away from my gaze and said softly, "It's for your own safety, Mom." At that moment, despite his psychotic state, our son saw and bravely named what the judge and Maryland laws had refused to see. He was a danger to others. What was the judge thinking? A bonfire, explosive substance? And he'd had responsible jobs before that. I will always be grateful that Matthew wanted to protect us. How I wish Maryland law had protected him. After he'd been in Colorado only a few months, I got a phone call that my son had died by suicide, having set fire to his camper van. The raging fire could easily have spread to neighboring homes and caused many deaths. In the explosion, Matthew received severe burns over 96% of his body. When the police arrived, Matt told them, "I tried to kill myself and failed. Please shoot me." Instead, he was taken to a burn unit. Talk about expense. He was airlifted halfway across the state. The doctors realized he would not survive his horrific burns and began treating his pain while they tried to contact family. They had to intubate him to keep his airway open. They also had to make at least a dozen long and deep incisions all over his body to prevent the massive swelling of the burned tissue from constricting his lungs and not allowing him to breathe. At midnight, unable to locate his family, they allowed his suffering to end at last. Is this the freedom to choose that Maryland law has in mind when deciding whether a floridly psychotic person may refuse treatment that both family and doctor are urgently requesting? It is cruel and barbaric to withhold treatment from a person who urgently needs it, has scientific support, that diagnosis from experts that he's psychotic, but this person cannot understand that they are ill. Our family must live each day knowing that if only Matthew had received treatment, he might still be alive. He was a responsible member of society. He was brilliant. He had a very responsible job. He was a big success until he got this disease, and then we couldn't get any help for him. He never got in trouble with the law before, only after he became psychotic, and the system was blind to his suffering.
Thank you. Thank you very much for your testimony. We're very sorry for your loss.
Thank you, dear.
Do we have any questions for this panel?
I welcome your questions.
Thank you. I'm not seeing any. Thank you very much for your time. We appreciate it. Okay, we will now move to some unfavorables. We have Kimberly Watts, Maryland Office of the Public Defender, Sanjeev Varghese, Dan Martin, Dan Rabbit, Michelle Livshin. Looks like we got room for maybe one more up here. Dara Johnson. Maybe we can get one more. Courtney Bergen.
Got a big table.
Yeah, it looks like we've got everybody. We're able to squeeze all the unfavorables up here. Okay, whoever wants to start, go right ahead. We can start on the left over here. Sure. Go right ahead.
My name is Kimber Watts. I'm the Chief Attorney for the Forensic Mental Health Division from the Office of the Public Defender. I'd briefly like to address our staffing needs. I disagree with Senator Reedy's assertion that this won't really change our staffing needs for several reasons. First, because it might result in fewer people being detained on minor charges, but only time will tell. More to the point, it will certainly increase our staffing needs in terms of the number of hearings that we will have to have, because if more people are hospitalized, and certainly this is a pathway into hospitals, then more people, we will have to have more people to represent them, and they get hearings every 6 months. Further, we have some concerns about whether this will decrease pathways out of hospitals, particularly when you look at the provision that requires people to be able to provide for themselves due to, and includes, being due to poverty. We have an insufficient number of, well, hospital beds for one thing, but step-down resources for people. And so if they don't have places to go, it will be challenging to get them out. So this will certainly increase our workload. That being said, I'd also like to say that we certainly understand the tragedy of psychotic disorders and the impact that those have. But this bill doesn't limit itself to those psychotic disorders. It doesn't limit this definition to those worst case scenarios. It encompasses not only anyone with a mental disorder, but anyone in this room who may develop PTSD or, as you're aging, develop dementia. And so we feel like it's overbroad. Thank you.
Thank you very much. Just go right down the line. Yeah. Can you move the microphone a little? Thank you.
Good evening, Chair, Acting Chair, Vice Chair. I'm Sanjeev Varghese with the Deputy Chief Attorney in the Mental Health Division. We urge an unfavorable report on this bill. There is a lack of evidence-based empirical evidence to support the language change that's sought here. In 2021, the work group that worked on this, on civil commitments, did not come to a consensus on the language for dangerousness, but they did come to a consensus on asking for more data to be secured as to the civil commitments. The work group, that hasn't happened. This bill would actually cause a greater shortage of beds. That is an issue we currently face. By changing the definition of dangerous to allow this broader, indeterminate, undefined terms to include dangerousness would create a greater influx into these psychiatric facilities. In the 9,000 or so cases that we represented for the Mental Health Division last year, only 125 individuals were released at a hearing. That's at a hearing where the ALJ is using their understanding of dangerousness as to whether or not to retain somebody. The gravely disabled standard has already been applied in the matter of JCN. The Maryland Supreme Court effectively incorporated gravely disabled standard as the existing criteria for civil commitment. The court affirmed the ALJ's finding that JCN was dangerous due to her refusal to take her necessary psychiatric meds, her somatic meds, and her delusion about resuming her PhD at Yale, and her denial of having a mental illness. None of those were imminent. None of those were causing her to be a danger at that specific moment. We've had individuals certified and brought in because they were speaking gibberish. It was a woman from Ethiopia speaking Amharic. We had a transgendered teen who was certified because his parents believed he was exhibiting symptoms of psychosis. His symptoms were his gender identity. We urge an unfavorable report.
Thank you very much. Dan?
Good evening, Chair Beidel, Chair Guile, Vice Chair Hayes. The jokes keep coming. My name is Dan Rabbit. I'm a policy director at Behavioral Health System, Baltimore. We serve as the local behavioral health authority in Baltimore City, and we stand in very respectful opposition to SB 707. The stories that the proponents shared are heartbreaking. Our hearts go out to them. I've been working in behavioral health my whole career, and I have my own stories in when people deteriorate and don't get the care that they need. It is tragic. But civil commitment is a very serious decision, and it needs to be balanced. And the bill before you is not balanced. There was this work group in 2021 that led to some regulations being promulgated. This bill goes far beyond those regulations. There was a bill in 2022 that this body rejected. This goes beyond that bill in 2022. It includes other provisions. The provisions around non-imminent risk and the possibility that your deterioration could lead to danger at some point in the future is very broad. Really, like anyone who is having symptoms of a mental illness could deteriorate and have into a risky situation in the future. And so we think that that really puts too many people in a position to have their civil liberties removed. You know, a civil commitment, like you're handcuffed and taken somewhere against your will, that has its own impacts, negative impacts on your mental health, and really should only be done as a last resort. We feel that we should go back to the recommendations from that work group, get more data, improve the training so that the standards that we do have are well understood, and go back to that consensus regulation that came out as a starting point, not start here far beyond bills that have been considered before. Thank you.
Thank you very much. Dan?
Yeah, thank you. Madam Chair, members of the committee, Dan Martin with the Mental Health Association of Maryland, also here in respectful opposition to Senate Bill 707. Like we've been saying, this bill defines for purposes of involuntary commitment or evaluation danger as including a non-imminent risk of potential future psychiatric deterioration. And as folks have been saying, the question of how to define this is a long-standing debate, and it's something that led the Behavioral Health Administration to bring together a really inclusive process in 2021 to recommend a new definition. And that process included consumer and family advocacy groups, behavioral health providers and professionals, legal rights groups, hospitals, people with lived experiences, and more. And in the end, not everyone got what they wanted, but there was a definition offered that was agreed to by a majority of the participants. And this definition in this bill is not that definition. In fact, the psychiatric deterioration component of this bill was discussed and roundly rejected as overreaching. And I'll just quote from that actual report right now. The issue of whether the criteria for involuntary commitment have been met in order to detain someone against their will should be based on current and acute issues present for a specific individual, not because of the possibility that the lack of immediate treatment may lead to future harm or treatment resistance. And again, it's just because it would subject an overly broad population to involuntary commitment unnecessarily. Just because someone's symptoms are worsening doesn't make them a danger or mean that involuntary hospitalization is the appropriate level of care. And I'm just gonna, I have some other testimony here, but I'm just gonna skip that because I just wanna make sure that I get this in time. You know, I too feel really a lot of sympathy for the family members that have spoken here today and the family members that are going to be speaking. Their stories are heartbreaking, and I feel for them because I'm a family member too. You know, my sister-in-law has been living with schizophrenia for years. It's been really hard for my family, for my brother, for her, and you know, it's a really challenging situation. I understand what people are going through, but I just want to say that, you know, not all family members support, you know, expanding involuntary commitment in this way. Not one person or one group speaks for all family members. And I just, again, wanted to kind of happy to work with the sponsor and with others to kind of come to some kind of compromise based on the report that came out in 2021. And thank you for allowing me to talk.
Thank you, Dan. Dara, is that right?
Michelle.
Oh, Michelle.
Lifshin.
Oh, sorry. Yes, Michelle, go ahead.
Thank you, committee members, for the opportunity to be heard today. My name is Michelle Lifshin, and I'm representing Honor Own of Maryland, and we're opposed to Senate Bill 707. The proposed standard would be based on a prediction of substantial risk of what might happen in the future, instead of an assessment of the current safety status and available voluntary supports. Use of emergency petitions would no longer be a last resort. Being EP'd makes individuals in distress go through a traumatic, isolating process where they're forcibly restrained by police for transport and waiting for hours in crowded emergency departments to be evaluated or admitted when the danger is not imminent. Worse, they leave the hospital facing the exact same scarcity of accessible community services. In our written testimony, we have stories from peers who were seeking support from loved ones and providers, but were instead restrained and isolated through hospitalization. And I just want to read a quote from one of those stories. I was emergency petitioned at 19 years old because I refused to take medication that caused troubling side effects. I didn't scream, curse, and I didn't threaten to do anything to myself or anyone else. The therapist claimed I would become a danger to myself or others. And police came, slammed me into the car door, handcuffed me as tight as possible. And in the hospital, I experienced assault, seclusion, and humiliation. I still have flashback nightmares and horrible intrusive memories. It will likely haunt me for the rest of my life. These scars last a lifetime, creating fear, mistrust, and disconnection from the behavioral health system. In the 2021 Behavioral Health Stakeholder Work Group, The group broadly agreed that the EP process is too often inconsistently applied and used inappropriately, and instead we need more training around the standard and data collection. Broadening this dangerousness standard is not the solution, and it does not improve care. What does is making trauma-informed support services available and accessible in every community. That is how we help people stay out of the crisis cycle and move forward in recovery. We urge an unfavorable report. Thank you.
Thank you very much. Courtney?
Good afternoon, Madam Chair, members of the committee. My name is Courtney Bergen, and I'm an individual living with serious mental illness who has experienced involuntary psychiatric hospitalization. And I'm here in opposition to SB 707 because it puts me and others like me at increased risk of harm, abuse, and erroneous detention. SB 707 attempts to solve a problem that does exist, which is barriers with access to treatment, with a solution that doesn't actually address that issue. This bill doesn't create more resources. It's not going to create long-term solutions. It's a temporary fix that could interfere with my liberty and the liberty of others just like me in our communities. Having been, pulled out of school when I was still a child, pulled out of work sometimes due to erroneous detentions based on people's inferences about my dangerousness to others, inferences and stereotypes that were based on my disability, that were not based on actual facts, that were not based on the current circumstances. It put me at risk. It made me miss school. It made me miss work, and it put me at risk of homelessness, really. But it didn't solve the problem. I didn't get better. In fact, it made me more unlikely to seek treatment voluntarily. It made me scared of hospitals. It made me scared of doctors. It made me scared of any sort of clinician who was supposed to help me. Because I was scared of being detained. I was scared of being restrained. I was scared of being held down and involuntarily injected with medications that were making it so I couldn't breathe. I was refusing medications because they didn't make me feel good. They didn't help me. They didn't solve my problems. I did need support. I couldn't take care of myself. But that support wasn't available to me. And to so many people in our community, that's the issue. That long-term support isn't available. And those are the solutions we need right now. We need real solutions, not Band-Aids that patch a problem that isn't really the barrier that people are experiencing right now and that are going to put so many more in danger. So for these reasons, I'd ask for an unfavorable report.
Thank you very much, Courtney. Do you have any questions for this panel? Senator Reedy.
Thank you, Madam Chair, and I know it's a late night, but I just wanted to touch on a couple of things in question. For our friends with the Public Defender's Office, number one, I respect what you all do. I know I find myself on the opposite side of a lot of votes, but I do understand you have an important job and important role. I do want to clarify, the bill says except in the case of indigence, so we're making that exception, so we're not doing that. Is there any danger standard you would support? Either one of you,
I have not been the person from our office who's been on the work group. I know, unfortunately, Carolyn McCabe has been. She's not able to be here, so I can't speak to what we've advocated for in the past. But certainly, it's worth discussing. I think that there is a reasonable dangerousness standard. I'm just not sure. I think that this.
Yeah, I appreciate that. And then I think maybe a question for. Oh, did you want to answer? I'm sorry.
That's okay. I wanted to just add on to that. So the Supreme Court of Maryland already is utilizing that gravely disabled standard when they affirmed the ALJ's, the administrative law judge's order committing the person to the hospital. And that was for the individual who was delusional about continuing her PhD at Yale, that she could drive, that she didn't have an illness, that she wasn't taking her psychiatric.
How did that person get, I'm sorry to interrupt you, but how did that person get into court?
I believe that was through an emergency petition through her family.
Right, but what the standard was, the problem you're having is that most of the time, somebody, in order to be found dangerous, somebody has to have really done something very, very serious, as opposed to trying to find a standard where, when they are not able to take care of themselves. It sounds like you would think that that goes too far, it sounds like.
So for this is what the standard is right now in Maryland.
Okay. And then I'll only do one more question, thank you. I think maybe looking at, Dan, I don't know if it was you that referenced the report, or all of you referenced the work group. And I recognize, I think on this bill, there's four parts, and I think the fourth part, I understand the concern there, I think we wanted to have the discussion. But I do think we need more than just the first one or two parts of the bill, for sure, of the standard. It is true that the work group in 2021, my understanding, and I'm looking at testimony, and I went back to try to check this, they recommended language about the individual behaving in a manner that indicates that he or she is unable, without supervision and assistance of others, to meet her need or his need for nourishment, medical care, shelter, or self-protection and safety. And there was also bodily harm, serious illness, or death. So it sounds to me like we're not that far off. Would you dispute that when I say that, or?
Well, one quick note to your previous question about most EPs requiring very serious situations. I would love to see the data on like what the circumstances are that lead to EPs, because in Baltimore City and like in a lot of schools, like it actually doesn't seem like that hard to get somebody involuntarily committed. So I would wonder, like I think the OPD said, out of like 9,000.
Well, then having a specific standard would be better then, right? Because then the judge.
Yeah, we're not opposed to a specific standard. I will say the basic needs piece of the bill is less concerning to us than the lack of like the non-imminent and like risk of deterioration.
Understood. Whether we agree on that 100%, I get it. So I appreciate it. We can talk more offline. Thank you, Madam Chair.
Thank you, Senator. I don't see any other questions. Thank you very much for your testimony. We're going to now move to the virtual. First, let's do Laura Pogliano.
Yes.
Go
Hi,
ahead.
Thank you. Thank you for letting me testify today in support of the bill to revise the danger standard. My son, Zechariah Poliano, was severely ill with paranoid schizophrenia for 7 years before he passed away. He became severely debilitated, catatonic, unable to speak or walk, and nearly died of starvation and dehydration because the Maryland Danger Standard for psychiatric emergency evaluation was a barrier to getting him into a hospital for treatment. In April of 2012, he told me he had a broken back, brain disease, he had pulverized ankles, cancer, 100, illnesses that were psychosomatic, and he said he was going to bed and would get up when he healed. That led to a 2-week standoff where I sat by his bed, begging him to let me take him to a doctor. He was so psychotic he couldn't even respond rationally to what was happening to him. By the time I was able to get an emergency petition, he was so drastically ill that the police had to help him out of bed and carry him down the stairs. He was a 20-year-old athlete. That's how this deterioration happens. He then spent 13 days in Johns Hopkins Hospital before any medication because we had to have 3 court battles inside the hospital, remove his competency, medication over objection, and then a 48-hour appeals process, all while he deteriorated. I work with families all over the U.S., and here's the fear. Their child or loved one will either meet the danger standard by doing something violent and horrible, or their child will not meet the danger standard and will languish like my son did until he was so critically ill we had to intervene. This is archaic. It doesn't make sense. It doesn't serve families. In any other disability, I would have been held legally negligent for allowing a child to waste away in a bed, even if it was his own decision. But in this brain illness, I'm supposed to allow him to make a choice. That's the point I want to make. The danger standard has to be clarified and remedied so we can get help as soon as possible. It also costs the state about $400,000.
Thank you very much for your time.
Yes.
Thank you very much for
Thank you.
sharing your story. Thank you for your time. Okay, moving on to the next witness is Rayetta Michael.
Hi, thank you for allowing me to testify here today. My name's Rayetta Michael, and I'm co-founder of Help in the Home. We provide in-home and in-community care for people with complex mental health needs, and we've been doing this for almost 20 years. The involuntary treatment law needs and has needed over these 20-some years to have the danger standard defined. As it stands, it is funneling people with treatable brain diseases into, at best, marginalized lives in their parents' homes, in homeless shelters, at worst, into the criminal justice system and into graveyards. In my 25-year career, I personally have witnessed, well, I didn't witness the crime, but I knew the people. I personally knew 3 individuals who were murdered by people they cared for who had psychosis, and they were unable to get them the care they needed. One was Dr. Wayne Fenton. In the early 2000s, he was a leader at National Institute of Mental Health, and he wrote an op-ed piece for the Washington Post saying, in our society, we do not allow our adult parents with Alzheimer's disease to sleep on grates and have that choice. Yet, we are allowing our adult children who have brain diseases to do just that. And here we are over 20 years later, and the law is still the same. The other 2 people that I know whose lives were taken were parents who had their loved ones living with them and couldn't get them the care that they needed. I've also seen 2 men, like Laura Pagliano's son, whose families had to witness while they wasted away and became so emaciated and their limbs swollen before the crisis team would take them in involuntarily. It's torture to have families watch that. So I say these stories are not rare exceptions, and I ask you please to pass this bill in order to define the danger standard. Appropriate treatment can prevent irreversible medical harm, violence, and death, and it restores individuals to lives of safety, dignity, and hope. We've seen many people like Bethany get the care that they need and live good, meaningful lives.
Thank you. Thank you very much for your time. We appreciate it. Next, we have Sherry Snyder.
Thank you very much. I appreciate you giving me the time. For over 20 years, my family, many community agencies, and myself have unsuccessfully sought help for my 42-year-old son, Brian, who is severely mentally ill with schizophrenia and paranoia. Because he has not been an immediate danger to others, threatening them or threatening to kill himself, he has been turned away from intensive treatment and denied that. He's lived in a personal hell alone in a trashed, filled house, angry, without medical care. And that was until August 2025 when police officers stopped him outside of his home. Although Brian has never been violent, after 20 years of isolation with no consistent treatment, he became afraid and he threatened the officers with a knife. He was charged with multiple felonies, taken to the Allegheny County Detention Center, where he was found, surprisingly, incompetent to stand trial, and later, months later, finally assigned to get treatment at Finan State Hospital. It took committing a crime that Brian, without that brain disease, with treatment, he would never, ever have hurt anyone. He's never threatened that. But it could have resulted in death or injury to the officer or to Brian instead of getting the help he needed. And so now he faces serious felony charges, but he is getting help. We were in court yesterday, and the judge approved the huge improvement in Brian. Brian was so proud of himself. He's returning to Finan for intensive treatment. He has a wonderful, incredible treatment team. We have not seen this Brian for 20-some years, but he'll still be going back to court to face felony charges. So I ask you, please, as a parent, to support Senate Bill 707 to help people like my Brian, who really need help and had to commit a crime in order to get there. Thank you so much.
Thank you. Thank you very much for your testimony. Next, we have Joanne Connors, favorable.
Hi, can you hear me?
Yes.
Okay. Good evening, Senators. I was diagnosed with schizophrenia 30 years ago, And when I'm on medicine, you would never know it. I work full time, I exercise, I go to book clubs, I fix up my house just like you and everybody else. However, when I'm off my medicine or on an inadequate dose, I have psychotic delusions and lose insight that I have a serious illness. Then I refuse hospitalization and medicine. When involuntary hospitalization and medicated over objection, within 24 hours, I realize I need the medication. I tell this story because I'm a firm believer that prompt involuntary hospitalization for psychosis is the compassionate thing to do for someone with schizophrenia, not allowing them to remain psychotic until there is a risk of physical danger. I approach this no different than any illness that someone comes to the emergency room for and is unconscious. I might as well be unconscious, for when psychotic, I am living in a reality all made up by my mind. I want my doctor to treat me as such. I want him to facilitate hospitalization where I can receive life-saving medication over objection if needed. I don't know any other illness where someone coming to the emergency room is not referred to the life-saving treatment they need. In short, this is a disease with a biological basis. If a person's cancer was at stage 0, but the doctor waited until the cancer was at stage 4 before treating it, he would be sued for malpractice. But this is what will continue, not treating psychosis until someone is at stage 4 of physical danger to themselves or others. I have waited for this bill for a long time. It seems almost ridiculous. I've spent over 69 days in the hospital, and the fact is I would have been healed after 24 hours. This bill may be a moot point for me because I know my situation and have a notarized letter which my family can submit to a judge asking that I be hospitalized and given medication against my will when I am at stage 0. But I would be devastated if this letter does not do the trick. So I am asking you to pass this bill to protect my civil rights due to my disability to be treated at stage 0 and not stage 4.
Thank you very much for your testimony. Now move to favorable with amendments. Dr. Kashina Cross. Go ahead, Dr. Cross.
Thank you so much, Madam Chair, members of this committee. I'm the Honorable Dr. Kashina Cross, and I serve as a municipal elected official in Prince George's County. I'm also a retired member of the United States Air Force, a veteran who has witnessed many PTSD accounts and even psychosis, which is really affiliated to those that have had direct exposure to really chronic events in wartime. 5 combat war survivor myself, I also am working with residents and families and first responders and community organizations confronting the growing mental health challenges facing our communities following COVID-19. Senate Bill 707, I humbly ask for support with amendments because it does seek to clarify the definition of danger of life and safety for the individuals and others in a framework that involuntary admission and emergency evaluation, and the intent of this clarity is very important. It is clear that the deterioration is not met by narrow interpretation, but the imminent harm. With that invention, the result is a preventative crisis, a criminal justice involvement has a tragic outcome in many occasions for the member that is involved, the person that is experiencing the episode. From a municipal government perspective, it is clear that we need to have an increasing reliance on law enforcement with a default responder behavior health emergencies that is characterized by statutes with clarity and also clinician support and feedback from families placed in position to clearly help define the definition of support. My amendments are for the statute to include a documented clinical justification tied to observable behavior and professional assessment. Second, require timely judicial and independent clinical review following involuntary admission. And third, require data to support the outcome associated with emergency evaluations, as well as diversion from criminal justice systems. I humbly request favorable with these amendments.
Thank you, Dr. Cross. We do not have your amendments. You'd only signed up for oral testimony. So to the extent you have some written amendments that you wanted to provide to the committee, you can send those via email, and we can look those over. So thank you very much for your testimony. We appreciate it. Next, there is one unfavorable. That's Tam Lynn Kelly.
Good evening, members of the Senate Finance Committee. My name is Tamlin Kelly, and I'm here today on behalf of Disability Rights Maryland to express our opposition to Senate Bill 707. Disability Rights Maryland works to ensure that people with disabilities are not subject to abuse or neglect. Many of our clients have been hospitalized against their will. And every day we see the desperate need for effective mental health services that are voluntary, accessible, and trauma-informed. We urge the committee to support strategies that have been proven to improve public health, many of which remain underfunded, and to reject ineffective strategies such as Senate Bill 707. While the intent behind this bill is good, and most of us can agree that it is important to protect both individuals experiencing a mental health crisis and the broader community serious harm, however, expanding the criteria for involuntary hospitalizations is not a proven strategy to achieve these goals. I would like to draw your attention to a recent study by the Federal Reserve Bank of New York and the report entitled "A Danger to Self and Others: Health and Criminal Consequences of Involuntary Hospitalization." This study is particularly relevant to Senate Bill 707 because they studied cases the authors called judgment calls. In other words, they looked at cases where some physicians would commit the person involuntarily and others would not. The study finds that involuntary hospitalization does not achieve the intended effects of preventing the individual from harming themselves or others. Hospitalization actually increases the risk of death by suicide or overdose, and increases the likelihood of being charged with a violent crime among these judgment call cases who are involuntarily hospitalized. It is critical that we focus our limited state resources on interventions that are proven to achieve their intended outcomes. We need increased access to voluntary, community-based care that is trauma-informed. For these reasons, we urge an unfavorable report on 707. Thank you.
Thank you very much for your testimony, and that is all of the testimony that we have today. That ends the bill hearing on Senate Bill 707 and ends our bill hearings for today. Thank you very much for everyone for your time.